Okay, so this should, yeah, you think about that basically. Yeah.
I mean, they voted on the presentations
No. Oh, the laptop, yeah, but it's close on it.
Are you all right, Greg?
Yeah, just sorting out.
Is there a pointer?
There was one on the memo, I got one. I can bring you one, but I'm not added to the
Would you like a pointer or you?
Well, I'm going to run off my own.
Oh, okay. A pointer might be quite nice. Thank you very much. Thank you. How are you, Greg?
Nowadays, I don't get nervous about the talk. I get nervous about all this stuff.
I know, we were just saying that.
Hey, Joe, you're okay.
So we're going to see how Rachel's getting on.
Yeah.
Because we are a bit late, aren't we?
We are.
But we can't really start without Rachel, so I'm going to find out.
Okay. 5 past. No, it's whether you've got video. Yes, if it didn't work, it wouldn't fall flat. Yeah. Good choice.
great. Hushed silence in expectation. So, welcome everybody. Welcome to King's College London, one of the great London institutions, and it's very appropriate that we're here today for a training day in one of the great universities of London and the world. A lot of you will be here for the AICC conference tomorrow as well, and we welcome everybody to both of these events. We haven't always linked a training day with the AICC conference, but I think we all feel that it's the obvious thing to do. And for those of you who've made the effort to travel, I think it does make sense to try and couple the training day with the AICC conference, and we'll try and do that in future years. We've got two parallel sessions today. We've got a session in here in the Great Hall, and we've got a parallel session up in the River Room. The River Room is straight out of these doors and take an immediate left. There's a long corridor, go all the way to the end, and there's a sort of set of back stairs. Go up there, and it's the first room on your right. They're just setting up the audiovisuals there, and that's why we're just running a few minutes late. I think it's important to realise that you don't have to stick to a session, so you just feel free to go to whatever talks you feel are most appropriate, and feel free to sort of migrate between the two sessions as the day goes on. I'm led to believe there are bathrooms straight ahead. We're going to have coffee and lunch in here, I think. Rachel, is that correct? Yes, in here. Fire alarms aren't expected to go off, so that'll be real if it does. And phones, you know what to do with your phones. So thank you to all for all coming. A particular thanks to the speakers and the chairs who've taken the time and effort to prepare for this day. An enormous thanks to Eleanor Wicks and Valerie Honore, who are still on the front desk registering. The amount of work that goes into the membership, the registration, the setting up for this day is enormous, and we're incredibly grateful to them doing all that sort of backroom work. But Rachel Bastianen has organised the day and the conference, and we are all indebted to her for the enormous amount of effort that she's put in. And I think you will find that today's programme and tomorrow's programme is really, really exceptional. And I think we're taking these training days and the conference to sort of a new level. So I think we should start because we are running late. We'll make up that time during the morning, I think, quite easily. So enjoy the day, and we'll see you all later.
Thank you, Stephen. Is this mic working? Yeah? No?
Yep.
Should be, yeah. Okay, so sorry for the slightly delayed start. There were audiovisual problems in the other room, and as Stephen says, both rooms will be running 15 minutes, so if you're moving between the rooms, don't worry, the other room is also on the same time scale as us. So Joe Westerby and I are chairing the first session, which is a session directed towards, I guess, more towards inherited arrhythmia. We've got some fantastic speakers, the first of which is Juliana, which I welcome to the stage to give her talk. Juliana is from, I think, based at Birmingham. She's a specialist nurse, but she's been working as an AICC coordinator, which is a kind of new role to do with the sudden cardiac death pilot study, which has been promoted by BHF and NHS. So I'm delighted to hear from you to give us an update on how it's all going. Thanks, Juliana.
Thank you very much for having me, and thank you to the AICC for inviting me to speak, and thank you for attending today. So my name is Georgiana. I am one of the lead coordinators. I'm coming from the Central and South Genomic Medicine Service Alliance, so that's Birmingham, and I'm also a lead nurse in the AICC service at University Hospitals Birmingham. So perhaps most of you are familiar with the pilot, but for those of you who are not, I just wanted to provide just a quick background about what this pilot essentially entails. So what we're trying to do with this pilot really is to standardize the way that we look after sudden cardiac death and sudden unexpected death cases. We know that our ICC colleagues do a fantastic work to look after these people. However, nationally, we have noticed some inconsistency in the level of care and support that is provided to these families, which has led on many occasions to missed opportunities, particularly when it comes to tissue retention, which we know is a one-time only opportunity, as well as signposting families at risk in a timely manner to ICC services. So a group of stakeholders got together around 2020, and they've designed a pilot which essentially encompasses 3 main areas. That's cardiac pathology, post-mortem genetic testing, and clinical familial evaluation. And the reason why we do this is to try and provide the personalized care to those family members affected by sudden cardiac death. There is a 2-year timeline to the project. We are now in our 2nd year, and we are running off the 7 GMSA alliances. So there is one coordinator like myself in all 7 regions, and in addition to the coordinators, we have representatives from the GMSA itself. Of course, we have the coroner and its officers. We have pathologists and expert pathology, although that's not available in all of the sites, unfortunately. And we have our colleagues in the clinical cardiology, clinical genetics, and of course the GLHs, which support the pilot. This site provides you with a snapshot of our activity up to date. So on your left, you can see the date where we went live. So more or less all of us went live around the beginning of 2022. And if you can cast your eye onto the 4th column, you can see the number of index cases signposted to ICC. So that's 98. Those are 98 deceased patients that have been signposted directly by the coroner into an NHS ICC service. And this number is quite remarkable if you think about the fact that those have been direct referrals, whereas before we used to receive referrals from GPs or other clinicians where they would come months or years after the death. Now we have that link where a coroner can signpost directly into an NHS service. Those 98 index cases have generated 439 at-risk family members. Those are just 1st-degree family members, which we've identified to be at risk. More than half have already been screened in an ICC service, and the remaining are either waiting an appointment, and those haven't been captured here. Some live abroad, but they have been notified of the risk, and a very, very selected few have declined to be screened. So hopefully by the numbers alone, you can see that the pilot is working. And given that we are now in our 2nd year, it's really time for us to think ahead and to plan for the long-term future of this pathway. So a national rollout really remains the aim here, and for this we do need the support of a national infrastructure. We have seen great work coming out of Northwest GMSA, as they've already rolled out to 3 other regions in Liverpool, Blackburn and Blackpool. We've also seen some excellent engagement in the East GMSA, and the coordinators, with help from the BHF, have been very supportive in that they've helped other coroners, which are not part of the pilot but are keen to participate, and we've also accepted their cases and provided the support when needed. Another thing that will help with the future proofing of this pilot is the fact that the ICC service specifications do have a provision for the role of the ICC coordinator, and also a provision which identifies routine specialist cardiac pathology requirements, which will be very helpful. Like any project, there are a few risks which we've identified, and the main one is surrounding funding. So our funding will come to an end in March 2024, and because of that, we've seen very little interest from trusts and from integrated care boards and commissioners to actually pick up the bill and continue to fund this, just because we have this uncertainty. There is also a little bit of a clinical risk in certain areas, in that the patients that we see in this pilot don't fall into a dedicated clinic, so we sort of have to see them on an ad hoc basis or integrate them into an existing ICC service. And then, although I said the ICC service spec will help, unfortunately, these changes won't be implemented before March of 2024, so we are left with a bit of a gap. So what are some of the things that we've been trying to do in the meantime to future-proof this pathway? Well, there's been talks at a national level, so NHS England Genomics Unit is currently working to secure long-term funding. Then we've also had help from CRY, which very kindly have extended the provision for cardiac pathology by another year, so up to March 2025. And we've also had the ICC coordinators, which have been convened to develop business cases, which we are now in a phase of taking back to our own trusts and try and advocate for the creation of this role, which is unique in the sphere of ICC. It's been a little bit difficult just because we're all linked to different trusts, so there's a different structure, different funding streams, different funding, but that's something for us to work between now and end of March. And then because of that, all of the sites are encouraged to engage with their trust and their commissioners to secure that provisional funding. We've had quite a few successes thus far. So as I've mentioned, we have seen a very successful expansion in the Northwest. We've had a very interesting Blackburn case, which was filmed for the Cause of Death documentary on Channel 5. And it essentially followed the family through all the steps of the pathway, and that makes for a very interesting watch. We've had additional engagement in the North London area, and we've also now finalized a centralized database where all the coordinators are able to input their data. And we have trialed the database and the analysis, and the input methodology is working. And of course, last but not least, whole genome sequencing is now available to be offered to families as part of this pilot, which is a new development. I wanted to take just one slide to talk about the role of the ICC coordinator, because this is a new role in the sphere of ICC. And it has been deemed by several key stakeholders as absolutely essential to the long-term implementation of this pathway. So aside from the fact that the coordinator has this overarching view of the pathway and is able to intervene when needed to support our colleagues, what they've been doing is that they've provided a link between the judiciary system, which is the coroner, and the healthcare system, the NHS. And we never really had that communication bridge there before and that relationship. And that is very important because it allows for these direct referrals to come into an NHS service. They've also used their clinical expertise and training to support families on a one-to-one basis, really, and to provide them with that help when it comes to decision-making processes around tissue retention, bereavement support. They've also used their clinical skills to help triage those who may be at risk based on their symptoms, to fast-track them, or to signpost them at other ICC centers around the country if they don't live within our area. And of course, we do work very hard to facilitate genomic counseling and testing at the beginning of the pathway, as opposed to at the end, where we see now in ICC, we might do genetic testing right at the end after a patient has completed their clinical screening. We want to bring that all the way forward and offer it to family right at the beginning. I will now discuss an interim report by Bright Purpose. So this is an external agency which has been appointed to evaluate the pilot. And this is the summary. So this is all very fresh information from September of this year. And essentially what the evaluation was is to inform if a national rollout is feasible, what sort of challenges are we looking at, what are some of the barriers and the critical success factors which we absolutely need to have in place in order to be successful. So perhaps the question on everyone's mind is the pilot working? Are we doing this for a reason? And yes, they have determined that the pilot is absolutely working. They've also determined that many stresses and risks related to the decision-making processes have been relieved because of this pathway. Families are better supported by experts, and they have recognized this huge potential to save multiple lives. They've also identified some challenges, some of which we've been aware of, and across all sectors, you will see most of these are related to increased caseloads and staff shortages. In the pathology department specifically, we are facing a challenge in the sense that specialist cardiac pathology capacity is an issue, and succession planning, because of that, can also be problematic for the pilot. There's also a couple of risks which they've identified. At a pathway level, we do run the risk of missing cases. So we might have cases where a pathologist is doing a post-mortem. It's a pathologist outside of the area of the pilot, so they're not familiar. And this is bound to happen. Some cases will be missed, or some cases may be referred prematurely, which can lead to upset to the family members or to a lot of work that's being done by the colleagues, which ends up not being useful in the end. There's certain delays which can happen, and certain capacity challenges, and the fact that we have been relying on the goodwill of people. We sort of have been squeezing cases in here and there and ask our colleagues to accommodate us. At program level, the main risk they've identified is the funding gap, and this is a real threat. The introduction of the whole genome sequencing is risky in the sense that, not for the benefit that it provides, but that it comes with additional workload. There's a lot of workload for the lab, and also to the AICC coordinators, which now have to go back to all of the eligible cases and reconsent all of those family members. There's also risk when it comes to the capacity. When we think of rollout, a national rollout will generate a lot more referrals, and we have to think of our AICC services, how are they going to cope with that increasing capacity, and making sure that the expansion is not that on an ad hoc basis, but rather controlled and organized. There's 4 critical success factors which they have identified. In no particular order, they are linked to the commitment and the support across the pathway. So they have noticed that people are willing to go the extra mile. They do believe this is the right thing to do. Communication and team working, again, is essential because it builds that gap across stakeholders and bridges. And then we have the role of the AICC coordinator and the senior leadership from the coroner. And that's particularly important because our existing coroners are in a position to advocate with their own colleagues and to show them that the pilot is feasible and encourage them to agree and expand this to our area. And I just wanted to end with our last 12 months KPI. So that's October 2022 to October 23. And hopefully you can see by this chart that the pilot is certainly working. We've seen a very steady and progressive raise in the numbers and a successful expansion to 4 other areas so far. So our focus now really is shifting towards long-term planning and future-proofing of this pathway. Thank you.
Thank you very much for that excellent talk. A very clear explanation of the pathway and also the challenges that it's facing, and also the benefits that it provides for essentially sudden unexplained death victims and their surviving family members. So next we're going to move on to Bode, who is a consultant cardiologist and a cardiac electrophysiologist with expertise in ICC, working at the Queen Elizabeth Hospital in Birmingham. He undertook a clinical and research fellowship in ICC and sports cardiology at St. George's and was also a CRI fellow. He was under the guidance of Elijah Bear there, and we look forward to his updates on Brugada syndrome.
Thanks, Terry. Thanks for the invite to speak. Thank you all for attending. So I actually gave this talk to a group of general cardiologists a few months ago, and kind of that was the take-home message that I wanted to kind of give them at the time. So this is interventional cardiologists probably see 1 case of Brugada in their career. I kind of didn't want to overcomplicate it for them, but now I'm in a company of more learned folk. You know, none of that's actually true. Okay, so that's probably what we're going to focus on for the rest of this talk. So, firstly, the presence of the type 1 pattern is indicative of Brugada syndrome. For the spontaneous group, yeah, that's reasonably true. But for those with a drug-induced type 1 pattern, actually we know now that the presence of the drug-induced type 1 pattern isn't necessarily indicative of Brugada syndrome in the absence of other more relevant clinical details. So look, the yield is high. Across mixed cohorts, you've got survivors of cardiac arrest, sudden cardiac death victims with a yield of between 20 to 40%. That's really high. For a condition that affects 1 in 2,000 of the population, the drug-induced type 1 pattern is readily seen. In addition, this paper by the Turkish group in Kan Hajdemir in Turkey identified the drug-induced type 1 pattern in almost 30% of patients with a benign SVT. So we know that false positives or false positive response to adrenaline is definitely a problem. We looked at this in our own cohort, in our own study, hopefully due to be published soon. So in 100 healthy controls, systematically evaluated for family history, baseline ECG and echocardiography, we saw a 3% of the yield of the drug-induced type 1 pattern. So we know the false positive response to sodium channel provocation does exist. So what does that mean? What's happened? So in light of this, the consensus suggests that, again, if you have a drug-induced type 1 pattern alone, it's not enough to make a diagnosis of Brugada syndrome. So that's where the Shanghai criteria comes in. So over the last few years, and bear in mind, the scores given for the Shanghai criteria are not based on any real-world scientific odds ratio. They are just a consensus. So we know that the vast majority of our patients who are going to have sodium channel provocation are going to be sudden cardiac death relatives. They're not going to fulfill the diagnosis of Brugada syndrome based on the Shanghai criteria. So it's an imperfect score. It's all we have at the moment, but it's an imperfect score. Does it correlate? Well, one large validation study tried to have a look to see if those with the highest Shanghai score actually had risk. And they did find that those with a score of greater than 5.5 had a significantly greater cardiac arrest or sudden cardiac event rate than those with a score of less than 3, so a non-diagnostic score. But you really got to look at the data. You've got to look, they're comparing apples and pears. If you look at group D, you've got to have a score of, an ECG score of greater than 3.5, on average, almost 3.5. So that's the spontaneous group. Actually, the drug-induced group, those with an ECG score of 2, we still don't know. We actually still don't know whether or not it's really validated. We had a look at that in our own group. So in our own cohort of family members of sudden cardiac arrest or sudden cardiac death victims who had subsequently been diagnosed with Brugada syndrome based on the appearance of a drug-induced type 1 pattern, only 22% went on to fulfill the diagnosis of definite or probably definite Brugada syndrome based on this. So it's imperfect. We know that this downgrading of the drug-induced type 1 pattern is going to be very difficult for some of our families who have already been told that they have Brugada syndrome based on the death of their relative or other more relevant clinical information. But the way I kind of interpret it, or the way I use this, is to counsel your patient before you're doing the adrenaline provocation. You know, if you think that they're unlikely to reach the full diagnostic score, discuss that with them. If they're asymptomatic and their ECG is normal, then are you going to be doing them any harm by not giving them an adrenaline? Perhaps not. It's provocative, but it's probably what we should be trying to adopt in our clinical workflow. So that first statement, the presence of the drug-induced or the presence of the type 1 pattern equals Brugada syndrome, I think we can adjust that statement. I think we can say that the presence of the spontaneous type 1 pattern, yes, is indicative of Brugada syndrome. But if you have a drug-induced type 1 pattern, you need to have more relevant clinical details before you can make the diagnosis of Brugada. So what was the next statement? The next statement was Brugada syndrome is a monogenic condition. Again, we know that's not true. So, you know, since the first gene was identified by Chen probably 2 decades ago, the SCN5A gene, a number of other genes, in excess of 20 genes, have been implicated in Brugada syndrome. The vast majority are those found in the SCN5A gene, and in the most recent literature, we know that actually, in a critical appraisal of these other genes, has actually found that they're not really that important, or they can be disputed. Only the SCN5A gene has categorical evidence of involvement in Brugada syndrome. So actually, when you're consenting someone for clinical testing for with a diagnosis of Brugada syndrome, actually the only relevant gene to test for is the SN5A gene. So that's complicated, I suppose, isn't it? So I've said to you that it's a monogenic condition, and we're looking for changes in the SN5A gene, but we know that it's not perfect. We know that this isn't forming or doesn't fit with normal pattern of Mendelian autosomal dominant inheritance. We know that because of incomplete penetration, low disease penetrance. We know we have families with mismatch between genotype and phenotype. We know that there are sporadic cases, and despite advancements in clinical and scientific genomic medicine, we're still as yet unable to find any other specifically categorical disease-causing genes. So we know that it's got a complex pattern of inheritance. So in 2013, the first Brugada GWAS identified that there is a role for common genetic variation here. So in a GWAS of over 1,100 cases of Brugada syndrome, the diagnostic type 1 pattern induced with agmelin or flecainide or a spontaneous pattern versus controls, and replicated in European and Japanese cohorts, the team identified 3 really important SNPs, so 3 really important single nucleotide polymorphisms that increase one's risk of developing Brugada syndrome or having Brugada syndrome. So this is cumulative. So one SNP on its own probably doesn't do much. But when you have a collection or up to 5 or 6 SNPs, we know that your risk of developing Brugada syndrome is 20-fold. So this is important. So we know that there are potentially oligogenic and monogenic factors here that link to your risk of having Brugada syndrome. So we know that's probably the start. And fast forward another decade, Bach has found 21 SNPs. So 21 SNPs implicated in oligogenic pattern of inheritance and linked to the risk of having Brugada syndrome. So we know this is really important. What's even more important, it has a predilection for those who are SCN5A negative. So the majority of the patients that we look after are SCN5A negative. And you can see that there's a shift with genome-wide significance with a p-value of less than 3.5 to 10 to the minus 8. So really significant p-value that highlights that, especially those with a baseline spontaneous type 1 pattern, there is an oligogenic pattern of inheritance which can be predicted by this 21 SNP array. So what does it mean? So genome-wide significance, polygenic risk scores, is still all science, isn't it? It's not really made its way to clinical medicine. And I think that's probably true. But look, this other group had a look to see if checking someone's or knowing someone's polygenic risk before they have agmelin predicts their response to agmelin, and it does. So if your polygenic risk is in the 5th quintile, so if you have the highest polygenic risk, you have the highest chance of developing a type 1 pattern with agmelin. How can it be used? So the authors, or I should say, hypothesize that it can be used in a number of ways. It can be used before you give sodium channel provocation diagnostically, but also if you're exposing someone to drugs that may increase one's risk of developing the type 1 pattern or even arrhythmia, it may be a useful tool. So again, it's still science, but it's important and looking like it could be clinically relevant on the horizon. So I suppose we can change that statement that it's monogenic. We know, I've given you some evidence to suggest it's oligogenic. Definitely there is some monogenic inheritance, but it's probably more likely to be an oligogenic condition. What was the next statement? The next statement was, it's a primary electrical condition without any structural abnormality. So it's kind of a cheat, really, because the original description of Brugada syndrome did actually have some structural changes in those post-mortem. So fibrofatty replacement in these 2 individuals reported by Corrado back in 2001. And you can see that their resting ECGs were very suspicious of the type 1 pattern with progression over time. Again, going forward, Nadamini with the seminal paper in 2015 identified increased levels of fibrosis and collagen in 6 patients who died from sudden cardiac death, who were later found via their family members to have likely to have died from Brugada syndrome, with reduction in connexin 43, which is a really important gap junction protein. So this is really important. This is a really seminal paper. This not only because of the histopathological changes, but also because of the in vivo changes that he identified. So in 6 patients undergoing thoracotomy with a history of Brugada syndrome and ventricular arrhythmia or syncope, he identified that this deposition of fibrosis had a predilection for the RVOT epicardium, and ablation here reduced or terminated the type 1 pattern and drastically reduced their future event rate. Again, really important study. Going on from that, Chris Miles, who's not in the room, but his own work identified a similar finding. So you can see a predilection for collagen in the RVOT, but also in the LV myocardium. So for the first time, we've seen histopathological evidence that there is increased fibrosis in the LV epicardium in patients who subsequently been diagnosed with Brugada syndrome via their family members after they have had a sudden death. So this is really important. This is really, really important on the horizon, but it's histopathological. So how is that clinically relevant for our patients? If you look at imaging studies, we know that patients with Brugada syndrome have increased right ventricular dimensions, so structural abnormalities in the RV, but also fibrosis in the LV mid-wall, more prevalent than healthy controls. Not to the degree that patients with ARVC or arrhythmogenic cardiomyopathy have, but definitely greater than controls. So that histopathological evidence that I gave you does have some clinical clues that potentially we could find and develop. MRI is probably not the modality of choice or the modality that's going to really clinch that diagnosis, because we just can't see fibrosis in the RV. It's just too thin. So that's probably why we're still looking at subtle changes in small groups, not seeing big evidence that this is a structural condition. Again, Belinda Gray's work identified very similar findings with significantly greater index volumes in the RVOT and controls in patients with Brugada syndrome compared to controls. Not to the extent of ARVC, but significantly greater than the controls. And then you look at more focal RVOT regional wall motion abnormalities. So is Brugada a cardiomyopathy? Is it an epicardial cardiomyopathy in some patients? So I think we can kind of agree that I've changed that initial statement that it's a primary electrical disorder to actually, well, it could be in most patients, but in some have subtle structural changes that we're able to see histopathologically, but we may actually be able to detect with advancements in cardiac imaging. So the final statement was that treatment is limited to ICDs, primary or secondary prevention in those with the highest risk. Now, I think it would be remiss of me to try and delve into risk stratification in this 20-minute segment. It remains probably the most challenging aspect of looking after patients with Brugada syndrome. A lot of the risk stratification algorithms that have come out over the last decade are very good at looking at those who are the highest risk: cardiac arrest survivors, patients with spontaneous type 1 pattern and syncope. But that's not the bread and butter. That's not the volume of patients with Brugada syndrome. It's the intermediate group that we still actually don't know how to risk stratify. Those who are asymptomatic at the start with a drug-induced type 1 pattern alone, they still have events. They actually have more events because there's more of them. We're still no further forward, in my view, to try and work out what to do with them. So I'll skip that. Actually, I wanted to focus on ablation in Brugada syndrome. I didn't want to steal John's thunder because he's probably going to go into the techie details. But as an electrophysiologist, again, it would be remiss of me not to mention this because I think it's really important. I refer you back to what I mentioned about Nader Mani's study, where he looked at in vivo epicardial signals and the ablation of those signals and how they dramatically reduced event rates in patients who were at the front, high-risk patients. We know there are a wealth of studies, there are a number of them now, that have shown a dramatic reduction in events in high-risk patients undergoing ablation with Brugada syndrome. And there are a couple of strategies, and I'm sure John will go into the techie details. You can ablate the epicardium, but you can ablate the endocardium, but actually the success is ablating that signal in the epicardium, so on the outer surface of the heart. Again, adding more evidence that this could be a structural abnormality, a structural pathology. I think this is, again, a salute to Nader Mani and his great work in this field. So this is a longitudinal study looking at the outcomes of ablation in patients with Brugada syndrome and cardiac arrest or high malignant events. You know, to get 159 patients internationally into a study like this is no mean feat. This is really, really impressive work. All of these patients had Brugada syndrome, all of them had DFibs. The majority of them had VF, multiple episodes of VF prior to enrollment. A lot of them had syncope as well. And look what ablation does. Look before and look at after. So this is, almost 4 years, 5 years of follow-up after ablation. So this is really, really important stuff on the horizon. So I hope you can kind of appreciate when hopefully John goes into this in more detail, that it's for us as electrophysiologists, it's something we can actually potentially do and change for, yes, a small group of patients, but definitely has a dramatic improvement in their quality of life and shocks from defibrillators. So let's go through those statements again. Presence of a type 1 pattern, spontaneous, yeah, I'm happy to say that's Brugada syndrome. The drug-induced type 1 pattern, I'm a little bit reserved. I'd like to know what the rest of the clinical information, what the indication for the test was. Yeah, it shows a monogenic and potentially oligogenic pattern of inheritance. We're still yet to roll out the clinical utility of polygenic risk scores, but next time there's someone gives an update, I hopefully will be that further forward. Patients with Brugada syndrome have evidence of structural abnormalities, some that we can detect with advancements in imaging, some that can only be seen histopathologically. And those with the highest risk, ablation, ablation, ablation. Thank you.
Thank you for that wonderful update on Brugada syndrome. Very comprehensive, apart from for the risk stratification, which is going to be left for later. Next, we've got Greg Meller, who's a consultant cardiologist and cardiac electrophysiologist working at the Royal Papworth in Cambridge. He's also a previous CRI fellow, previously worked at St. George's, and he treats a range of heart rhythm disorders with a particular interest in inherited arrhythmia syndromes, unexplained cardiac arrest, and arrhythmias in athletes. We're looking forward to his talk on risk stratification in long QT syndrome.
Thank you, Joe. And thank you to the AV team for making sure my laptop connected. It's been a source of stress all morning. So thank you very much for the invitation and opportunity to speak to you today about how to manage risk in long QT syndrome. We're fortunate to have good guideline-directed therapy for long QT syndrome. These statements are taken from the 2022 ESC guideline and are summarised nicely by my assistant here, which we don't have. I've ruined her moment. I'm not sure if the sound is working.
Long QT patients must take beta blockers.
So this is my daughter several years ago. I recorded this for another talk on trainees about how simple it was to manage long QT syndrome. So if you give patients beta blockers, your long QT patients will be safe. And that's in line with our mission statement as AICC cardiologists to prevent sudden cardiac death. But of course, it's not quite as simple as that, because to complete our mission statement, we want to prevent sudden cardiac death, but with a minimal negative impact on our patients' quality of life. We have to remember that many of the ICCs, and long QT included, has very little day-to-day morbidity, and the morbidity that is experienced is generally due to side effects from medication or iatrogenic complications. Core to risk stratification is shared decision-making, and there's three components to that regarding long QT syndrome. First is the objective risk calculation, and we'll go into how we as physicians and specialists may do that. At the other end of the spectrum, there is the patient's risk perception. Again, we'll touch on how different patients perceive different risks. And the bridge between these two is the risk communication. So to touch on risk communication, I've just got one slide, and essentially this is to show that it's very difficult. I don't know how better to do it, but I don't think we're doing it very well. This is a statement from a paper which we'll reference again later on about outcomes from long QT from the Mayo Clinic. So it says that 2% of previously asymptomatic patients treated at the Mayo experienced an arrhythmic event over a follow-up of 6.7 years. So my question is, what is the annualized rate of events for these patients based on that statement? Is it 1 in 3,816, 1 in 335, 1 in 55,000, 1 in 47 million? Now, I won't ask for a show of hands, but I think this is here to highlight that it's not an easy calculation. It's 1 in 335, and you get that by dividing 0.02% by 6.7 years. But I don't think that's intuitive, and I think for a layperson, particularly sat in a room where someone's talking about the risk of them dying, that's very difficult to appreciate. Of note, these are what the other ratios are. So 1 in 3,800 goals in the Premier League are scored by goalkeepers. 1 in 55,000 is the annual rate of sudden unexplained death in young adults in the UK. And 1 in 47 million is the chance of winning the National Lottery at the weekend. Moving on to risk perception, this book by Michael Blasland and David Spiegelhalter, 2 statisticians, talks through how to analyse and appreciate risk in a wide range of contexts. And they do that through 3 characters: Norm, Prudence, and Kelvin. Norm sits in the middle and tends to weigh up risks. Prudence is very risk-averse, and Kelvin is happy-go-lucky, shall we say. So this is a scenario from that book. The 3 people come across an unattended bag left in a train station. Norm weighs up the risks, decides it's most likely to have just been left behind by another passenger, and carries on his day. Prudence freaks out, insists the station is put on high alert, and is convinced it's going to be a bomb. Kelvin walks up to the bag and steals the laptop. Now, if we imagine that Norm, Prudence, and Kelvin are diagnosed with long QT syndrome, Norm may weigh up those risks, have a conversation, and decide he'll be okay if he takes his Nadolol. Prudence panics and insists on having a defibrillator before she leaves the room, and Kelvin shrugs his shoulders and goes for a swim. We've all met these people, and when we have these conversations, it's important to try and work out who you're talking to. These images are borrowed from an excellent blog post by Alexandra Freeman, who runs a risk stratification unit in Cambridge. So imagine now that risk is perceived as colour. Many people use these scales much better or more effectively than numbers. So let's imagine that dark purple is higher risk and light purple is lower risk. So you'd probably say, therefore, that the pink person has a higher risk than the blue person because they have a darker purple heart. But of course, this is an optical illusion, and those 2 purple hearts are exactly the same colour. It's when put in the context of the patient that they're in that you appreciate the differences. So these things are all worth thinking about. But we'll move on to the kind of more safer ground, I guess, now, of the objective risk calculation. So the first message is that the overall risk of long QT syndrome is low. So again, this is data from that Mayo Clinic paper already referred to. So if you look at all comers in that large registry, the outcomes are very, very good. If you compare this data to the more historical long QT cohorts, we also see that the prognosis is improving. Maybe we should all pat ourselves on the back and say we're doing a very, very good job with our medical treatment. Probably we're actually identifying more and more low-risk cases through strategies such as family screening. The symptomatic presentation, or symptomatic status at presentation, is extremely important. Those who present with prior symptoms are much more likely to go on to have a further event compared to those who present without symptoms. Genotype is also important. There are 3 main genetic subtypes of long QT, and type 1 is lower risk than type 2, and then rarer, long QT3 has the highest risk. LQTM on this Kaplan-Meier curve is those with multiple variants in multiple genes, and they have the highest risk. As well as genotype, the actual degree of QT prolongation on the ECG is important. This is data taken from a large Italian registry. We can see moving from right to left across the top of the screen, the risk goes up from long QT 1 to 2 to 3, and then moving from the top to the bottom of the screen, the longer your QT measurements are at rest, the higher the risk. This is exactly the same data shown in a different format. This is to highlight that the vast majority of our patients sit in that green section of the triangle at the bottom. So all genotypes with mild QT prolongation have a very low risk. So this is a 5-year risk off therapy of 1% or less. The same group have then moved to try and formalize these risk calculations into, or risk factors into a calculator. So they call this the 123 LQTS model. It's available as an online calculator, and it's referred to in the latest ESC guidelines. So it does predict events well, and then the authors went on to look at which risk threshold should be used for implanting an ICD. So on the right-hand side of the screen, we have these coloured bars. Blue bars would be patients who receive an ICD but never have therapy, so potentially an unnecessary treatment. The yellow patients are those who have an ICD and have a shock. Red are those who do not have an ICD and have an event. And the green patients who have neither an ICD or an event. And you can see as your threshold comes down, you implant more ICDs and prevent a small number of clinical events. As I said, the author suggests a 5-year risk of 5%, so 1% annual risk, not too dissimilar to what we talk about in other conditions such as hypertrophic cardiomyopathy. The calculation looks impressive, but when you delve into it, it's actually relatively straightforward. So the higher this prognostic index, the higher the risk for patients. The prognostic index is derived from the QT, so anything over 470 milliseconds, your risk starts to go up. And then you have a simple multiplier, depending if you've got long QT or long QT3, that increases that baseline risk. So we're still just looking at 2 variables. And the authors themselves state in the limitations of the study that there may be other variables which are of prognostic importance. And in fact, a prior model has included many more variables. I'm sure we can all think of clinical variables that may be important for risk, such as the patient's age, sex, their symptom status, as we've already mentioned, maybe their ethnic background. The majority of patients were white European heritage in these studies, whether they exercise or not, whether they take other medications or comorbidities. I think we're a long way off having any kind of model that incorporates all of these risk factors. Nevertheless, the European Society of Cardiology incorporated this paper into their guidelines, despite it being published just in the same year the guidelines were released. So if you have a high LQ2S 123 score, it's a class 2B to have a primary prevention ICD. We know, as well as risk, there is a phenotype-genotype correlation across the different subtypes of long QT syndrome, both in terms of their ECG morphologies and also the triggers for arrhythmic events. This is the data from Peter Schwartz's original paper back in 2001 that shows those patients with long QT1 are much more likely to have their clinical events triggered by exercise, whereas long QT2 is with sudden arousal or emotion, the classic alarm clock going off. And long QT3 patients are more likely to have an event during sleep. Within LQT1, it seems that swimming is the particularly highest risk activity. We think this is due to QT prolongation at higher heart rates during exercise, with altered autonomic balance caused by intermittent breath holding and maybe temperature changes, leading to an increase in triggering ectopy, which causes the VF event. This is a recording from one of our patients at Papworth. This is from a loop recorder put in because she had a slightly vagal sounding episode. She was 18 at the time. She was working in France. She decided, well, she wasn't very good at taking her beta blockers, and she decided to try and outswim her friend underwater. And so you can see on the top row here, if this pointer works, we have sinus rhythm with some ventricular ectopics, then degenerating into polymorphic ventricular tachycardia. The ILR suspends recording to save its battery for 48 seconds. And when it wakes up again, she's still in polymorphic VT, organizes into this ventricular flutter, and then miraculously self-terminates and returns to sinus rhythm. It was at this point that Bethany was pulled out of the swimming pool by her friends. She survived. She's now much better at taking her beta blockers, and she doesn't swim. So we do talk about restricting exercise for our patients, but actually the evidence that exercise for the vast majority of patients is detrimental is not that strong. I won't go through these two bits of data in a lot of detail, but they are from a paper and an accompanying editorial demonstrating how it is safe for patients with long QT syndrome to return to competitive sport. And the title of the editorial, I think, is important, that we are trying to not only prolong the life of these patients, but allow them to live a happy and fulfilled life. And for many people, sports and exercise is part of that. So how do we minimize the risk for patients otherwise? We start with lifestyle advice. We talked about QT prolonging medications. The Credible Meds website, formerly known as qtdrugs.org, is a very good and reputable resource. Their smartphone app is very easy to use, and I recommend all of our patients download this. We talk about managing electrolyte disturbance, so during diarrhea and vomiting and overheating. And we talk about how to safely exercise rather than precluding exercise. Medical therapy, as we've already heard, beta blockers are the cornerstone of medical therapy and are very effective. So particularly the non-selective beta blockers, nadolol and propranolol, vastly reduce the risk of clinical events in long QT syndrome. They have best benefit in long QT1 and 2, less so in long QT3, where data to support mexiletine, a sodium channel blocker, is quite encouraging. It's worth remembering, however, that people do not take their beta blockers. So this study from New Zealand showed that half of patients did not take their beta blockers 80% of the time or more. So most of your patients are missing at least one dose a week. Beta blockers alone are satisfactory for the vast majority of long QT patients, but there are some with higher risk or who have breakthrough events on beta blockers who may require additional therapy. Excuse me. One of those therapies is left cervical sympathectomy. So this is a surgical procedure to cut the sympathetic chain and denervate the heart. It's indicated for breakthrough events despite beta blockers, for those who are truly intolerant of beta blockers and who do not have a low risk, or for somebody who's received an ICD and is having shocks. The side effects are common but tend to be well tolerated, and most patients from registry data who've had sympathectomies, even if they've experienced a side effect, would have it again. ICDs do play a role in long QT, but thankfully the vast majority of our patients don't require an ICD. This is the flowchart again from the 2022 ESC guidance, showing 3 groups of patients who need or may need ICDs. Firstly, there's a class 1 indication for patients presenting with a previous cardiac arrest. Secondly, a 2A, so slightly less strong recommendation for patients who have breakthrough clinical events despite good medical therapy. And finally, that class 2B, so should be considered for those who with a high baseline risk despite any other symptoms. At the other end of the spectrum, it is possible to not treat our patients at all, as in not to prescribe them medical therapy. This data again comes from the Mayo Clinic, where they looked at those patients with the lowest risk profile and after discussing with the patients decided not to embark on beta blocker therapy at all. So these patients, which comprised nearly 10% of their cohort, were all asymptomatic. They tended to be older at the time of diagnosis and all had very mild QT prolongation. And in that highly selected group, there were no clinical events over a 7.5-year follow-up. And the patients reported improved quality of life compared to those on beta blockers, mediated through the absence of beta blocker-related side effects. So maybe it's time to have a slightly more grown-up approach to long QT syndrome. And apologies, the sound probably didn't project very well again, but this is my daughter several years on saying that beta blockers remain the cornerstone of treatment, but risk stratification is essential to identify those who need additional treatments or perhaps no treatment at all. Thank you very much.
Thank you very much, Greg. Fantastic talk. Our last and final talk in this session, and we're going to do the panel discussion where the speakers will come up and we can take some questions. So the last talk is by Dr. John Whitaker. I'm delighted. You may have heard that the Brompton and St Thomas's have merged, so he's now my colleague. Wonderful to say. So he's going to talk us through catheter ablation for some of the ICCs. Thank you, John.
Thank you very much for the introduction, and good morning, everyone. Thank you for the opportunity to talk here today about catheter ablation for arrhythmia conditions in the ICC population. My name is John Whitaker, and as I've said, I'm a electrophysiologist working at St Thomas's and King's College London. So what I'd like to speak about today is the conditions that we might think about considering catheter ablation in. And an overall theme that I'll focus on is that when considering an interventional approach to an arrhythmia in the ICC population, the arrhythmia itself that we're treating and the underlying substrate for that arrhythmia are the critical considerations that are going to inform when we might propose to undertake an ablation procedure and our likely chance of successfully suppressing that arrhythmia. So with that in mind, I'd like to talk first of all about atrial fibrillation and then speak about ventricular arrhythmias and think about ventricular arrhythmias that we commonly encounter in some of the common ICC conditions that we're familiar with. So as many of you are aware, in the broader or the non-ICC population, atrial fibrillation is by far and away the most common arrhythmia that we encounter. And in addition, it's the most common arrhythmia that we attempt to treat or suppress with catheter ablation. Catheter ablation is an interventional procedure that's undertaken with the goal of trying to restore and then maintain sinus rhythm in the medium term. There are a whole range of different tools and techniques that can be used to try to achieve this, but the cornerstone of any ablation strategy for atrial fibrillation is to attempt to electrically isolate the pulmonary veins from the body of the left atrium. And the reason for that is that the majority of triggers for the majority of episodes of AF in the majority of patients come from the pulmonary veins. And so if a strategy can be undertaken to prevent those triggers reaching the left atrium, then one can effectively suppress the episodes of AF. Again, outside of the ICC population, I think we increasingly recognize that earlier treatment for atrial fibrillation is associated with better outcomes. And this is a consideration that's very relevant to the ICC population as well. It's also increasingly recognized that for the patients with reduced LV systolic function and symptomatic heart failure, atrial fibrillation ablation that successfully restores sinus rhythm is associated with a mortality benefit. And this is of particular importance to the group of DCM patients, for instance, who present with atrial fibrillation, and there's a conundrum about what the best strategy for their management is. And this is one study which demonstrated that and really gave some motivation to us to more aggressively pursue sinus rhythm in that group of patients with reduced LV systolic function. In the group of patients with paroxysmal atrial fibrillation, there's a broad range of indications for considering an interventional approach, and this can be used as a first-line therapy. And this is, again, a consideration that's highly relevant to the ICC population as well. Perhaps the strongest mandate, as I said, for considering an interventional procedure for atrial fibrillation is amongst patients who have reduced LV systolic function. And in those patients in whom their LV systolic dysfunction is thought to be contributed to by the tachycardia, then it's something that should be considered early, and there should be almost a good reason not to pursue it. There's a growing sense that LV systolic dysfunction that occurs in the context of AF should be contributed to by the AF until proven otherwise. So I think all of those considerations, whilst the data and the guidelines specifically refer to the non-ICC population, are equally as relevant to the patients with ICC conditions. I think it's perhaps appropriate to specifically refer to hypertrophic cardiomyopathy because this has been a controversial topic. And the reason for that is that catheter ablation for atrial fibrillation in persistent AF was not commissioned by NHS England. And the reason for that is that data does indicate that HCM patients who undergo catheter ablation for AF have less positive outcomes than those who have atrial fibrillation outside of the context of HCM. Furthermore, it's associated with a higher risk of complications. Now, the reasons for this probably relate to changes in the substrate that we encounter in AF in hypertrophic cardiomyopathy, in that they tend to have thicker atrial tissue, which is more difficult to effectively ablate with current technologies. They also have a higher prevalence of atrial fibrosis, which means that their substrate for AF is more complicated and often extensive than in other groups of patients with atrial fibrillation. And in addition, the procoagulant state that we know exists in these patients means there's a higher incidence of thrombotic complications as well. But acknowledging that it's more technically challenging and potentially associated with an increased risk profile, I think it's also important to mention that this is a group of patients who actually stand to gain the most from sinus rhythm. With their reduced ventricular relaxation or increased ventricular stiffness, there are patients who often tolerate loss of that atrial function much less well than equivalent groups. And so if one can achieve sinus rhythm in the HCM population, they're, as well as being the most difficult to achieve it, often also stand to gain the most. So I think with that in mind, it's really important that this conversation about the merits of interventional procedures in the context of HCM actually remains open. But as with the commissioning consideration in mind, as well as the other considerations about timing of intervention in AF, I think consideration of an early interventional strategy when the disease is in its paroxysmal form is of particular importance in HCM and indeed perhaps the other inherited conditions as well. So what's actually done during an AF ablation procedure? Well, many of you will know. These are typically done as day cases now. Vascular access is achieved typically through the femoral veins. Catheters are passed back to the right atrium. The left atrium is accessed via a transeptal puncture, and then a variety of tools are used to delineate the left atrial anatomy. And so what we're seeing here is a slightly accelerated video of a catheter poking around in the left atrium to identify the pulmonary vein ostia as well as the body of the left atrium. And what this would then allow one to do would be to apply energy in some form or another. What we're seeing here is radiofrequency energy to actually create that ring of scar tissue that would then electrically separate the body of the left atrium from the pulmonary veins. As I say, there's a whole range of strategies one can use to do this, but this would be the overall approach that's taken in all AF ablation procedures. So just to summarize atrial fibrillation before we move on to ventricular arrhythmias, this is a condition that is important to treat early in the disease condition. When it's associated with LV systolic dysfunction, which is something we encounter frequently in particular cohorts in the inherited cardiac conditions, then an aggressive approach to sinus rhythm is mandated, to trying to maintain sinus rhythm is mandated, and delivering that treatment as early as possible in the disease process will improve outcomes. So moving on to catheter ablation for ventricular arrhythmias. First of all, I'd like to think about the indications that we use for considering an interventional procedure. And broadly, these are the same for patients with inherited cardiac conditions as they are for patients without inherited cardiac conditions. So anyone who has symptomatic ventricular arrhythmias, so episodes of VT or PVCs that occur that give them symptoms and that are not suppressed with medical therapy, are reasonable situations to consider an interventional approach in. If patients have a high burden of PVCs, we all know this can result in a reduction in their LV systolic function. And in a similar parallel to the situation we encounter in AF, suppression of PVCs that are associated with LV systolic dysfunction is a very strong motivation to try as aggressively as we can to suppress those PVCs. And catheter ablation is going to be the most effective way of achieving that in the vast majority of patients. Those patients who are receiving recurrent ICD therapies, whether it's ATP or shocks, are of course candidates for consideration of the most effective strategy to suppress the ventricular arrhythmias that require them to have those therapies, and catheter ablation is often among the more effective strategies that we have. The majority of ventricular arrhythmias that we encounter occur because of changes in the substrate of the ventricle. And what the substrate for ventricular arrhythmias is, typically is viable myocytes that exist in and around areas of fibrosis within the heart. And those viable myocytes, because of their proximity to the fibrosis and because of changes in their functional qualities as well, have different excitability, conduction and refractory properties to other pieces of myocardium. And those changes allow them to overcome some of the intrinsic defenses that the myocardium has that prevents arrhythmias under normal circumstances. And this paradigm for the substrate for ventricular arrhythmias is broadly applicable to almost all conditions that we treat when we undertake a catheter ablation. And the specific disease process that this occurs in the context of is what informs the distribution and extent and complexity of that fibrosis. But that's the fundamental process that is predisposing to ventricular arrhythmias across the spectrum. And what we're trying to do when we undertake a catheter ablation is identify that substrate that supports recurrent ventricular arrhythmias or sustained ventricular arrhythmias, and then destroy it through the application of energy in one form or another. So thinking first about dilated cardiomyopathy, this is a condition in which that fibrotic process typically preferentially affects the subepicardial space in the heart. And what that means is it means in order to effectively identify and then treat that substrate, one needs to very often acquire epicardial access. Now, that means that there's an additional layer of complexity and also an increased risk profile associated with a catheter ablation for ventricular arrhythmias in the DCM population. Previous data has indicated that around a third of patients having a VT ablation for DCM would require epicardial access. But in fact, there are some electrophysiologists who'd argue that actually epicardial access should be considered upfront in all patients undergoing an ablation for VT in the context of DCM. A sort of middle-of-the-ground pragmatic approach is to try to identify that using high-quality CMR imaging and actually focus your access based on where your imaging identifies that substrate to be. Regardless, I think it's important to acknowledge that a catheter ablation for DCM, or for VT in the context of DCM, is more commonly going to require these complex and higher risk strategies to actually access the substrate. And unfortunately, catheter ablations for VT in the context of DCM are associated with less positive outcomes than, for instance, a matched group of ischemic VT patients. And the reason for that is probably the extent as well as location and complexity of that substrate. We know that the patterns of fibrosis we see in DCM are markedly different from that which we see in ischemic cardiomyopathy, and that makes both identification as well as treatment of it somewhat more difficult. So to try to give a flavour of why that might be, I've put an image up from a recent patient who we treated. What we're looking at is an endocardial shell of the left ventricle, whereby red indicates reduced voltage. So that's one marker we use to identify this fibrotic substrate for VT, and purple represents healthy tissue. And I hope you can appreciate there's this huge endocardial scar. And this was a patient with an ejection fraction of around 5% who came in with VT storm. And so in order to try to control his arrhythmia, we did take him to the lab, and he actually required a 6-hour-long procedure with endocardial and epicardial access and an attempt to sort of really try to target all of that substrate. So as you can appreciate, technically that was demanding, and the physiologic burden on someone who clearly had not very much physiologic reserve from the outset was something that really needs to be borne in mind when you're counselling patients about the indication for an ablation in such a circumstance. Despite those technical difficulties, often catheter ablation is the only tool we have left to try to control these arrhythmias, and acknowledging the less than optimal outcomes for such a strategy in this group, in those patients who cannot control their VT with other strategies, catheter ablation does receive a recommendation as a treatment for these VTs. Moving on to arrhythmogenic cardiomyopathy now. This is a condition which seems to respond actually much more favorably to ablation. And it's important to acknowledge that most of the data in the EP literature comes from the right ventricular dominant form of the disease. But in that cohort of patients, there are actually very positive and encouraging long-term outcomes. So actually up to 3/4 of patients who undergo a catheter ablation for VT in the context of ARVC remain VT-free at 5 years. And this is, even those who do have recurrence have a significantly reduced burden. Important considerations about the substrate in this group and the arrhythmias it gives rise to. The vast majority patients experience sustained monomorphic VT. This is exquisitely sensitive to ATP, but it also means that the clinical VTs that the patients are experiencing can often actually be very clearly defined, such that one can be confident that you're actually targeting the substrates that's relevant in that patient. As with DCM, an important consideration when you are planning an ablation procedure is that this substrate preferentially affects the epicardial surface. So what we're looking at here is we're looking at 2 images, and on the left there, an endocardial right ventricular surface, which we can see a little bit of red, but mainly purple, and then the epicardial surface, which is almost exclusively red. So what that means is it means that a technical consideration is if you want to access a substrate in ARVC, you do need to plan for an epicardial procedure right from the start. And again, this has very important implications for patient counselling when you're characterising the risk profile for a procedure that they're undertaking. And there is a group of patients for whom the possibility of an epicardial ablation pushes the risk of a procedure out of their comfort zone. They're actually prepared to tolerate even ICD therapies rather than take the risks associated with an epicardial procedure. But because of the success of the procedure that we see, the positive outcomes, actually catheter ablation for patients with ARVC who are experiencing sustained symptomatic episodes of ventricular arrhythmia does receive a recommendation if they're not controlled effectively with beta blockers, so effectively prior to introduction of an antiarrhythmic medication. Returning now to hypertrophic cardiomyopathy, but now from the ventricular arrhythmia side of things, unfortunately, catheter ablation in this cohort is associated with less positive outcomes than even the other non-ischemic cardiomyopathies. And the reason for this seems to be not dissimilar from the atrial situation, but the presence of deep mid-myocardial substrate, which perhaps many of us are familiar from seeing on cardiac MRI. Fibrosis that's buried deep within a hypertrophied ventricle is extremely difficult technically to deliver ablation therapy to. We know from preclinical and clinical data that using current technologies, our ability to create a lesion or to deliver ablative therapy from the endocardial or epicardial surface beyond about 1 centimetre in depth is very, very difficult. So even if we can identify where that substrate is, actually delivering energy that penetrates that substrate and effectively eradicates it is extremely difficult. Despite those considerations and the less than ideal outcomes in this group, again, there's a cohort who come in whom there are no other options to try to control refractory ventricular arrhythmias. And in that cohort, consideration of an attempt at an ablative approach is mandated in the guidelines. Typically, this is a group who people do reach for novel or experimental treatments to try to access and target that mid-myocardial substrate. But again, that's associated with an increased complexity and often risk profile associated with this procedure. But it's a critical consideration when you're counselling patients about what benefit they may derive from a catheter ablation procedure. And when those patients do reach the point that you need to have that discussion, then as detailed a knowledge of the location of that substrate from imaging is an absolutely critical part of your assessment, so you can counsel your patients as to whether or not you feel you're likely to be able to target that effectively. So we've had a wonderful talk about Brugada syndrome already, and to very briefly allude to this, as we understand, it was previously thought to be an electrical disease. That doesn't seem to be the case. There's this fibrotic change which has been demonstrated on pathology, and also in electrophysiological perspective, which is characterized by electrical signals that are not dissimilar to those we see when we're assessing the substrate in other conditions. And they seem to be localized to the epicardial aspect of the RV outflow tract. And as we've heard, actually targeting the substrate that we see from an electrophysiologic point of view in that region can be extremely effective in suppressing recurrent ventricular arrhythmias and can also lead to normalization of the ECG. So when we're thinking about trying to control refractory arrhythmias in this group of patients, for instance, or specifically rather in the group in whom those arrhythmias are occurring despite the use of quinidine, then this can be a very effective treatment. But as with some of the other conditions we've talked about, this is a procedure that's going to require upfront epicardial access, and that is associated with a risk profile, and that's a critical part of the counselling for the patients involved in that decision-making process. So, idiopathic ventricular fibrillation. This is diagnosed in patients who have recurrent episodes of ventricular fibrillation in the absence of any electrical or structural abnormality. So these are patients that are resuscitated from sudden cardiac death. Actually is associated with a relatively high annualized shock rate, so therapies from their ICDs for recurrent ventricular fibrillation. Now, in a proportion of these patients, one can identify a monomorphic triggering PVC. So a PVC arising from a characteristic location that precedes the episodes of polymorphic VT and ventricular fibrillation. And in those cases, actually targeting an ablation of the PVC can very effectively suppress the recurrent episodes of VF. Those PVCs typically arise from the Purkinje system, but they can arise from other sites as well. And I've just shared an example here of a patient of ours who's a sudden cardiac arrest survivor who came back to us with recurrent shocks from his ICD that were the result of a very rapid VT that actually coming from the RV outflow tract, degenerating into VF. And again, that was represented a very satisfactory target for ablation to then reduce the trigger for those episodes of VF. This is a group of patients who, if you can identify that trigger effectively, do very well and significantly reduce their recurrence of ICD shocks. So, in summary, atrial fibrillation, specifically AF, should be treated aggressively in those patients who have impaired systolic function, and outcomes are much better earlier in the disease process. The outcomes for catheter ablation of ventricular arrhythmias is heavily dependent on the underlying substrate and the condition that's given rise to it. The ablation strategy that's selected, and therefore the risks that go with an ablation strategy, vary significantly by disease and reflect the location and extent as well as complexity of the substrate that's responsible for those arrhythmias. Outcomes are generally better for ablation in arrhythmogenic cardiomyopathy, or at least the ARVC form of that disease, Brugada syndrome, and idiopathic ventricular fibrillation, whilst the DCM and the HCM group unfortunately have less positive outcomes, but it is still sometimes a helpful adjunct alongside other management. Thank you very much. I'll stop there and leave you.
To thank John and everyone else. They were 4 spectacular talks, weren't they, outlining and bringing us all up to date with the state of the art. I'd like to ask all the speakers to come up. Then perhaps we can take some questions from the audience. We've caught up some time, amazingly. I don't know how we managed to do that. I'd like to thank all the speakers for keeping to time. I've got a question for you, John. That was such an exciting talk. Ablation really is spectacularly better in ARVC than it used to be, isn't it? Is there any situation now where you would feel, if you were faced with a young person, where ICDs can cause a lifetime of problem, that you could offer ablation and delay putting in that ICD? Is there a situation where you might even consider that now?
So thank you. That's a very, very interesting question. I think there's a lot of interest in whether we will get to that point. I think if someone is having recurrent VT, my own personal perspective would be that one couldn't, even in the context of an apparently entirely successful catheter ablation, consider that disease process to have been cured. And I suppose the reason being that we know there's progression of the substrate, and I think that as we also increasingly understand, although the predominant substrate seems to be located in the right ventricle, there probably are changes even in patients who have a classical ARVC form that actually exists in other areas. So personally, I wouldn't. I can't think of a situation where I would be comfortable with that, but I'd be very interested to hear others' perspectives on that as well, because I think there's a lot of interest in it.
Yes, I think around the world there are a few people advocating this, aren't they? Bodhi, what's your take?
I echo John's sentiment. I think you'd be quite brave. I think you could consider possibly, if you are confident you've replaced the substrate, an SICD to avoid some of the long-term risks from transvenous ICDs, longer life, just program it as a VF shot box for those critical kind of situations. But I would be quite uncomfortable if the patient already had a documented ventricular arrhythmia to rely alone on ablation.
Even in the circumstance where they're non-syncopal, tolerated it well, young person, 16-year-old, still going to put that ICD in?
I think if they're non-syncopal, I probably wouldn't.
Okay. John, non-syncopal, Bodhi's not going to put one in.
I think you have to have it's part of the disease process. So non-syncopal VT that can be managed medically or with ablation, I would have to counsel them.
Yeah, it's difficult, isn't it?
There was a report in Europace, I think, that we're referencing, and I think it's a provocative idea, and I think there is a group of patients with ARVC who don't reach criteria that we would accept as needing a device, and there's a group who decline a device, of course, as well. And so we have some information about it, but I don't think the data that we have supports ablation as the route to getting there. I think it's probably to do with different phenotypes of the condition that are malignant versus otherwise. I don't think one would think, oh, well, I've got rid of that with an ablation. And I think that would be one of the criticisms I would have of that paper, is that they probably selected a much more benign group than other cohorts. And yes, they did an ablation, but probably or at least it's conceivable the outcomes would have been the same with or without the ablation.
There's a question there. I don't know what we're doing with. We've got a roving mic. Okay. Is that me? Oh, thank you very much. It's at the back.
Hello, I'm Ellie. I'm a genetic counsellor at the Brompton. I'm still trying to understand Brugada syndrome better. So my questions
I think we all are.
Yeah, my question's for Bodhi. If I've understood your talk correctly, am I correct that if you do an Ajmaline test, you can get some false positives?
Correct, yeah.
So do you still feel that there's a role for using Ajmaline when screening relatives?
Yeah, so it depends what you're screening. If you're screening a relative of someone that's got a definite type 1 pattern in their family, then they would score enough for that positive response to be definitive and probably Brugada syndrome. All other circumstances, if you're screening a family member, all other circumstances will probably lead to them having less than definite diagnosis. So if they're asymptomatic, and if they have a family member that's died suddenly from autopsy negative sudden death, and they have a type 1 pattern, then they would not necessarily fulfill the diagnostic criteria. I think one important role is the utility of potentially 24-hour, 12-lead, high-lead ECGs to see if over that time course during follow-up you see the spontaneous pattern on its own. And I'm not sure if Chiara Scrocco is in the room, but she's recently submitted a manuscript that actually looks at the positive utility of ambulatory ECGs in that group. So there are percentages of patients that you do an Ajmaline on at presentation who have a normal resting ECG who later go on to have a spontaneous type 1, adding weight to the diagnosis. But you're correct, it's probabilistic. So it's been downgraded from diagnostic to probabilistic.
Thank you.
So this is a very important thing, isn't it?
For our patients,
because yes,
Yeah, it is.
and a lot of patients who shouldn't be ours. So I mean, one of the things I deal with the whole time is my EP colleagues and other cardiologists sending in a patient with palpitations who's got a funny looking ECG.
Yeah.
Can you do an Ajmaline test to exclude Brugada?
Yeah.
So how do you manage that, Bodhi?
Yeah, so I think that's probably the majority of patients that have a diagnosis of Brugada syndrome, isn't it?
Yeah.
It's funny that patients with Brugada syndrome have a predilection for chest pain because that's the first time they have an ECG. So that's the first time the ECG of incomplete right bundle blanche bulk pattern with J-point elevation is picked up. And that can be a benign phenotype. So you can find papers that look at the degree of the R prime. But if someone has a sharp R prime and J-point elevation, that is in keeping with normal physiology. But unfortunately, that ECG pattern, for whatever reason, has been labelled as looking like a type 2 pattern, even though some of us in the room will probably say we can tell the difference. To the untrained eye, there is no difference. So you're completely correct. A lot of patients that have been labelled as having Brugada syndrome because of some non-specific symptoms have then gone on to have an Ajmaline. So how do I approach it? I think, firstly, it's really important to look at the resting ECG and look at the R prime, determine whether you think this is a benign-looking R prime, sharp R prime, or a broad R prime. Take a thorough family history and speak to the patient and tell them, look, your ECG may well be abnormal. You have no family history of sudden death. You have no blackouts. If you were to have this diagnosis of Brugada syndrome, or probably Brugada syndrome, it will have a psychological impact to you. There's no treatment. If you look at the risk stratification, which as I said, I wasn't going to delve into, they could potentially be on the low-risk group for want of a better phrase, and there are no real medical or interventional treatment other than lifestyle. Perhaps they would decide, you know what, I'll leave it.
The trouble is you get Prudence who comes in, and once she's been told, oh, you might have Brugada, you're going to see the AICC specialist, it's very hard to get it back in the box, isn't it?
Yeah, it's really hard.
So I fight very hard not to do Ajmaline.
Yeah, yeah, I agree. It's a kind of almost a 180 shift, isn't it, from how we were thinking about Ajmaline maybe a decade or so ago, since there has been a paper where they found 30% of patients with just a simple SVT having drug-induced type 1 pattern. So I think the studies suggest that if you have an Ajmaline for the right reasons, 90+% of the time it's going to be the correct diagnosis. But if you have Ajmaline for the wrong reasons, there's a chance you could have an incorrect diagnosis, which is impactful to your psychological life, but not necessarily impactful to you clinically.
So Ajmaline for relatives of sudden cardiac death.
Yeah, because I think the consensus document is just that, isn't it? Yeah. It's not based on any real-world odds ratios.
I think we've got a question from the audience.
Hi,
Thanks, Bodhi. I'm just going to ask an additional question on top of that. How do you deal with the families who've come along and they've had a parent who's had a positive response to Ajmaline, and they're all quietly waiting for their children to be old enough to have an Ajmaline to know if they've got the Brugada syndrome? Because Brugada syndrome is not one thing.
Yeah.
How are you approaching those families now with this? Yeah, we were going to do your Ajmaline.
Yeah.
And on the back of that, for kids that would have had Ajmalines maybe
Yeah.
at 8 or 9 years old, and now
Yeah.
we're pushing it back to maybe 15 or 16, are you redoing anyone?
Yeah, no, I think what I do is I educate them and say, look, what we thought about Ajmaline being a perfect test, we know is not correct. And there's a potential chance that even though you have a positive response to Ajmaline, it may be that actually you don't have this condition called Brugada syndrome. And I think then you have to give them as much information that they can understand, even though the information for us is still cloudy. You have to give it to them in a way that they can understand so they can make the decision about having it. And, you know, I've had patients who have said, you know what, I think I will leave it. I feel well, my resting ECG is completely normal, I have no syncope. I'll avoid those drugs that you told my GP about. I'll make sure I treat my fever properly. I'll make sure I keep myself full of diurolite if I have diarrhea, but I won't have that label of this condition that you say I may not actually have. I think the Shanghai criteria is useful as a guide. It's useful as a guide for your pre-test probability. So if you think that if they have enough that they would score with a positive type 1 pattern, either because they have a family member or they've had a gene in their family, then I think go for it. If your pre-test probability isn't going to take you over the line, have that discussion with them up front about it.
The problem, Bode, if I may, with that approach is when they need their knee replacement and they hit the anaesthetist and surgeon who says, so what's this story here then? You want to avoid these drugs, but you haven't got a diagnosis of Brugada.
Yeah, so it's the same kind of adage that do you do an intervention on someone so they can get their HGV license? Well, you treat them based on their clinical need. You don't treat them based on their ability to get a license or to have an operation. You just tell the clinician, you tell the person doing the operation, well, what would you do if they did have Brugada syndrome? How would you approach the anaesthetic? Do that. If you're not comfortable doing it in your setting because you don't have the appropriate monitoring, then take the precautions of doing it in the setting that the patient can be monitored.
I actually agree with you. The trouble is it's such a difficult message to get out there, isn't it?
Yeah.
You know, the previous message was easier.
It was, but not for the patient long term.
It wasn't right,
Yeah,
but it was easier. Any other questions?
Yep. Got one at the front there.
Thank you. Just a quick question on the ICD selection. I know it fortunates for the minority of patients with long QT. Do you use, obviously young patients, you're always thinking about subcutaneous ICDs, avoiding leads. But have you found atrial pacing helpful in your patients, particularly long QT 2-3 patients? I'm never quite sure where the balance is with subcut versus a transvenous system in those patients.
Yeah, it's a good question, Harshal. I think, so firstly, my threshold for a prime prevention ICD in long QT is sky high. I can't think of anybody in our local practice where we've done that. The patient's presenting with cardiac arrest where you are going to put an ICD in, the choice of device is difficult. As you said, many of the patients are young, and so to avoid transvenous leads has a real benefit, and we have lent towards that. But maybe for the long QT2 patients who are bradycardic even before beta blockers, then there probably is a role for atrial pacing in those patients. Again, it comes down to individuals. So I would generally go for SICD, but maybe long QT2s transvenous lead with an atrial lead. Long QT3s, we have one long QT3 family. I think long QT3 is exceptionally rare. None of those family members have an ICD.
May I ask, Greg, about your patient who you shared with us, who didn't take her beta blockers? Does she have an ICD?
She doesn't.
She doesn't.
No.
Interesting.
So in that situation, she clearly hadn't taken her medication. She had such a strong provoking factor LQT1, was she? She was LQT1, and it was swimming. So it was a very dramatic thing at the time. She was away in France. We had this ILR report come through for the remote monitoring. So there's a lot of trying to get hold of her and getting her back in the country, etc., etc. But since then, she takes her Navlo every day. She has a reminder on her phone. She doesn't swim anymore, which wasn't a big thing for her. And she's had no further events. That was 2017, that event.
I've got a quick question for Georgiana. So with regards to the SUD programme, what's your experience been with approaching the commissioning services so far, and what do you think like the critical next step's going to be, and how do you think cardiac pathology is going to fit in the future?
So personally, I haven't been to the commissioners myself. I've been to the trust, and it is quite difficult when you come to ask for money. The first reaction is, thank you very much, next. So that's been the reaction so far. So it's about breaking that barrier really to try and insist. It's at a national level, there has been talks with the commissioners, and the reaction has been about the same.
So difficult at the moment.
Very difficult.
Do you think, Juliana, though, that there will be sufficient coroners who might now see that the benefits of this programme and take it up and push these people in and force this upon us?
Yes, so there's definitely sufficient coroners. We've had a lot of interest from those in adjacent areas, so they've heard about the pilot, and they have contacted me directly to say, can I send you a patient in? And we have accepted some of their referrals, or they will ask for advice. Would this be suitable for the pilot? And then we provide advice. The interest is picking up, perhaps not at the speed as we would have liked, but we haven't made a lot of effort to roll this nationally just because we are trying to do it in a controlled manner.
I think personally looking at it, I think that's the genius of the project, getting the coroners involved, because it took such a lot of effort to busy people with a huge workload to get them involved and enthusiastic. I wonder if they will force it upon us.
Yeah, I mean, the chief coroner for England has already agreed to the pilot, so I think that says a lot. And at some point they will have to, even those who are more reluctant to take the project up, at one point it will come to that stage where they will have no choice.
Yeah, it's a huge number, isn't it?
Yes, so we are doing seven. We started off with 7, now we're doing 11 coroners, but there's about almost 80 just in England alone, so huge expansion scope.
No, but I meant a huge number of patients that have come through the system and the impact on how many relatives you're looking at.
Exactly, yeah.
That's very impressive, isn't it?
At least what we've been doing now times 10.
Yes, yeah.
Which is huge.
Yeah.
And it's much quicker, isn't it? They're getting through the pathway much quicker than before, because obviously it was a year or so.
Yeah, and they're getting everything done within a few months, whereas an ICC referral would wait, depending on the current waiting times in each area, but it will be, in our area, about 6 to 10 months, whereas the pilot patients are prioritized.
Any other questions? There's no other question. I'd just like to ask John, you alluded to your counselling for epicardial versus endocardial ablation is different, and I suspect there's quite a few people in the audience who aren't ablationists and would quite like to know how you counsel people for an epicardial ablation.
For sure, yeah. So epicardial ablation access is typically done through the subxiphoid approach. And historically it's been done using a needle to try to access that potential space. So very technically experienced and gifted people were able to enter the pericardial space and then pass a wire through. But of course, to go through that route, there's often liver in the way. You're passing the needle, approaching the right ventricular space. And so there's a lot of critical structures that you can really do damage to. And in most of the sort of original case series of epicardial ablation, which have all come out of very, very high volume experienced centres, the rate of complications, serious complications, so right ventricular perforation needing open heart surgery, coronary artery damage requiring open heart surgery, visceral abdominal damage requiring open abdominal surgery, was of the order of 10%. And this was in the best hands in the world, people who'd done more than anyone. And so actually that's the number that I quote for epicardial ablation, a risk of a significant complication between 5 and 10%. Now, in the last few years, there's been a bit of a paradigm shift in our strategy for doing this, in that actually a colleague in Brighton has pioneered an approach whereby you can make that potential space much bigger by injecting carbon dioxide directly into it. So you no longer have a millimetre to aim for, you've got more like a couple of centimetres. And this appears to be associated with a dramatically reduced risk of complications, sort of the order of 1%. And so we've adopted this, and we've got quite comfortable doing it now, and we've had no adverse consequences with it, which is very much the experience that they've reported in their series. So when I'm quoting that risk, I also say that we're moving towards an approach which seems to be associated with a dramatically reduced risk and that we're comfortable doing it, but that there remains the potential for significant complications. And people's reaction is a very personal thing. I think it's got very little to do with what I say to them. I think some people, as I'm sure we all experience, and I'm sure we experience when we're counselling people regarding ICDs, it's to do with their own individualised perception of risk. And some people say, you know, I guess our Kelvins say it's fine, even if it's 10%, that's never going to be me, let's go ahead with it, let's get on with it. Whereas some people are not prepared to accept any interventional procedure at all. So that's broadly how I counsel people. So yeah, I'm sure other people have different approaches as well. And I talk them through the whole procedure so they know exactly where the risks are and what the potential innovations that may improve the safety profile are. But I absolutely quote high numbers, and I'm quite sort of clear about doing that.
Thanks. Any other questions, anyone? Yes.
I'll shout rather.
Okay, yes.
Do we nationally have capacity and responsiveness to be able to deal with that sort of epicardial, particularly epicardial ablation?
It's a very good question. I think there is absolutely the volume of patients who would benefit from epicardial approach to ablation. So I think there's the patient volume for sure. I think it should be done in centres, as with all of this type of interventional procedure, where the volume is sufficient that the operators are confident. And I think there are increasingly that number, or centres where there is that capacity and confidence and experience to do it. I suppose, I'm not sure if this is your question, but I guess another aspect of this is it justified to expend the resources in doing such a procedure, because these are complex and expensive procedures, a lot of kit, a lot of staff, takes out a cath lab for a whole day, almost universally, and one could make an argument, could you have a greater health impact by doing a greater number of simple procedures? And I have no data to support this, but I think it's an important technical skill that's developed and maintained, because there are clearly cases where it's absolutely necessary. And so that would be one argument that I would have for actually making sure there are sufficient centres doing it, that when there's simply no other approach, it's not something that's going to be associated with higher risk because people aren't experienced. Is that sort of...
Do we have enough centres nationally, and are they distributed appropriately to ensure that they can meet the needs of the nation as a whole?
Okay. So I guess I think that it's geographically uneven, shall we say. And so certainly on the south coast they have the volume. In London we have the volume, and there are definitely other major city centres that have the volume. Whether they are distributed evenly enough that everyone geographically can access such a centre, I'm afraid I just don't know.
So certainly the volume in the big centres, in the big cities, I suspect is absolutely sort of the experience is there to do it. Yeah.
John, just a little follow-up to Ian's question. Epicardiation in non-cardiothoracic centres, do you think that's an issue?
I don't think it should be done. No, I don't think it should be done at the moment. Yeah, I think that sort of the possibility of needing a bailout surgical procedure is high enough, and it will be an emergent need for it. So personally, I don't think it should be. We may get there. We may get there, but for me, no, at the moment.
So that has a big impact on those sorts of...
Completely, yes, absolutely, yeah. Yeah, that's a very important point, yeah, thanks.
Okay, well, I'd like to take the opportunity to thank everyone again. It was a fantastic morning, and I think now we can break for coffee, and I think we're back on track on timing, so amazingly. So half an hour coffee break.
you'll do an introduction, I'll stay here. You'll introduce Sam, we'll go sit down. We'll both come back up. I'll say thank you to Sam, introduce Caroline, we'll both go sit down. That's how it worked. I was watching what they did.
Okay, everybody, the next session is going to be starting in 2 or 3 minutes. So for those of you who are planning to go to these sessions in the River Room, if you like, start making your way upstairs, and the talks will start in sort of 2 to 3 minutes or so. Thank you. Great. Well, welcome back to the second session. And just to say that anyone who does want to join the River Room session, that'll be starting simultaneously upstairs. So we've got a brilliant session coming up, sort of largely focused on heart muscle disease, and then we're also going to hear from Kate Thompson talking about an MRC AICC node initiative. So we will start off with Professor Sam Mohideen from Bart's Heart Centre, who is going to talk to us about left ventricular non-compaction, cardiomyopathy and hypertrabeculation. Sam's Professor of Cardiology and Heart Muscle Disease and MRI at Bart's Heart Centre and has been an AICC Council member previously. Thank you, Sam.
Thank you very much for that introduction, Steve. I've very slightly changed the title of the talk, and as you can see now, the title of the talk actually is the talk. This is really the conclusion of what I'll be telling you. Left ventricular non-compaction cardiomyopathy doesn't exist anymore, so we're told, and I want to present data and an understanding as to why that's being said. I have no conflicts to disclose, but want to start with this slide, which many people it contains information that many people will be familiar with. Left ventricular non-compaction cardiomyopathy means something to many people. And you can see from the images here that some of the imaging abnormalities that are identified as a heart muscle disease characterized by lots of left ventricular trabeculations are quite striking. It definitely draws the eye. And this is how LVNC would be defined. It's characterized by excessive trabeculations with intratrabecular spaces that communicate with the left ventricular cavity. It's described to lead to heart failure, to malignant arrhythmias and thromboembolic events, and is thought, at least hypothesized, to be due to a problem with cardiac development in utero, an arrest of the formation of a compact layer of muscle in the left ventricle from the non-compact layer. And I want to talk about each of these things and pull them apart, if you like. You can see also that there is, when you look at these hearts, you can very readily imagine how non-compaction can lead to LV dysfunction because you've got an abnormal muscle. malignant arrhythmias. Perhaps these trabeculae form the substrates for reentrant rhythms, for example. And these features here of thrombi in the left ventricle, they're very arresting. And the idea that thrombi can form in the trabecular spaces, I think, is a major reason why we've thought of this in the past as an entity. This next slide, I don't want to be too philosophical, but I think it's important to ask the question, what do we mean by a diagnosis? What is the disease entity? Why do we call a disease and differentiate from other similar conditions? And this is a very pragmatic way, I think, of identifying what it is we mean by a condition, a distinct illness or an illness that shares a number of important key features, doesn't have to share them all, shares similar causes, but fundamentally, from a pragmatic perspective, allowing us to diagnose a condition and using certain rules, a framework, if you like, with which to manage symptoms and prognostic risks. And the question we have, really, is whether or not that is the case in left ventricular non-compaction. This is a recently published state-of-the-art paper written by a number of people from a broad spectrum, pediatric cardiologists, adult cardiologists, imaging specialists, developmental biologists. And I'm going to present to you a summary of the work that we did and a conclusion at the very, very end. But essentially, this paper contains a lot of what I want to tell you today. Start with this slide, actually. This slide, I think, is a very good summary of the problem we're talking about. It's a problem of what to call a condition and how it can be useful in giving someone a diagnosis, because you can then use a framework to manage them. And we all have a number of different frameworks. So this chap, 63-year-old man, presents to A&E, rapidly conducted atrial fibrillation, features of heart failure, echo shows LV impairment. He sees the EP team, and he's given a diagnosis of AF, which will improve, his LV function will improve after ablation, which it doesn't. He remains in systolic impairment. And the AICC team is asked to see him, and they determine he's got a family history of this or that or the other. His ECG looks funny, it looks like a heart muscle disorder. So they send him for genetic testing, and it comes back with a myosin heavy chain mutation. So in our eyes, he's now got myosin heavy chain related heart muscle disease of some kind. But we also send him for an MRI scan, and the person that requests the MRI scan doesn't tell the reporter any of these things, which is a problem when you request tests. You must give the right context. And they look at the MRI scan, they say, well, you know, he's got LV impairment, systolic dilation. He's got latent enhancement in the left ventricle. He has perfusion imaging because he has perfusion imaging, and it shows he's got global hyperperfusion. It looks a little bit like a syndrome X. He's got a right ventricle that also looks architecturally abnormal with, could these be microaneurysms? But he also has abnormal trabecular anatomy. And quite honestly, you could call this a form first of ARVC. You could call it syndrome X. You could say this is gadinopathy. It's a scarring condition. You could say it's DCM. But this is what the person chose to call it. And I think that's because it's a striking abnormality. But actually, you can see there are alternative diagnoses and conditions to consider, different ways of considering. This is a very old slide. Steve, you'll remember this slide from way back. This is how the ESC have categorized heart muscle disorders, finding that the framework specified or used for HM, DCM, ARVC, and restricted cardiomyopathy is a useful way to progress through management. It helps us understand what information to elicit, how to interpret it, how to organize it, how to use clinical information. And we do that according to these diagnoses. The more recent ESC guidelines have exactly the same concept, except they use colors and circles instead. But it's the same idea. The question is, does LV non-compaction, should we be adding it to this list of things? And the answer, I think, is no, and I'll tell you why that's the case. So back to the idea of being pragmatic, of therapy, of treating. And I show this slide in all my talks because I think it's the most important slide from a clinician's perspective in ICCs. This is what we do in the clinic. We want to make a diagnosis so we can use these diagnostic frameworks. If we can't use one of those frameworks, we describe the abnormalities that we see because they are helpful in allowing us to assess why someone's symptomatic and therefore what treatments we can give them to make them feel better, outflow tract obstruction, diastolic impairment, systolic impairment, that kind of thing. Evaluate prognostic risks. All our disorders cause people to die suddenly, to have strokes, or to have progressive heart failure. They all speak the same language, if you like, but understanding how to prevent these things depends really on the condition we're looking at. We want our patients, despite the condition that they have, to live as healthy, long, happy lives as possible. So we need to be able to understand how to manage the taxi driver, the aeroplane driver, the pilot, the pregnant woman, the athlete. We need to be able to understand how to interpret this condition, this diagnosis, in their context. That's important. And then finally, we have to understand a little bit about how to do gene testing, who to test, when to test, and family screening. And that's because utility is important. And so the questions here are, is LVNC, does identifying someone with LVNC allow you to do these things? Do the cases share causes, phenotypic profiles, and outcomes? And does that allow you to diagnose cases easily? Does it allow you to treat people differently because of the detection of non-compaction? I don't want you to look at this slide. I want to talk you through it. There's a lot of information on here, but it makes a few simple points. This study is illustrative of several others, and in this study, 95 subjects who had a clinical diagnosis of LVNC, for reasons that we can talk about maybe, underwent gene testing using a broad panel. And because 40 of these 95, so under half, had genetic abnormalities identified, likely or pathogenic abnormalities, the authors conclude that LVNC is therefore a genetic disorder. It's only less than half of the people. And when you look at the disorders, rather, when you look at the genes affected, you think, well, really, we're very accustomed in ICC to deal with allelic and non-allelic heterogeneity, but this is really, really, really broad. Sarcomeric, structural, desmosomal, ion channel, other. More than 5 separate, very different, disparate categories. You've got to ask yourself, is the problem here to do with case ascertainment? Are these all the same thing, or are these a bunch of cases that have come together because of the identification of an imaging abnormality? And that's also seen here in the clinical characteristics. Many of them have a form of dilated cardiomyopathy, presenting with heart failure, and they have arrhythmias. So the question is this a single entity? Is this a condition? Perhaps LVNC is not a disease or even a disease group that's useful for us to use. These may be very, very different diseases. And you can see here when you look at this is the same data from the same group of patients, that the majority have sarcomeric mutations. Of those that have a genetic abnormality, many didn't. And almost certainly this group includes people that you and I might think have normal hearts, apart from the fact that they have LVNC. So, case ascertainment is an important issue. How do we identify cases and distinguish them from non-cases? And non-cases could either be normal people or people with other heart muscle disorders. So how is non-compaction, how has it been defined? And there are 3 examples here of people who've been diagnosed with LVNC. Are we talking about the relative thickness of the trabecular versus non-trabecular layer, or ratios of those things? Are we looking at the morphology? Jerry's favorite topic is the morphology of trabeculation. We're looking at meshes like we have here. We're looking at cords like here. Is it the size? Is it the involvement of the papillary muscles? What exactly is this thing? Is it a developmental problem, or is it something else? The location in the left ventricle. You very commonly see trabeculation in the apical lateral. Very rarely see it in the septum. So is seeing it on the septum important? Is the right ventricle, is involvement important? Which cardiac phase? Which imaging modality do we use? All these things have contributed to some noise around the subject about to do with ascertainment. of cases. And again, here, I don't want you to read the detail. These are just 1, 2, 3, 4, 5 different ways that have been described for diagnosing, detecting cases of LV compaction, non-compaction using echo or MRI. And it's important to note that each of these strategies for detecting non-compaction were developed in really small groups of patients who had the diagnosis made already. As small control groups, no external validation. And even at this stage, when you look at patients, it becomes clear there's a problem in pregnant women, in people who are of Black African ethnicity, certainly in athletes, people who have chronic anemia, and those with hypertension. So these people all appear to acquire non-compaction. And when you look at it more carefully, as is summarized on this, in this meta-analysis, that when you look at various different cohorts, patient representative cohorts, so non-patients with similar, in fact, these are just normal cohorts, non-cardiac patients and athletes, that more than 20%, sometimes as much as 60% of individuals meet those criteria for a diagnosis of left ventricular non-compaction. It's clearly nonsense. These particular papers make the same point. A significant proportion of asymptomatic population free from cardiovascular disease satisfy all currently used MRI criteria for LVNC. Lots of asymptomatic patients have LVNC in this large MRI study and also in this study from athletes. So our way of detecting cases is really, really poor. And what the reason might be because actually the left ventricle is hugely trabeculated. And you can imagine that the better your imaging modality, the more of these that you'll see, perhaps also when the heart changes in respect to physiological circumstances changing, these may either become more visible because the heart's dilating, or they may themselves get thicker and bigger because muscle changes in physiology and in disease. I talked about Philip Zemrak's study. I was honored to be one of his supervisors for his PhD, and he published these 2 fantastic papers from 2 large MRI cohorts of patients and screening subjects that tell us, and the title there of the second paper it describes the finding. It's not associated with cardiovascular morbidity and mortality when you detect features of LV non-compaction in normal populations. So if you have someone who has no symptoms, no family history of heart disease, a normal systolic function, and this is an isolated finding, it does not signify poorer outcome over 9.5 years in the MESA study, at a similar length of time in this other study. If you look at individuals who have been diagnosed with LVNC, with left ventricular non-compaction, and you separate them according to whether or not they have LV impairment, those that have normal ejection fractions don't have normal outcomes. It's just those that have poor LV function, and so you've got to ask yourself the question, surely we're just dealing with heart failure, dilated cardiomyopathy, and not necessarily something that's intrinsic to the imaging finding of LVNC, of non-compaction rather, or of trabeculation. There's a slight caveat to mention, and I think this is an important caveat, and the question here is, within a group of people that have a heart muscle disorder, is there something additional you can learn from the fact that they may or may not have hypertrabeculation? Ne Ang from our place, he performed this meta-analysis on the left-hand side showing there's no difference between cardiovascular death and malignant ventricular arrhythmias in people with DCM plus non-compaction when compared to just those with DCM. But there may have been a signal with heart failure admission. That does by no means mean there's a causal relationship. It could be that people that have DCM and non-compaction could have a physiological adaptation that marks them up as being not doing well, or it may be that the causes of DCM that give you a poor outcome may also cause non-compaction. There's no necessity for causality. But this study also suggests the same, that if you have DCM and you have non-compaction, you may have a poorer outcome. It's not the non-compaction necessarily that's doing it, but there may be prognostic information in that. coming towards the end of the talk, and I just want to bring up a few other points about where these trabeculations come from. And this slide's meant to help summarize that. The first is a person in my clinic who has had an abnormal heart since he was a baby. And he's got this really funny-looking heart, which has been variously called non-compaction. It's called DCM. It's also been called left ventricular apical hyperplasia. He's gene negative for every gene test we can throw at him. He's the only person in his family with this disorder. It looks really developmental, and you can see the RV looks funny, the LV looks funny, the papillary muscles are odd. And you can buy the fact that this is something that happened during development. This is a developmental architectural abnormality, I think. Second case here is a woman who is screened because she has HCM in the family. She's got mild systolic impairment. It's not projecting very well there, but she definitely has increased trabeculation to the lateral wall. We know myosin heavy chain is one of the frequent genetic findings if you look at DCM with non-compaction. And so I think she's got a genetic predisposition towards her LVNC. I don't know whether these were present when she was born, or whether they've just developed as she's got older, as the other phenotypic features of HCM or DCM do. And this last case here is of a young man with severe sickle cell disease. He's black African, and he has a typical pattern of non-compaction, if you like to still call it that. But this is well recognized in people with chronic anemias, and it appears to be due to load dependent. It does go away, for example, if you treat hypertension or in pregnancy. So there are different routes to excessive trabeculation: developmental, genetic, as well as reversible load dependent. And then talking just briefly about the non-compaction aspect of things, this is just really, I think, to put one of the final nails in the coffin of the term non-compaction. We now have a better understanding of the development of the muscular layers of the heart. This is a mouse embryonic heart that shows a compact layer that's very thin and a much thicker non-compact layer. But the compact layer doesn't form from a transformation of non-compact into compact. These two layers develop separately, and it's because of allometric growth, differences in growth speed. Here you can see there's not one changing alchemically into another. It's just the two layers grow at different speeds, and the compact layer grows towards the end of development, and therefore becomes thicker because it grows, not because it's transformed from something else. So the term non-compaction as an etiological descriptor is also not something that's accurate. So it's a misnomer. Don't use it. So as a diagnostic entity, I hope I've shown you or argued that LVNC is a misnomer. It's an inaccurate premise because it's not a disorder of myocardial compaction. The trabecular pattern that we see is there for a number of different reasons, both in health and disease. And different causes may coexist. A patient that has non-compaction and then has hypertrabeculation and then gets heart failure may get more, even more complicated anatomy. And there's a certainty about what it is anyway. We don't really know how to differentiate case from non-case. And until we can, I don't think we can understand better whether or not there is a signal of prognosis in people that have non-compaction. And then finally, this is the summary of our paper. Non-compaction discouraged for inaccuracy, and we should be using trabeculation or hypertrabeculation as terms that describe a phenotypic trait, not a disorder, not a diagnosis. I've said all those other things there. What I do want to just emphasize is that I think we need to do more work on how this isn't the guy that phones home. This is excessive trabeculation, how it interacts with DCM, and there has to still be a caution in neonates and children because something different may be happening there. And then finally, just to say that the ESC recent guidelines say almost exactly the same thing, encourages not to consider LVNC as a cardiomyopathy and to use their preferred term is hypertrabeculation. And I hope I've argued, I've given you the evidence as to why this is being said. Thank you, Steve. Thank you.
Thank you very much, Sam. Now, I know that you've got to run away and you're not going to be here for the panel discussion to avoid difficult questions. I'm going to ask you a difficult question now. Now, you're a professor, and you said a very profound statement at the start of your talk. You said, why do we call a disease a disease? And that sort of highlights this recurring problem in ICC, that we keep having to reclassify things, and the criteria that we choose keep changing. And you've got examples of non-compaction, Brugada syndrome, is it pattern, is it syndrome, what criteria do you need? We've got non-dilated left ventricular cardiomyopathy, hypokinetic cardiomyopathy, the problems with left-sided arrhythmogenic cardiomyopathy. So this is a problem, and for clinicians, for the jobbing clinicians, this is very confusing. How do you think we can do better in the future? What are we doing wrong? Are we not being careful enough with our definitions? Do we not involve pathology, genetics, imaging, clinical criteria simultaneously, or how can we try and avoid doing this repeatedly?
Steve, your question is an excellent question. I don't know that there is an excellent answer to it. I think the fundamental point to make is that we're not dealing with a small number of discrete conditions. What the diagnostic frameworks that are used, I think, are used because they have proven empirically to be helpful from a pragmatic perspective. And that's because these disorders are sharing elements between them that allow us to use the knowledge we have within those frameworks that are useful for symptomatic and prognostic therapy. But there's no ideal diagnosis, because these are all disorders that are so heterogeneous in their etiology, but even the phenotypic effect of individual etiologies is itself varied. So I don't think that we should be trying to force diagnostic constructs onto these conditions. What we should use is our flexible frameworks. And I think the ESC approach to it is actually quite a good one.
In other words, sort of describe what you see and manage accordingly.
I mean, fundamentally, I say to people who do my clinic that slide of the pragmatic approach to the individual patient doesn't require a diagnosis, but it helps you organize what you see in the way of abnormalities in a way that has a utility. So why are this, what can I do to make them feel better? What can I do to improve prognosis? So that's the approach, I think. But the idea of making a diagnosis simplifies that approach.
Brilliant. Thank you.
Thank you very much.
Let you get away.
Okay, so we're going to move on to our next speaker now. So I'd like to introduce you to Dr. Caroline Coates. So Caroline is a consultant cardiologist and senior lecturer at the University of Glasgow. She's the lead clinician for the National Network for Inherited Cardiac Conditions and has played a key role in developing the direction of ICC services in Scotland. And I think you'll all agree we're excited to hear her talk today on the new therapies for hypertrophic cardiomyopathy. Thank you, Caroline.
Great, thanks very much. And thanks for the invitation to speak. And I'm glad I'm not organising this meeting this year. And it's good to be back in London. So this is a hot topic, and I think most meetings has someone who talks about this. So that's me for today. So I think everyone in this room probably sees patients with hypertrophic cardiomyopathy. It's one of our most common inherited cardiac conditions. I'm going to talk specifically about new treatments and focus on cardiac myosin inhibitors. Just check I've got the right. Step from here. These are my disclosures. So hypertrophic cardiomyopathy is very broadly classified as obstructive or non-obstructive. And that's because outflow tract obstruction has historically been a key part of both the symptomatology of patients, but also the diagnosis. And on, this is the kind of typical echo appearances that you might see. But actually, not unlike the previous talk, it's much broader than that. Hypertrophic cardiomyopathy can affect the septum, the whole heart, the apex. There are a number of different genetic variants that lead to the same phenotype that we see in clinic. As you know, echocardiography is essential to the diagnosis, and this is going to become increasingly essential as we move into a therapeutic, some of these new therapeutics. So what this illustrates here is the mechanism of obstruction in most patients and the challenges with distinguishing outflow tract obstruction from mitral regurgitation. And I think anyone that scans these patients will acknowledge that this is the single most challenging aspect to record is the outflow tract gradient. So if we're measuring an intervention that impacts gradient, we need to be really precise about our measurements. So you will no doubt have seen that the ESC guidelines that were published in the summer had a short section on new treatments in hypertrophic cardiomyopathy. And this is the first time it's been adopted into the guidelines. And this is where this is the sort of treatment pathway, if you like. So for patients with obstruction, and that's defined as a gradient on Valsalva or exercise more than 50, if they have symptoms, then you can start treatment, or treatment's likely to be beneficial. Beta blockers first line. Calcium channel blockers are for patients that perhaps don't respond to beta blockers or have a contraindication for that. All of those drugs are given a class 1 indication, but the level of evidence is actually not as strong as you might think. If people are still symptomatic, then we come to what's known broadly as add-on treatment. We've been using disopyramide for many years, probably underusing it actually, because it is quite effective at reducing outflow tract gradient, but it does come with side effects and a tolerability to it that the effect can wear off over time. You'll see the new drug, mavacamten, which receives a class 2 indication, and that's because but a level of evidence A, which means there's been a randomized controlled trial. And then if people are still symptomatic, then we think about the more invasive septal reduction treatments like septal myectomy or alcohol ablation. So if you've not seen this, I'll just bring this study to your attention. This is a very small study that remarkably was only published 2 years ago, which is actually the only randomized controlled trial that we've got of beta blockers in hypertrophic cardiomyopathy. So this was done by a group in Denmark. And very simply, they gave people beta blockers, measured their gradients, crossed them over to receiving placebo, and they demonstrated very nicely that there is a reduction in gradient with beta blocker treatment. They also measured exercise capacity, and you can argue, why this didn't improve exercise capacity. It was a short treatment window, but nonetheless, it had an effect on reducing gradient, perhaps didn't improve overall function. So we then come to mavacamten, and what is this drug? Well, essentially, this is a drug that has been in development for a number of years, and it's specifically designed to target the underlying problem that we believe exists in hypertrophic cardiomyopathy, which is that it can reduce gradient whilst preserving ejection fraction. So mavacamten kind of gets right into the sarcomere. It inhibits how myosin and actin interact, and it reduces the force of that interaction, so it allows the myosin to be in a more relaxed state for longer. So the pivotal study here was a study called Explorer-HCM, and some of you may have enrolled patients into it. And this was the biggest randomized control trial at the time of hypertrophic cardiomyopathy. It enrolled people with obstructive symptoms, class 2 or class 3, and the primary endpoint, which is the measure of how effective the drug is was a combined endpoint of reduction in NYHA class and measurement of oxygen capacity on cardiopulmonary exercise testing. So over on the right, you see the results. So a very dramatic reduction in gradient at 4 weeks. And then after 12 weeks, really that gradient reduction's maintained up until the end of the study, which was a 30-week study. On the bottom, you see the improvement in NYHA class. So this is a little bit harder to interpret, but you can see the class 2 patients are the ones in pink. And as they move through the study, their symptoms, you have many more patients in NYHA class 1 in the treatment group compared with the placebo group. So if we look at the timeline of how's this drug got into the guidelines, it's actually taken probably 10 years, right from understanding the biology to conducting the early phase trials, and then the kind of phase 3 implementation trials, and there's work still ongoing. So this just summarizes some of the trials that have happened and are ongoing at the moment. So the Explorer HCM, you can see, was published in 2021, and then there are some ongoing extension studies. So people that went into Explorer are still being followed up to look at long-term efficacy. Valor HCM is a study that specifically took people that were on a waiting list or being referred for septal myectomy and randomized them to receive mavacamten or usual care. And again, there's long-term data from that, some of which came out at the AHA last weekend. So ultimately, all that evidence generation has led to marketing authorization for mavacamten, initially in the US, in Europe in June, and then the NICE recommendation, as you'll know, came out in September. So you may or may not be aware that mavacamten isn't the only cardiac myosin inhibitor. Aficamten is the next-in-class compound. They differ in their chemical structure, and they have different, really pharmacokinetic properties, which mean they have different half-lives, the individual response profile is different, and the drug interactions are different. So if we look at aficamten, that's a little bit further behind in terms of evidence, but it's very rapidly catching up. So the Redwood study was the phase 2 study that's been published. There's a portfolio of studies looking at aficamten versus placebo, directly comparing a beta blocker with aficamten, and then a non-obstructive trial as well. And all of those patients go into a long-term study to see the outcomes of long-term treatment with these drugs. Now, as well as reducing gradient and improving symptoms, these drugs seem to have a significant impact on cardiac biomarkers and other measures that we know are associated with worse prognosis in this disease. So that's just data from Explorer and Redwood showing that both drugs have a similar effect. Okay, so that's the evidence. What you probably want to know is, who am I going to give these drugs to? How are we going to do it? Who should we prioritize? And who's going to pay for it? So I haven't got the answers to all of that. But implementation of new treatments, whichever part of medicine you're working in, always comes with its challenges. And I think as a community, this is the first time we've really faced a significant change in a treatment that potentially quite a few of our patients are going to benefit from. So the NICE recommendation is a really useful document as a starting point. If you're a prescriber and are going to be prescribing these drugs, then good knowledge of the SPC, or the summary of product characteristics, is the key document that you need to look at. There are some very helpful patient and professional-friendly sort of checklists that are being provided. But essentially, there are a number of different doses of mavacamten. Before initiating it, patients must have an echo where their ejection fraction is more than 55%. They need to have a negative pregnancy test, and they need to be genotyped for cytochrome P450. Or we need to use a lower dose. And that's because of the interactions with cytochrome P450 inhibitors and inducers. And people that are poor metabolizers, because they have a genetic predisposition to that, are at much greater risk of LV impairment. And that's up to 3 times they can have 3 times the dose of mavacamten compared with someone that is a normal metabolizer. So the SPC contains several figures, and I've just pulled one out as an example of the approach to prescribing and safe prescribing of these drugs. So this is how you would initiate and monitor treatment for patients that have, that are normal metabolizers, basically. And very simply, it's a baseline echo, it's an initial dose, it's a titration at 4 weeks, another titration at 8 weeks, and then 12 weeks. So you need to be familiar with that and following that algorithm. So echo, as I said at the start, is a really key part of monitoring these treatments. Particularly at the moment, we might find that there are individuals, there might be doses that we don't need to have such intense echo follow-up, but we don't yet have that evidence, so we need to follow the prescribing guidelines for these drugs. So practically, this is an increase in the number of echoes that our patients would normally be getting. So that will have an impact on echo services. The follow-up echoes can be focused. There are particular metrics that you're looking for. So continuity and careful echo protocols, I think, will really help. But I think ultimately we can discuss it in the discussion, but I think every centre is going to have a different approach to how this is implemented, depending on your own individual circumstances, services, geography. I think that there are quite a few gaps in the evidence. We're obviously, this is early days. There's lots and lots more evidence that's going to come out in the next few years. But these are some of the current ones. So we don't know yet if they're effective in non-obstructive hypertrophic cardiomyopathy. We don't know whether we should be going to the highest dose tolerated, which is what the trials followed, or whether we should be using the minimally effective dose. We don't know about safety in children. There is an adolescent study coming in aficamten. We're learning about the long-term safety. If you're going to be on this for 10, 20, 30 years, we're going to only gather that data over time. There's a little bit of data now published about genotype specifics. At the moment, the data is that whether you've got a sarcomere variant or not, it is as effective. We do know that some sarcomere variants, some of these genetic mutations cause hypocontractility at the cardiac myocyte level, and there just aren't enough patients with those mutations on these drugs to draw any conclusions yet. And then I guess the holy grail is actually, if this mechanism of hypercontractility is there right from the start, should we be giving these drugs well before people develop hypertrophy? So it's quite an exciting area. There's lots and lots of research to be done and lots of data to come out. So just briefly mention that this is only one of the vast number of potential treatments that we're seeing develop. And it's not just in hypertrophic cardiomyopathy. We're seeing developments across all of the genetic cardiomyopathies and channelopathies, to be fair. So gene therapy in hypertrophic cardiomyopathy is also an area of active research and clinical trials. So gene therapy, really what it means is the introduction of new genes or genetic modification of existing genes as strategies. So it's a it encompasses lots of different techniques. And usually the genetic material is delivered through AAV vectors or capsids. There are a few conditions where these treatment trials are quite advanced: Duchenne, Fabry, and Danon. The first patient with hypertrophic cardiomyopathy was dosed in the USA last month, and that's an NYBPC3 trial. There's recognition that immunosuppression regimes, in order to deliver gene therapy, need further work because of the what's called off-target effects, and that's things like hepatotoxicity and hemolytic uremic syndrome. And then obviously it's very challenging it's been hard enough to do randomized trials in hypertrophic cardiomyopathy, but in very nuanced treatments like gene therapy, then trial design needs very careful thought. So I've taken a number of patients through these trials, and I thought I'd just share actually what we get asked patients for feedback actually through, not myself, but our research team. And I think we would not be at this point if it wasn't for patients participating in trials like this. And as a country and Europe, we're really starting to contribute a lot to advancing these therapies. So I think, as you'll read, patients value the opportunity to be in trials, and I think it's our job to try and facilitate it, to allow them that. So in conclusion, echo is essential. Make sure your echo services are able to diagnose and monitor these treatments. Beta blockers, calcium channel blockers, and disopyramide are first line. Cardiac myosin inhibitors are an emerging drug class. We're expecting more clinical trial data at the end of this year and into next year. And I think now's the time to consider how we're going to implement these treatments. And I'm sure the AICC will be helpful in bringing people together for that. Thanks very much.
Thanks very much, Caroline. You are staying around for the panel discussion, aren't you? So I don't need to pepper you with awkward questions. So our next speaker is Dr. Eleanor Wicks, who will be familiar to many of you. Eleanor's a consultant cardiologist in Oxford and has previously trained in London. And Eleanor has been on the AICC Council for several years now and is currently the Joint Secretary. And Eleanor's going to talk to us about myocarditis and arrhythmogenic cardiomyopathy.
Thank you, Steve, and thank you all for coming today. So we've got quite a broad topic to cover here, so I'm going to take you through things. First of all, I have no relevant conflicts. So we know the next kind of 15-20 minutes or so, we're going to look at the definition of myocarditis and arrhythmogenic cardiomyopathy, think a little bit about the pathogenesis, the cause, symptoms, diagnosis, and to try and just pick out a little bit the interplay between arrhythmogenic cardiomyopathy versus inflammatory components, as they actually also play a significant role. So just a brief thing, this is the training day. So what is myocarditis? Myocarditis is inflammation of the heart muscle with inflammatory cell infiltration. And if you develop cardiac dysfunction, we commonly describe that as inflammatory cardiomyopathy. We commonly see ventricular adverse remodeling, maybe LV dysfunction or other arrhythmogenic kind of elements. The cause of myocarditis is quite heterogeneous, so it could be related to viruses, drugs, toxins, or even autoimmune disease. And the schematic there at the bottom really just demonstrates that a highlight of different viral agents or bacterial agents that can attack the heart muscle itself. But the spectrum of presentations that we see are quite vast. We commonly see people with an acute coronary syndrome-like presentation, so chest pain and with unobstructed coronaries when they go for an angiogram. But other people may present with a more fulminant picture or arrhythmia or LV systolic dysfunction. And increasingly, we see other conditions, such as in cancer therapies. We may see an acute myocarditic process in the context of immunotherapies, for example. But what's the scale of the problem when it comes to myocarditis? So Most present, as I say, with acute chest pain, and that's in up to 95% of people. So we have to decipher it from the acute coronary paradigm. But 50% of troponin-positive chest pain presentations are actually due to the myocarditis with unobstructed coronary arteries. Now, if we think about the clinical syndrome and how do things progress, about 50% of acute myocarditis resolves in the first 2 to 4 weeks, but 25 actually develop persistent cardiac dysfunction. And myocarditis is the 4th most common cause of sudden cardiac death in post-mortem studies. So it's also common in idiopathic dilated cardiomyopathy, and this is a kind of area where I guess in the heart failure arena we've really failed to look into the actual underlying etiology of LV systolic dysfunction, but we must be mindful that inflammation does play a role in causing dilated cardiomyopathy. Many of us in clinical practice will have seen hot phases of disease where someone presents acutely with chest pain, they have a troponin rise. And again, these elements need further unpicking. If we think about basics, going right back to basics, history, examination, thinking about what blood biomarkers you may perform, thinking about whether someone has systemic features of an autoimmune disease, and measuring a troponin and an NT-proBNP are all kind of the basics, really. We go on to think about imaging in more detail. Should we think about cardiac MRI scanning or PET scanning? And then consider those that are at higher risk that may require endomyocardial biopsy. Our management is very much driven conservatively at the moment with symptoms and monitoring for adverse markers such as arrhythmia or end organ dysfunction. And the standard gold therapy of treatments is your cornerstones, your 4 pillars of heart failure medications, for example, and then tackling each complication as it arises, anticoagulating if someone develops an LV thrombus. What I would say, when it comes to an acute presentation with myocarditis, wait until the troponin falls before you send them home from hospital, because that's the high-risk kind of period where people may develop quite abrupt arrhythmias. We do classically describe or advise people against exercise, and that's because high-endurance sport or higher levels of exercise in the context of acute inflammation within the heart can make the heart more twitchy and prone to more arrhythmia and deterioration in function. And then there are broader lifestyle measures, which I'm not going to dwell on. Again, from a training perspective, what do we look at on cardiac MRI? Well, we're looking at the cardiac function and the shape of the heart. We're looking on whether or not there's any sign of scar tissue within the heart. We're looking at whether there's any signs of inflammation within the heart, and then other elements such as thrombus. And we can look at the pattern of scar in the heart, which can be very helpful as well in trying to guide us towards a diagnosis, which I'll come on to later. PET scanning, this is one of my areas of interest, but again, the white that you see here in the 2 middle images suggests active inflammation within the heart, and following immunosuppression therapy, this can resolve. And biopsy, and I'll come back to biopsy shortly. But overall, the management of myocarditis actually requires quite a multidisciplinary approach, because we do need to think about arrhythmogenic elements, heart failure team from an LV dysfunction and the imaging side, but also histopathology, immunology, and increasingly really immunology are really key components to managing these patients. Now, clinical outcomes are really tricky because, as I've mentioned, the vast majority's hearts will improve and recover, but 25% will deteriorate, and it's detecting who those patients may be that's really important. And what we don't really know is who goes on to develop fulminant myocarditis, who will recover and heal themselves, and who will have a long-standing, more chronic disease, and then which therapies are appropriate for which patients. So we've got a lot to tease out. We do know that there are adverse risk factors, being older is one of them, male sex, comorbidities, and having an elevated troponin, an NT-proBNP, and some other markers on admission. And increasingly, we're becoming more aware about the relevance of cytokines, which are an element of the immune system. Genetics, I'll come on to. We know that there are lots of overlaps between inflammatory heart muscle disease, inherited heart muscle disease, and actually 1 in 13 patients who present with myocarditis are found to have a likely pathogenic gene variant in one of either the dilated or arrhythmogenic cardiomyopathy genes versus an absence in healthy controls. And those that harbor a gene variant generally tend towards having an adverse prognosis. What we do know, irrespective, is that even if you have some fibrosis, but your heart function is normal, your prognosis looks to be quite good. And there was a recent study here by Amrit Lotter from the Brompton group corroborating that. if you have fibrosis with LV dysfunction, you have a much greater adverse prognosis. Overall, myocarditis, it's one of the hot topics at the moment, and it's increasingly being recognised for a hospital cause of hospital admissions. And I'm sure we've all seen in our clinical practice patients that present in an acute hot phase, whether that be a hot HOCM, i.e. someone known with hypertrophic cardiomyopathy, they present with chest pain, have a troponin rise. This is likely to be an inflammatory element to their condition. Overall, I don't think we know a fraction of what we need to do in this area as yet. And I think there's a really complex interplay between the clinical syndromes, the imaging, the genetics, the histopathology, immunology, molecular biology, and the immune system in itself that we really need to tease out and delve more deeply into. The reality is that we have to think about how we decipher those that are at high risk and those that are going to develop, that have a worse prognosis, so that we can try and reassure those people that are going to recover versus those that may need more input and follow-up over time, particularly as their risk may progress. And there's a real interplay between underlying potential pathogens and the inflammation or the immune response and the host genomics and other interfering environmental factors. So all of these things can interplay. And I think there really is quite a mixture between the acute inflammatory element causing myocarditis, and I think genetics really does underpin this quite significantly. What we haven't really thought about is, could patients that develop LV dysfunction carry the genetic variants in cardiomyopathy-associated genes? And I'm sure in clinical practice, in fact, actually, show of hands, does anyone in clinical practice have patients with myocarditis that they've done genetic testing in, apart from the maybe small group of possible sarcoids? So it's increasingly becoming more and more common, but it's not unanimous. We don't all do it on a general basis. But what we know is that a lot of patients carry cardiomyopathy-associated genes, and those with LV dysfunction, for example, if we look into the world of peripartum cardiomyopathy, alcohol-related cardiomyopathy or chemotherapy-induced cardiomyopathy, we see a vast increase in truncating mutations in the Titin gene. So again, this is in the context of dilated cardiomyopathy, but what about in the context of myocarditis? And again, further corroborative information from children, a study demonstrating in those in a small population of 42 with acute myocarditis at presentation, nearly 17% carried rare variants in the known cardiomyopathy genes. And this is seen throughout Europe as well. We see familial twins that have myocarditis, and they were found to have a desmoplakin truncating variant. And again, across the gamut of other diseases, lots of studies now that demonstrate that desmoplakin is commonly seen in those patients that present with myocarditis. And if you have a desmoplakin gene mutation, as the curve on the right shows with the blue line, your adverse outcome is much worse if you carry a gene change as well as have the acute myocarditis. Now, a recent study at the Brompton group looked at the myocarditis on MRI scanning, and along with a group in Maastricht, looked at myocarditis on endomyocardial biopsy. And they looked at the prevalence of the rare protein-altering variants within this cohort of those genes listed, which are the kind of common genes that we would look at from a twitchy DCM element, if I can describe that. And what they actually found overall is that 8% of patients that have myocarditis carry likely pathogenic variants in arrhythmogenic cardiomyopathy or DCM genes. But what was really quite interesting here, and this is a real take-home point, is this graph here at the very bottom. If I just draw your attention to the very bottom panels here, yes, in dilated cardiomyopathy, as we'd expect, LV function is down. But in the arrhythmogenic cardiomyopathy gene carriers, actually, LV function was pretty much preserved. So, red flag, if you have someone with preserved LV function in the context of a myocarditic or an acute or an arrhythmogenic cardiomyopathy, it doesn't mean to say that someone is safe. So nowadays, depending on the gene variant, we do think about device therapy in some of these patients who may have red flags or high-risk symptoms. And we know at 5 years that all-cause mortality in this same group was up to 11% for genotype-positive patients in this group with myocarditis as the underlying etiology. So 11% of myocarditis in this group of about 400 patients. Again, the genetics were really important here. So what does this mean? Well, I think it certainly demonstrates that we have that the underlying inflammatory component may explain why we have such wide heterogeneity in individuals and in outcomes in the context of myocarditis. But likewise, in the context of arrhythmogenic cardiomyopathy, again, the interplay of inflammation may actually underpin some of this variation we see between individuals and presentations. And then other environmental factors and genetics that may be important. So, I mean, should we be offering genetic testing to all patients that present with myocarditis? I have to say I don't think we should, but I think we have to be a bit more pragmatic. But I do think we should be considering genetic testing pretty much routinely, actually, in those patients that certainly present with myocarditis but have a family history of cardiomyopathy or have a family history of known sudden death or a family history of recurrent symptoms, recurrent hot phases, or recurrent arrhythmia or heart failure. Because I think this is an area where it is of much unmet need. Now, just briefly to give a little bit more background on arrhythmogenic cardiomyopathy. So we know that this is a genetic disease of the heart muscle caused by defects predominantly in the desmosomal genes, which causes fibrofatty replacement. So at the molecular level, we have the DNA gene mutation that causes its protein dysfunction and then histologically leads to the fibrofatty scar within the heart muscle. That then leads to functional abnormalities, and we'll see on the ECG, for example, epsilon waves, which are characteristically seen, or late potentials. And then at the organ level, the characteristic things we look for are aneurysms within the heart muscle, dilatation or dysfunction of the heart muscle, and a substrate for VT that we see. But again, there's quite a wide variation in how these people present, and ventricular arrhythmias commonly precede LV dysfunction and pathological abnormalities. So again, if you're concerned, think broadly, do the genetics, because that may prompt you it may guide risk stratification a little bit more. The only reason I wanted to kind of walk you through here is just the classic T-wave inversion, V1 to 3, and the arrhythmic elements. And the CMR here at the bottom, you can see a really nice kind of RV aneurysm there. But risk stratification in these patients is key. Now, I mentioned just briefly CMR, so we see in this diagram here, your top left, we see extensive late enhancement, which is almost circumferential. Now, to me, that's a red flag for desmoplakin. Obviously, there are other things that can potentially cause that, but actually, DSP is the common red flag for circumferential late enhancement in this area. And again, this patient had some T2 edema imaging, which demonstrated presumed acute inflammation or water within the heart muscle. Now, I'm sure these genes are familiar to all of us that are here today, but it's not just the desmosomal genes that are implicated in arrhythmogenic cardiomyopathy. A lot of the other genes that can relate to biological functions or maintenance of cytoskeletal structure, the nuclear envelope stability or calcium handling, sodium transport, cytokine signaling, all of these things are really important and are involved. Again, classically, the presentation is similar to a myocarditic presentation as it is in ACM, chest pain, troponin elevation, ECG abnormalities, features on cardiac MRI scan, etc. So again, teasing these two diagnoses out is quite hard. What does seem to modulate the phenotype that we see in arrhythmogenic cardiomyopathy are specific drivers. So we know that endurance exercise increases risk and can cause disease progression. And we know that there's a role of inflammation. And many studies now have increasingly looked at this and have proven that there is inflammatory infiltrate in up to 2/3 of hearts with arrhythmogenic cardiomyopathy. Viruses are increasingly being detected. Autoantibodies are also being detected. PET scans can demonstrate it. And we're seeing a lot of injury, particularly up to 15% in desmoplakin carriers too, or those that present with recurrent myocarditis. There are lots of mechanisms, I'm not going to go into it, but essentially we are seeing active inflammatory signaling in DCM, and this is a main driver it appears to be a main driver of the phenotype. And histopathologically as well, we're seeing lymphocytic infiltration. We're seeing markers, CD45 and other markers of immune inflammation within these patients. So inflammation really does play a role. So the key message really here is to think that inflammation can trigger and can modulate arrhythmogenic cardiomyopathy in the phenotype that we see. And the pathology in arrhythmogenic cardiomyopathy is different to that we commonly see in a viral myocarditis or autoimmune myocarditis. This is a really lovely paper that if any of you are interested in reading, it kind of summarizes a lot of the latest updates, really. And as I've mentioned, autoantibodies are implicated, but I won't go into detail with regards to this. But could we use some of these autoantibodies or immune molecules or cytokine elements to think about how we can actually treat or target the treatment of myocarditis or arrhythmogenic cardiomyopathy through new therapeutic agents? And this diagram really just integrates to say that there's a whole kind of interplay of both the pathogenesis or a pathogenic variant, along with damage that may accrue, release of inflammatory cytokines and other inflammatory infiltrates that then can lead to the long-standing downstream effects. But there are, in the green here, options for treatment. So as Caroline just mentioned, gene therapies are increasingly becoming utilized in this area. Anti-inflammatory or immunomodulatory therapy, targeted anti-inflammatory therapies, opportunities for other kind of aspects of precision medicine, I think are really becoming forward here. And if we think to the cancer world and the rheumatology world, they're already using a lot of these treatments. So to just move to treatment therapy, so we have the conventional treatments and we have antiviral or immunosuppression or immunomodulatory treatments here. And classically, as we would with anyone, assess symptoms, confirm the diagnosis. Think about the etiology. It's really, really critical. Wait and admit until the troponin is falling. Exclude coronary disease. Check the biomarkers because they can highlight risk. And assess disease stage and severity and end organ dysfunction because that is what will drive risk. Consider biopsy in those with high risk features. And again, thinking about the wider downstream risk, avoiding exercise, and think of a follow-up and management plan for onward monitoring. So if we think about who needs a biopsy, for example, so I tend to suggest that it's the higher risk patients that need biopsy. And it's those that either present very acutely and those with severe LV dysfunction or red flags such as conduction disease or VT or recurrent VT, a failure for the troponin to fall, for example. But again, we commonly use MDT discussion to guide biopsy because it's not readily available. But if biopsy is performed, it should be performed in a centre that knows what they're doing because the interpretation of the biopsy samples is actually key. So I would refer patients to a specialist centre. If we think about treatment options, so for those, we tend to look for whether their viral is positive or negative in a biopsy sample, and then would advocate whether we would give antiviral treatment or immune suppress if the sample is negative. And that kind of tries to help you guide when should you go beyond standard therapy. If there's no inflammation, we would use standard heart failure therapy. If there was inflammation and virus negative, we would use immunosuppression. If there's chronic inflammation and positive virology, then we would treat with an antiviral as well and take it from there. And then there are lots of studies that really look at albeit very small studies that look at the use of immunosuppression therapies or immunomodulatory therapies. But there's a lot that we don't know. So there are only small studies, few randomized trials, and some with neutral effect as well. We don't quite know how long should we treat. Should we treat as a single agent with, say, with prednisolone, for example, or should we be using prednisolone and azathioprine? So there's lots of work that's actually ongoing in the background at the moment. We have to be mindful that some of the agents, and particularly immunosuppression therapies, are highly toxic, have major side effects, and can cause long-term downstream damage, such as infections and cancer, for example. So we have to make sure the right patient gets the right treatment. And there are other immunomodulatory therapies which we can consider, but I'm not going to dwell on them. Where are we now? Well, the novel therapies that are beginning to come through are aspects to look at different parts of the immune system to see if we can guide directed tissue-specific or disease-specific therapies by utilizing specific markers. So to conclude, overall, the management of, I'm calling myocarditis, be it myocarditis or a hot phase of ACM. So lesson one, take home, is these conditions are not one entity. They're distinct, several different distinct diseases with very different outcomes. And they can mimic each other and overlap each other. There isn't an easy diagnostic pathway, and diagnosis is not always possible, but it's about trying to delve deeply into to see where can we improve things, what can we do next, what can we do better here. We often require quite unique or different management, so we use the regional MDT process to try and optimize this. Lesson two, is quite a multi-specialty team. It does involve people, immunologists, biopsy histopathologists, cardiologists, imaging experts, etc. And that's so that we can and geneticists, that we can bring together everything in one place. Obviously, from a cash-strapped NHS, there are significant resource implications, so this is not easy, and trying to ensure that the right person gets the right assessment and treatment is challenging. There are diagnostic limitations. Biopsy is not it's not an easy solution, and you could take 5 biopsies and not get anything at all, but if you took a little bit of tissue from a different part of the heart, you may well have achieved a biopsy, a positive biopsy, but you can miss it due to the patchy nature of disease. And sensitivity is obviously low, and complications can arise. We've got much limited understanding on the immunological mechanisms, and we're way behind the cancer and rheumatologists in this area, but we are slowly picking up. So I think watch this space, really. And whilst therapies are largely unknown, there's a lot coming through. So I would say, in every patient you see that you're concerned, is this arrhythmogenic cardiomyopathy, is this myocarditis, think about the family history. Think about the imaging studies and look at the detail from those studies. Consider whether PET or biopsy is required. Consider genetic testing, particularly in those with recurrent symptoms, progressive symptoms, familial disease, and end organ dysfunction. The clinical course can sometimes help you. And then more inflammatory markers, I think we will start to see more routinely in due course, but at the moment we don't have so much access. There's no doubt inflammation's involved in the pathogenesis of arrhythmogenic cardiomyopathy, and the mechanisms contribute very much, but I suspect they may vary, and the phenotype that we see will vary according to the causal underlying gene variant. And we have to look more broadly. I mean, if you have someone with a desmoplakin cardiomyopathy, red flag. Think about devices at a much lower threshold. Exercise is important, and ultimately, hopefully, some of the inflammatory understanding that will develop over time will help us develop novel therapies to be targeted and personalized in the longer term. Thank you very much.
Thanks a lot, Eleanor. I think that will generate a good bit of discussion in the panel discussion afterwards. So we'd like to move on now to our final talk of this session. So I'd like to introduce you to Dr. Kate Thompson. So Kate is a clinical scientist working in Oxford. She's recently completed her PhD at the University of Oxford in cardiovascular medicine, and she's going to talk to us this morning on the MRC-AICC node. Thanks a lot, Kate.
Thank you. Thanks so much. Right. Okay. So I'm a clinical scientist based in Oxford. I've been specialising in inherited cardiac diseases for about 20 years now. And we provide a cardiac testing service for the South Central GLH. But what I'd like to speak to you about today is to give you a quick overview of a new cardiac research initiative, which has been funded as part of the Rare Disease Research UK network. This is all still pretty hot off the press, so much so that the website isn't live, but hopefully in the next few days or weeks it will be. So this network's been established with £14 million worth of investment by the MRC and the National Institute for Health Research. The Rare Disease Research Network comprises a central coordination hub with 11 specialist nodes, and they're based at different universities around the UK. Some of these are rare disease nodes, and some of these are called thematic nodes. And the idea is to bring together expertise from across the UK rare disease research system, and it's seeking to encourage greater collaboration and coordination of research into rare diseases. And they're wanting to involve patients and those working in academia and healthcare and industry. And the whole aim of this funding is to accelerate understanding of rare diseases, to improve diagnosis and treatment for patients. So we were very fortunate that as part of this network, we got awarded funding for the cardiovascular initiative. So this initiative is going to focus on building resources that can be used by the clinical and research community to improve our understanding of inherited cardiac conditions and our ability to diagnose and treat affected patients. So the node director is James Ware, who I'm sure all of you know well, and he's a professor of cardiovascular and genomic medicine at Imperial College London. Co-director is Tom Lumbers, who's based at University London Institute of Health Informatics. Kathy Sudlow, who's the director of the British Heart Foundation Data Science Centre at Health Data Research UK, is one of the co-investigators, as am I. So there's 3 core projects that have been proposed as part of this initiative. The first aims to build an ICC genetic database, a national genetic database. The second is to create a national inherited cardiac disease cohort, so combining genotype and phenotype data. And the third is to explore the contribution of common genetic variants, so polygenic risk in inherited cardiac conditions. So just to give you some insight into the motivation behind the proposal to create a national genetic database. Well, as you all know, genetic testing for ICCs is now a routine practice in the NHS and is a key component of patient care. And we've been undertaking genetic testing for over 20 years now, and in that time have tested tens of thousands of patients. But despite all this experience, results interpretation still remains very challenging. And there's a number of reasons for this. Obviously, these are really heterogeneous conditions. So we've detected thousands of variants in hundreds of genes across patient cohorts. But many of these variants are novel or private. They may only be seen 1 or 2 times. There's a lack of evidence generally, and this is really not helped by the fact that there's a lack of data sharing, particularly amongst the NHS laboratories. So due to lack of evidence, many of the variants that we see are still classified as variants of uncertain significance. So these aren't clinically actionable. And having high proportions of these variants really does reduce the clinical utility of testing and the cost effectiveness of testing. And I think probably more importantly, it brings a lot of uncertainty and confusion for patients and for healthcare professionals. So the UK NHS laboratories are sitting on a wealth of genetic data. I mean, historically, data from tens of thousands of patients. And based on current referral rates, we estimate that the NHS England cardiovascular labs are probably testing about 6,000 index cases a year across a range of inherited cardiac conditions, and probably an equal number of family members are being tested. But there's no effective or efficient mechanism of sharing that data. If we were able to centralize this genetic data and make it accessible to all the labs, we'd really increase our evidence base. And this would have a significant impact on results interpretation, not just for individual variants, being able to say a variant's been found in 6 out of 5,000 HCM cases in the UK, but would also, by pooling that data, have large cohorts, and being able to actually do analysis on these large cohorts would really provide us with more information about rare variants in ICC genes in general. So collectively, pooling this data essentially would really help us interpret test results better and improve genetic diagnosis. So this is what we're seeking to tackle in the project 1 of this. This is being coordinated by myself and Stephen Hardy, who's at NDRS, the National Disease Registration Service. So it's a partnership involving the 4 NHS England cardiovascular specialist laboratories. So they're in Brompton and Bristol, Manchester and Oxford. Stephen Hardy and colleagues at the National Disease Registration Service and the Decipher team. And we're not abandoning Scotland, Ireland and Wales. It's just that there's information governance issues that mean that we might need to bring them on board a bit later. We're going to be building on the knowledge and expertise that the CanGene CanVar project have built over the years, and that's led by Claire Turnbull, and they have had huge success in creating a national cancer variant database, which is really used routinely in the UK NHS. So we're aiming to collate genetic and clinical baseline data from the laboratories, and we're going to be pulling that together within the NDRS. Now, the NDRS has legal permission to collect and analyse this data. So we'll be able to store that centrally, and the laboratories will be able to access that data. The mission of Project 2 is to build a national ICC cohort. So this is a resource that could be used by the cardiovascular, clinical and research communities to answer some of the key questions in ICC research. So for example, improving our understanding of variant penetrance and disease expressivity in families, then looking at genotype-phenotype relationships, and looking at the characteristics of patients who have genetically undiagnosed disease. Obviously, answering these questions really does need large cohorts with genetic and clinical data. And there's a need to ensure that we've got appropriate consent processes in place to make sure that patients who want to consider participating are able to. We need streamlined processes for data capture and linkage. We need a trusted research environment which is secure and is flexible and scalable and has appropriate governance arrangements and is accessible and provides a robust analytical environment for approved research. So this is a project that's been coordinated by Tom Lumbers and Cathy Sudlow at the British Heart Foundation Data Science Centre, and it's seeking to establish a national ICC cohort. So this will be uniting genetic and clinical information for consented individuals within a trusted research environment. So they're going to be aiming to design a consent process that's embedded in the genetic testing pathway so that they can offer research participation to individuals being referred for genetic testing. And so hoping to capture and unite genetic and clinical data that's been generated through routine healthcare. So that will be the genetic data and clinical data that's been collected from the labs within NDRS. There'll be national longitudinal data within NDRS. And there's also plans to include, try and capture primary unstructured data such as cardiac imaging and ECG. The third project that's been funded as part of the initial phase is a cohort enrichment project, really, and we're planning to do genome-wide common variant genotyping on about 1,000 patients. So that will be individuals who've consented to contribute their genetic and clinical data to this ICC cohort study. And this project really aims to understand the polygenic contribution to ICCs, evaluating genomic risk scores in the context of the rare genetic variation and the clinical data we have on these patients. So we are partnering with various organisations to engage with patients and the public and the wider research community. We want to ensure that there's opportunities for the whole community to have input into the design and development of the cohort and the governance of the cohort. So just to quickly summarise, it's hoped that the Cardiovascular Initiative can build these resources which will benefit the ICC clinical and research communities. We hope this is just the beginning and that with future investment we'll be able to build a more comprehensive ICC patient registry. But ultimately it's hoped that these resources are really going to accelerate our understanding of inherited cardiac conditions and improve diagnosis and treatment. So please do keep a lookout for further information and please contact any of the team if you want to find out more about any of the projects or indeed if you're interested in getting involved in any of those projects. Thank you.
Thanks very much, Kate. That sounds absolutely fascinating and very ambitious. So, can we get the panelists, the speakers, up to the podium, please, and we'll have a discussion. Is there a microphone somewhere for people to ask questions? Brilliant, thank you. Great, so I mean, we've had some really fascinating talks there, and I think we're slightly ahead of schedule, so we've got certainly time for some questions and a discussion. Has anyone got questions from the floor? Jerry.
Those on calcium antagonists, what's going to be the way we deal with that?
So, depending on which one it is, I think you've got an option of withdrawing it, switching to mavacamten, or using lower doses and monitoring closely. the benefit, you know, we don't know, you know, in some ways what the right thing to do is. So I think I would just, you know, initiate with caution and monitor these patients really cautiously.
Yeah, thank you. Because I think that's something that people are struggling with at the moment when they're trying to write their sort of SOPs. It's what to do with that.
Mm. I mean, I took patients off drugs actually to put them into trials, and I think we will, you know, although it's an add-on therapy, I think it will very quickly move up to there being evidence once we know about withdrawal of background treatment. So, but I agree, it's difficult to know.
Could I ask an extra bit on that? Because I guess, Jerry, you're, I guess, alluding to for the wider floor of potentially the development of LV dysfunction in the context of mavacamten with the calcium channel blocker. So it's, I really just wanted to reiterate that from the question. So hence, you know, if you're withdrawing, should you withdraw the calcium channel blocker? Because it can cause LV dysfunction, given the small risk of LV dysfunction with the use of mavacamten. So that was the relevant bit for the question, yeah.
I mean, it's a long-term issue as well in hypertrophic cardiomyopathy, isn't it? We have lots of patients that are started on these drugs, and sometimes as their condition progresses, people don't think to stop a negative inotropic agent, and I think it's, yeah, having that as a red flag on your pathway would be a sensible way to approach it.
And I think switching even between beta blockers and calcium channel blockers can be difficult, can't it? It's not without its hiccups, and you know, you can destabilize patients. So it is something I guess we need to be very careful over.
I guess perhaps it becomes something within the pathway that when the patients come, particularly if the echo follow-up clinics are physiologist stroke red flag related, it should be a box that should be a, have you checked, are they on a calcium channel blocker or whatever, so that it's a really kind of poignant point, I guess.
Should we stick on the mavacamten issue? Gemma, so Gemma Bassendale's a clinical scientist in Leeds and runs our AICC echo service. And echo is a critical part of the rollout of mavacamten. I know you've been developing protocols for how to do a more focused echo.
Yeah.
Can you just describe that a bit and how focused is focused?
Yeah, so I think that was actually one of the questions I was going to put to Caroline, is that, you know, we've alluded to the fact that this is going to be a significant increase in the number of echoes that we need to do. So we've estimated in Leeds that it's going to be annually around about 300 extra echoes, which for all echo services is massive. So the one way that we're getting around this is that we're inputting these patients into a specific obstruction clinic. So they come to us specifically for up titration and management of new medical therapy, only for patients with symptomatic HOCM. And they'll have to have a full echo, a detailed echo at the beginning, but then in terms of follow-up, as you alluded to, you know, obstruction, ejection fraction, degree of mitral regurgitation probably will be sufficient. But again, with the BSE broadly are quite against focused echo protocols. And so this really does need to be managed, I think, locally before we can kind of all come together and decide on something that is probably to be rolled out nationally, I think. But certainly pathology-driven is the way we describe it rather than focused. We get around it that way. It is definitely going to be the way we do it. Otherwise, we won't be able to meet up with the demand.
Is it something that we could drive via AICC to try and help support regional centres? Because it's, I mean, if we're all doing it from the same pathway rather than multiple centres having to write their own pathways, would it be sensible, do you think, to try and centralise it and bring people together to finalise it? Because it's...
Yeah, I think everyone will have their own sort of way of doing things. I mean, I think there's a lot of parallels to draw with cardio-oncology, for example, where we've had to adapt echo services to monitor, you know, immunotherapy and things. So I personally feel like we're still at a really early stage with these drugs, and collecting real-world data is important. So I think we will be undertaking a fairly standard echo protocol that's relevant, that really reflects the focused protocols that were in the trials. But I'm quite happy if the report just has ejection fraction rest and outflow tract gradient, because actually that does save time. But I think it's really important that we understand what these drugs are doing to left atrial function, to pulmonary pressures over time. But that obviously is a particular interest, and that might not be as relevant to someone, you know, in another hospital that just wants to get the patient safely onto the next dose. So I think there's definitely scope for collaboration, but I'm not sure there's one right way to do it.
How do we deal with inter-observer variability? I mean, we all know that one person's moderate is another person's severe, and who takes responsibility for this? I mean, surely the only way is to compare studies with previous, you know, you've got to compare the imaging, but who does that? Should that be the sonographer? Should that be the cardiologist? Should it be MDT?
Certainly our model is that it will be a core group of sonographers. So we have 3 highly specialist AICC sonographers, and we feel that that's manageable with the number of patients that we have. I think that is the best model, but I appreciate that's probably not achievable everywhere. You know, particularly if echo services are so stretched, you might just, these echoes may just be put onto a standard outpatient echo list, for example. So in that situation, I think there probably does need to be an MDT format in place to be able to cross-check these things.
I mean, I think the prescriber is the person who's responsible, and you know, not unlike other conditions, you'll have your own level of, I want to see the raw data. You know, I've always looked at the images myself when I've prescribed in these studies, and I don't, even though I've got the most experienced HOCM echocardiographer and doing it, I still like to see the Doppler in 2 views, that, you know, the Valsalva gradient is what it is, and see the ejection fraction. I don't go and measure it, you know, myself, but I do review the images, and I think I'll continue to do so, you know, in the short term.
That's key.
See, I don't, and I mean, I do review some imaging, but I'm not an imaging doctor, and you know, Gemma is highly skilled, an expert in that field, and I'm only ever going to take her, you know, more experienced views on this. So I guess it depends who's doing the imaging, doesn't it?
Yeah, and the prescribing. I mean, I think this is you know, cardiologists prescribing, isn't it? It's not something our nurse prescribers are going to be doing initially, and it's not something that GPs are going to be prescribing. I assume it's the same in England and Scotland. So I think as the prescriber, we hold the responsibility for the dosing and the safety of it.
Yeah. Good. Here, we've got a question. 2 questions. Greg.
Another logistic thing about initiating mavacamten, the need for cytochrome P450 genotyping. How do we go about that without leading to delays in initiating? Should we be testing HCM patients for their cytochrome status before?
Yeah, so I think that's happening. So there's going to be some centralized SIP testing going on, and you know, if you want to be ahead of the curve, you could send all your patients that you think might be initiated to get their genotypes done, whilst it's being funded by, you know, the pharma sector, really. That, I think, is going to be in place in December, and that will give you information so that you know about that for your patients. Otherwise, if you don't have SIP testing available, which we don't currently yet, or not within the NHS, everywhere, there's a protocol for low-dose initiation where you can start someone on 2.5 milligrams, titrate up to 5, but you can't go beyond that without SIP testing. But this type of pharmacogenomic testing is you know, affecting conditions other than hypertrophic cardiomyopathy. Clopidogrel is you know, another example where some centres are incorporating that into their pathways.
Do you know the turnaround time for the testing?
I think they haven't published it yet, but it'll be fairly quick. 5 days.
Great.
So yeah, I'd get your patients tested once that's available, because it might be more problematic once that needs to be implemented locally.
Karen, once we've done this SIP testing, it doesn't have just implications for mavacamten, it has implications for other drugs. What do you think our responsibility is, having requested that test? where does our responsibility lie in terms of protecting them against adverse drug reactions from other drugs, non-cardiac drugs in the future?
Well, I mean, I don't know, but I see this as going on their health records. You know, it's a test that's being done. So I think having their genomic data on their health record, a bit like we do with their cardiac results or their hemochromatosis genetics results, I think it forms part of their medical record, so that other people might access that.
Yes, I suppose they wouldn't necessarily know to access it though, or know the significance. I think won't we need to in some way flag this up or work with our IT systems to work out what the alert should be? I've forgotten some of the drugs. Is citalopram one of them? Can't quite remember. But there are some commonly prescribed drugs that are going to be impacted by this, and it's a question of how we get that information to whoever's going to be prescribing, whether it's a mental health professional or a GP or a hospital clinician.
Yeah, so I think, I mean, we're starting to explore this with pharmacy, but it needs to form part of their records, I think, you know, like allergies and drug reactions, if it's
could
going
be like
to be
the
used for
warfarin,
prescribing.
you know, the warfarin kind of alert,
yeah,
yellow
exactly.
booklet and things.
Yeah.
Patients are often, well, patients should certainly work alongside their medical records, I guess, because ultimately they're going to be the people that a new treatment could implicate. So it's, I think, yeah.
Catherine's Yeah, there was actually on that subject, there was a very good talk in the River Room this morning, wasn't there, by a pharmacist who was focusing very much on pharmacogenetics. Very good. Any other questions? Yes, in the middle of the room.
Do you think in the long term, aficamten would become the first?
Sorry, I was saying, in the long term, is it possible that aficamten would become first line because of circumnavigating the need for the cytochrome P450 testing, and are there any other differences that are appreciated between the two at this early stage?
Yeah, I mean, I think it's difficult to answer that without the data. You know, the Sequoia study will be, the top line data should be available at the end of the year. There are, you know, it was engineered as a second generation drug exactly to circumnavigate these potential barriers for clinical use. So yeah, I think other important considerations are women, pregnancy, vetotoxicity, as well as drug interactions, and then time to clinical efficacy. We know from Redwood that there's similar to mavacamten, you know, it's effective within 6 weeks rather than 12 weeks. But yeah, I think we don't know yet, you know, is the honest answer. And there are other drugs in development, and you know, in the drug development pipeline that may come in and supersede these.
Very good. Any other questions? Yeah.
My question is to Kate. Kate, thank you for your presentation. That was really interesting to learn the different arms of the research study. For the case cohort arm of the study, in terms of gathering the clinical data, is there going to be a nationally approved consent form that we get patients to sign when we organize testing, or?
So that is something that's been discussed at the moment. So that would be the ideal, is that we have one form for cardiovascular genetics or inherited cardiac diseases, and within that form we put something about the consent, and we inform patients about what's happening with their data, and that at that stage, when the genetic testing is being consented for, that patients are, they discuss the opportunities for actually contributing their clinical and their genetic data into the research cohort. The only issue is at the moment is that NHS England doesn't want multiple different forms for different diseases. And without a national online solution for this, it does make it very difficult. I mean, we don't really want to go back to paper forms. We would like this to be, online options. But in a busy clinic, it's difficult to have, something that you have to log onto the PC. It's also difficult to have various different types of referral forms for different conditions. So all this is under discussion. And if anyone wants to input into this discussion, that would be great. I think the idea is they'll come up with a plan and then go out to the community and really get some feedback on that and thoughts about how it will work in reality.
Are you talking primarily there about Project 1 or Project 2?
So Project 1 is something that we can do anyway. So the NDRS has that legal authority to collect confidential patient information and undertake the analysis with NDRS. So that's separate, and that's a resource that the clinical labs can use immediately. So that's going to have immediate benefit for the laboratories doing the interpretation. The clinical cohort, or the ICC cohort, is really something different. It's kind of building a cohort that pulls in the clinical and the genetic data, and that would be for research purposes. So that's what's going into the trusted research environment. So they're kind of separate, but one can feed into the other if patients have consented.
Yeah. And because, I mean, Project 2 is highly ambitious.
Extremely ambitious.
And I would suggest that its success is going to be dependent on capturing most people in ICC clinics.
Yeah.
And how you do that, how you capture the hundreds and hundreds, thousands of patients that we see in real time in clinic is going to be really challenging.
Yeah. So
unless we've got cohorts of research teams going around doing all the work.
So this is something that Tom Lumbers is really coordinating at the moment and trying to map that out, work out what data is accessible, data that's accessible, how we can actually link that, because it is extremely ambitious. And I think really this initial funding, so it's for 5 years overall, but these initial projects are 2 years. It's almost trying to work out what can be done with the infrastructure as it is. So there's no defined research projects at the moment assigned for any of these cohorts. It is literally just, can we build this resource, because actually we need this large resource to be able to do the research more effectively, or the community needs to do.
Because I think a real risk is selection bias, and you'll be very tempted. You'll be subconsciously handpicking the interesting cases, the severe cases, the memorable cases, rather than the whole cohort.
Yeah.
And we found this with the EORP registry, the European Observational Research Project, something like that, EORP, which was selected patients from European centres, and what you ended up with was a highly selected group of patients from whom little meaningful conclusions can be drawn.
Yeah.
The other thing, I suppose, akin to the 100,000 genome project is, 100,000 genomes is an impressive number, but if you look at the number who've got long QT, it's far smaller than most published series of long QT. So you haven't actually taken, those numbers aren't sufficient to really advance scientific understanding. But yeah, I mean, if Project 2 can be solved, that'll be
and I think
transformative.
Obviously there is saturation in terms of projects and registries and pulling people in different directions. But I think the idea was that the focus was a point that we could actually capture patients who might want to contribute their data would be at that kind of genetic testing part of the process. But it's complicated, and the consent forms and the actually making sure it's informed consent, that's a really difficult thing to achieve as well. And also kind of having a more interactive e-consent process. So obviously the Heart Hive, which James has been involved with, we appreciate that in a clinic setting, people don't have the time to really go through a really thorough consent form and actually make sure that it's not just a tick box exercise for patients.
Good. Any other questions? No. Eleanor, one thing you mentioned was about a fall. You want to wait until the troponin's falling in myocarditis before you discharge. If the troponin's 10,000, that sort of will be self-evident, and most people will pick up on that. Are you also talking about the much smaller troponin rises that we see much more commonly, 200 or 300? Is it important there?
So again, it's one element of the overall clinical assessment. So it's one part of it. So if it's ideally, if everything is very much stable and the troponin is going in the right direction, that's fine. I think it's when the troponin is going up, then ideally not. If you can, I would always prefer to see the troponin irrespectively coming down. But with high sensitivity troponin, we are going to see higher markers. So again, it's got to be taken in the context of the clinical presentation and the severity of the phenotype that you're looking at. So if you've got significant LV dysfunction, then I would be more conservative and keep them in hospital to make sure things are really improving. If someone's got normal LV function and they've had no arrhythmia or any monitoring and their ECG looks fine, then again, I would be cautious with discharge them home, follow them up within a couple of weeks and make sure things are fine and improving in that regard.
And I mean, we as we all do, review imaging in MDTs, and you get that situation where if the adjudicating MRI doctor calls this as myocarditis, that can be, you can breathe a sigh of relief. Okay, he doesn't need gene testing, doesn't need family screening, discharge. You're suggesting otherwise. I suppose I'm trying to understand where in the patient pathway that decision gets made. A lot of these patients are presenting on acute takes. They're not going to be seen by a heart muscle doctor or an imaging doctor, often an interventionalist, and can go down a sort of Minoka pathway. I don't think they're going to be thinking about desmoplakin and vitamin C. But nor do I want them to refer them all to us, for us to debate it. So I can sort of see the logic in the pathway. I'm just not sure how.
No,
it works
so
in practice.
absolutely right. I mean, I think the referrals that should come to a specialist cardiomyopathy service are those with either recurrent symptoms, adverse phenotypes, high-risk markers, those with familial history. They're the ones that I would suggest that we would focus on. If you've got end organ dysfunction or arrhythmia, red flags. If you've got significant conduction disease, red flags. If you have severe LV dysfunction or RV dysfunction, they're red flags. But as I mentioned, at least 50% just normalize straight off. It's actually more like 60% of people normalize and recover from their condition. So the vast majority are going to recover straight away. The other element that sometimes we do, if someone's cardiac MRI scan, for example, looks very abnormal, if they have a cardiac MRI scan during their initial admission, then that sometimes will either engage a general cardiologist to follow up the patient and decide on whether they need something further doing, or at that stage, again, they may be referred to the cardiomyopathy service for onward follow-up and assessment.
Yeah. Okay, so recurrent symptoms.
I would say recurrent symptoms, significant end organ dysfunction, and the red flags.
Yeah, okay, brilliant. Okay, well, if there are no further questions, I think we are still ahead of schedule, but lunch is being prepared by the looks of things. So let's finish there, and we'll have a break, and we'll be back at 2:30. Yeah, brilliant.
Fantastic.
Thank you.
Stephen, these are Sam's.
Are they?
Yeah.
from Dan Hammersley, but I don't know whether it's on here. That's why I wanted to. Sorry.
No,
just
no,
to
no.
have
You
a
go
little
ahead.
look.
I just wanted to check mine was on there, and that's it.
Before we get cracking on the session, because so we haven't got Dan Hammersley's case on there yet. So if you can give us 2 seconds.
Okay. Do you want to make a seat, everyone? We'll get going for the next session.
Yours is there, Helen. Don't worry. It's in session 3. Well, maybe we'll get down to load it
Mine's
up
just on the
afterwards.
desktop. Sorry,
So,
Rachel.
no, that's all right.
I know. I just
yours is there,
expect
Helen.
that I put my presentation on.
So when you come out of Joye's, you'll see this.
Fine. Mine's that one.
It's that one, isn't it? The top one.
Yes,
So
I
it
won't
was
talk
the one
about
that was just-
cardio-oncology today.
It was the one that was just on the
Do you want to laugh?
on the desk.
You could do it.
On the desktop.
Like Joy and Helen.
And then we've got the first case. Oh, I can see Dan. I'm just going to get Dan to load his very quickly.
Yeah, sure.
You'll be getting me on Twitter
Oh,
next.
you're okay. Fine.
So I'll just open it and leave it there.
You can hear me well, I'm hoping. Welcome back, everyone. I hope you had something to eat, to drink, you're back refreshed and ready for an exciting session 3. We have a couple of great talks coming up, and it's all about exercise. I have the pleasure to introduce the first speaker, who I also know personally, and she is one of our greatest trainees. She is a trainee in Oxford John Radcliffe University Hospital, is Dr. Joy Basu, who has completed her PhD into novel insights into high-intensity exercise prescription in hypertrophic cardiomyopathy. She has won many prizes, with the latest being the BCS Best of the Best Abstract Award on 2 occasions, actually, I can recall. And we are looking forward to listen to her speaking about risks and benefits of exercise in patients with hypertrophic cardiomyopathy. And Joy, the lights on you.
Thank you very much for the kind introduction. So, as Dimitra said, I'm an AICC trainee in Oxford, and my research was predominantly on exercise and hypertrophic cardiomyopathy, so I'm hoping to take you through the risks and benefits of exercise in patients with hypertrophic cardiomyopathy. I have no conflicts of interest to declare. So I wanted to start with the history. Essentially, hypertrophic cardiomyopathy was considered to be the leading cause of sudden cardiac death.
accounting for about 36% of deaths in athletes. As a result, bodies recommended that individuals with hypertrophic cardiomyopathy should be restricted to low dynamic and low static sports. So specifically things like billiards, bowling, curling, golf, riflery. Cricket is debatable. And as a result, obviously, of a sedentary lifestyle, we now know that around 55% of individuals with hypertrophic cardiomyopathy actually fail to meet current exercise recommendations. A sedentary lifestyle also cultivates obesity, and we know from registry studies of up to 6,000 individuals that 70% are obese or pre-obese. And this also has effects on the phenotype, so people who are obese are more likely to have an obstructive phenotype, have atrial fibrillation, and actually poorer composite heart failure and hypertrophic cardiomyopathy outcomes. We know that a sedentary lifestyle also increases your cardiovascular risk, and this is no different in this cohort of patients, and not to mention the adverse psychological impact of being told that you can't exercise, particularly if you're used to engaging in high-intensity or competitive sport. There has, however, been a recent paradigm shift. So we have seen studies, autopsy studies of individuals with sudden cardiac death, so athletes predominantly, and sudden arrhythmic death syndrome accounted for 42% of those deaths in a study that was performed at St. George's in 357 individuals, and hypertrophic cardiomyopathy, as you can see, accounted for only 6%. Clinical phenotyping studies in athletes have also shown that individuals with hypertrophic cardiomyopathy who are athletic have better diastolic indices, they have greater left ventricular end diastolic dimensions, less issues with blunted response of blood pressure to exercise, less left ventricular outflow tract obstruction, and less severe hypertrophy. You might say that actually this may not just be that exercise is good for you, but that they have a clinical phenotype that enables them to exercise. Either way, there are individuals with hypertrophic cardiomyopathy who can compete at high level. And there have been some studies in mice, although this has not been reproduced as far as I'm aware, where mice with hypertrophic cardiomyopathy were exercised at 2 months or 6 months, and they found that there was reversal of myocardial disarray and fibrosis in the mice that started exercising at 2 months, and only reversal of myocardial disarray in those that started exercising at 6 months, suggesting that if you start exercising early enough, you may potentially reverse some of the, or not have some of the adverse cardiac remodeling that you see later in life. So one of the first studies looking at exercise was the RESET-HCM study. So this was a randomized control study, and what they looked at was individuals who were sort of middle-aged, mean age of 50 years, and they were randomized to 16 weeks of home-based exercise or usual activity. In the first week, they had several sessions at 60% of their heart rate reserve at a Borg rating, which is where you set a sort of subjective idea of exercise of 11 to 14. And then this gradually progressed from weeks 2 to 4 to 70% of the heart rate reserve. And then weeks 5 to 16 were essentially maintenance of this. So what they found was that those in the exercise group increased their exercise capacity in terms of their peak METs performed. There was a 6% absolute increase in peak VO2 and a between-group difference of 1.27 mils per kilogram per minute. And they actually also showed improved physical functioning. Unfortunately, they didn't demonstrate any benefits in the depressive symptomatology self-report scales or the Minnesota Living with Heart Failure questionnaires, but as you would expect, when you're exercising more, you might have this more of this response. There was no adverse event, specifically no death, cardiac arrest, or ICD therapy discharge, even though 30% had an ICD and 4% had a prior history of sustained ventricular tachycardia or aborted sudden cardiac arrest. And they also showed a reduction in the PVC burden. And importantly, in this table, you can see the differences in non-fatal arrhythmias between the exercise and the non-exercise group, and there wasn't actually a significant difference. There have also been some observational studies in athletes. I'll start with the study on the left, which is an Italian study of 88 athletes with hypertrophic cardiomyopathy. So they had a median of age of about 31 years. Vast majority were male and white, and most of them were low risk according to the ESC sudden cardiac death risk score. 61 gave up sport, 27 continued to engage in regular competition. And after 7 years of follow-up, there were 2 episodes of sudden cardiac arrest. One was in a novice boxer who'd had a myectomy, and the other who was in an amateur tennis player who was walking around a shopping centre. So these were those that had not continued to exercise competitively. So that equated to an event rate of 0.3% per year. And there were no difference in these events or symptoms between the groups. In our study of 53 athletes with hypertrophic cardiomyopathy, so this was a slightly larger study compared to the 27 who continue to compete. Again, not hugely ethnically diverse, but we did have a little bit more ethnic diversity. 72% this time were white, again, majority male, with 100% with a low ESC, sudden cardiac death risk score. And after 4.5 years of follow-up, we found that there were no deaths, sustained ventricular tachycardia, or syncope. So if you imagine that the event rate is averaged 0.5 to 1% per year, you'd expect between 1.2 to 2.4 sudden cardiac death events in this group, and we did not show that. Obviously, it's a small study, and I appreciate that you cannot extrapolate that, but it was an interesting finding. And we also looked at the ECG, the echo, and the CPET, and we saw, when we compared at baseline and their last clinic appointment, that there was no difference in the electrical, structural, or functional phenotypes between athletes. There have been some interesting studies in ICDs as well. So in this study, there were 440 athletes who were followed up for 44 months. Long QT made up 87, hypertrophic cardiomyopathy 75, and ARVC 55% of the participants. There were no deaths related to arrhythmia, no aborted sudden cardiac death, and no injury following syncope or shock during exercise. And the interesting fact here was that ARVC was the only condition that actually had an increased rate of shocks. I think about 15% of those individuals had shocks, and hypertrophic cardiomyopathy only 2%. The thing that I should add here is that it was obviously a study that people could be recruited into, so maybe those who had already had shocks or adverse events didn't actually take part. People may not have wanted to disclose they'd had a shock, because obviously that would affect whether they were able to compete. Anti-tachycardia pacing was not actually documented, so we don't know whether they did have some form of therapy. And again, we can't really extrapolate these findings to impaired cardiac function and to high-impact contact sports. So this was a study that I did at St. George's, the SAFE HCM study. So this was the first study looking at high-intensity exercise in a randomized controlled feasibility study. So we had 40 patients in each arm of a high-intensity exercise group, which was up to 85% of the heart rate reserve or usual care. And as you can see in the diagram where usual care is on the left and exercise is on the right, there was a greater change in total exercise time, peak VO2, the VO2 at the anaerobic threshold, and also the time to the anaerobic threshold, suggesting greater improvement in exercise capacity overall in the exercise group. Similarly, we saw some reduction in risk factors, so systolic blood pressure and BMI, and we also showed some clinically meaningful changes in the anxiety and depression scores on the hospital anxiety and depression scale. Again, we didn't show much in terms of the short form 36 questionnaire or the World Health Organization Disability Assessment Scale 2. And I suspect that it may be similar to the RESET HCM study, where these weren't actually questionnaires that were designed for patients with hypertrophic cardiomyopathy. And I know there is now the hypertrophic cardiomyopathy symptom questionnaire, so that might be something that we could use going forward. Importantly, there was no increase in arrhythmias between groups. There was safety profile, albeit in 40 patients, suggested no increased signal of risk. The live HCM study was the first prospective study of 1,660 patients with hypertrophic cardiomyopathy. This was conducted in 42 centres, a really impressive study. Individuals were recruited if they were between 8 to 60 years, and they were followed up for a mean of 38 months. And they self-reported their physical activity. So they defined vigorous activity as greater than one activity, equating to greater than 6 METs for greater than 60 hours per year. And competitive was just that, but done competitively. Moderate was greater than one activity of 4 to 5.9 METs for greater than 60 hours per year, and sedentary was everybody else. And they looked at a composite outcome of death, sudden cardiac arrest, arrhythmic syncope, and appropriate ICD shocks. I don't know if this is projecting particularly well, but it was the probability of not experiencing the composite outcome. You can see there's no difference between what they divided into the vigorous and non-vigorous groups, and I think 4.6% reached the composite endpoint with no difference between the two groups. And in a sub-analysis, they also showed there was no difference in arrhythmic risk between the two groups. And you can see the breakdowns of who experienced the composite endpoint in the table at the bottom. Although I have done all of my research into exercise and hypertrophic cardiomyopathy, we do have to be careful about what we say to our patients. We know that one size does not fit all, and Helen will probably go on to reiterate this. But in a study in a paper by Dresner et al., there was this nice table which basically illustrates that there are some groups that may be more at risk than others. So, for example, if you look at Black individuals, their annual risk of sudden cardiac death is about 6.6%, so that's a lot higher than we would expect. And similarly, there are other sports, for example, basketball, American football, and football, where we see this as well. So when we're prescribing exercise for patients, we might need to think about things like what sport are they actually participating in. And maybe we need to think about their age as well. So this study from the New England Journal of Medicine showed that adolescent athletes, I think there were 11,000 that were screened. They found 2 with hypertrophic cardiomyopathy who continued to exercise. 1, unfortunately, did not show a phenotype at the time of screening and then also went on to die. So there were 3 deaths in this group of 8 with hypertrophic cardiomyopathy. So maybe there is some risk that if you develop this at a young age, you're more at risk. And the other interesting study that I've put in below is in about 400 individuals who unfortunately died, and a molecular autopsy was performed on them. Of the 45 people included in the study, there were 41 pathogenic or likely pathogenic variants found, and predominantly this was in genes that can cause hypertrophic cardiomyopathy. Whether that was incidental or a risk factor still remains to be seen, as there are other studies that suggest the opposite, but it might be that if people have a genetic predisposition to hypertrophic cardiomyopathy, they may be at higher risk. So I just wanted to take you through a kind of overview of how you might assess a patient when you're talking about exercise. So history and examination is key. Symptoms, if they've had syncope, if they've had any exercise-related symptoms, that's very important. Family history of sudden cardiac death for your risk score. Echocardiogram, how thick is the wall, the left atrial size, the LVOT gradient at rest, and certainly at Valsalva, and if they're having symptoms during exercise, maybe even do an exercise stress echo. I think an exercise test, or ideally a cardiopulmonary exercise test, and I know not everyone has availability, is essential. This assesses their hemodynamic response, looks for whether they develop any arrhythmias, and looks at their functional capacity, which we'll go on to talk to you about why it's important for exercise prescription. And then for a Holter monitor, I would encourage everyone to tell their patients to exercise with the Holter monitor on, because if they're just sitting around doing nothing, you're not going to get any indication of whether they are at risk during exercise. And then a cardiac MRI is obviously very useful for fibrosis, and whether they have any signs of ischemia, if that's a suspicion. So in terms of risk assessment, basically, this is the HCM sudden cardiac death risk score. It actually says at the bottom to not use in athletes, but the reason I'm putting it here is because I think it does give you an idea about their general clinical risk. So I think it is useful to perform this, and actually in the guidelines they suggest that you should do this as well. So I think most of us are quite familiar with it, but essentially it gives you a 5-year risk of sudden cardiac death, with greater than 6 being high risk. And I think the thing that we sometimes forget about is shared decision-making. I think we as clinicians feel like all the pressure is on us to make the decision for the patient, but I think we should take into account what the patient actually wants. And once we've provided them with the information, they can then make a decision on risk, and we can say, actually, we don't think you want to do it, but they may want to go ahead and do it. So there is an element of personal choice in all of this. And I think obviously that is balanced against safety. And then if you're thinking about an athlete, you need to think about other stakeholders. So are there club physicians, club coaches, are there lawyers, are there family members, bringing everyone together and having a conversation about, exercise and what the risks are, so everybody knows where they are. So what do the guidelines say? So the ESC guidelines were published in 2020. So markers of increased risk, as I mentioned, was symptoms and past medical history of concerning symptoms, an elevated ESC risk score, left ventricular outflow tract gradient, so greater than 30, we're saying greater than 50, you're unlikely not to have symptoms, an abnormal blood pressure response to exercise, and then exercise-induced arrhythmias. If you don't have any of them, theoretically, you can exercise. And then if you have any one of those, then it becomes more of a grey area and therefore more tricky to prescribe. And that really needs to be down to a clinician-patient discussion. So what do you do once you've had that conversation? I think the important thing is to make sure that you monitor patients regularly, you tell them to report their symptoms. And I think when I say patients monitoring regularly, what do I mean? Maybe you want to see the younger patients a bit more frequently, the people that you think are more at risk, they're doing more risky sports, that kind of thing. Tell them it's really important to hydrate, and that if they're exercising on hot days or they're unwell, that they should replace their electrolytes. Advise against the use of supplements and substances to enhance physical performance. And then the other thing that's quite important, particularly if they are kind of elite athletes, but for everyone, but they're more likely to have this as an option, is an emergency response plan. So personnel that know exactly what their job is, an AED nearby, a way to communicate, and then practice this and review whether it works. So the final thing I want to talk about is just a basic approach to exercise prescriptions. Helen will probably go into this a little bit more detail, but the important thing is to think about this FIT principle, where you have a frequency of exercise, intensity, so mild, moderate, or high intensity, time and type. So the WHO recommendations is 150 minutes of moderate intensity or 75 minutes of vigorous intensity and strength of at least 2 days per week. So when you prescribe exercise, you say, I want you to do this amount of aerobic, this amount of strength training, number of days per week. Give them however many minutes you would recommend. In terms of the intensity of strength training, 1 RM is basically the maximum amount of weight that you can lift through a range of motion with 1 repetition. So 20% is usually aerobic. And after that, you get compression of the muscle capillary, so it becomes anaerobic. And after that, you need to sort of think about what sport they're doing, again, taking into account the high-risk sports, and then make sure that you have a review date for them as well. So on that note, that's everything that I have to tell you about exercise and hypertrophic cardiomyopathy, and I'm happy to take questions at the end. Thank you very much for your attention.
What a wonderful talk. Thank you very much indeed. But table tennis is quite strenuous at times. That's the only thing I'd have to say. Good. So we'll take questions at the end. So we'll move on to the next talk. So great pleasure to welcome Helen Alexander, who's a senior physiotherapist, been involved for many years with exercise in cardiovascular patients, and she's the senior lead at Nuffield Health for cardiac rehab and all things exercise related. So thank you very much, Helen.
Thank you so much, Jerry. Yes, I'm based here in the City of London. I work at Nuffield Health, our newest hospital, right next door to NHS Barts, hence why people do get our two hospitals confused. I lead a team, but the majority of my clinical work is working with people with all kinds of heart disease and helping them get more active, and that includes those with cardiomyopathy. What I really want to do today is to send you away feeling really equipped to answer all those questions people ask you about exercise. I'm well aware that isn't the first thing they come to clinic wanting to know. They want their diagnosis, devices, genetics, but it's often as they leave the room, isn't it? Oh, but can I exercise? So I just want you to feel equipped with some really practical advice about steering your patients towards safe and effective exercise. I'm well aware the patients you see will vary hugely in their activity levels. So you'll have some people who've been extremely active in the past, and you actually want to get them to reduce their activity levels to keep them safe. And then you'll have those people who you'll actually want to be encouraging to be more active to benefit their health. You'll have some who are very limited in their exercise capacity because of all sorts of health problems, and people who are completely unlimited. But they'll all come to you with the same questions about exercise. What is safe? And how do I get all the benefits without any of the risks? So exercise encompasses different modes of moving our body, doesn't it? We've got our aerobic, resistance, now balance and flexibility. Almost all of the guidelines talk just about aerobic exercise. That's the complete focus. But I don't think we should neglect the benefits of the other forms of exercise, particularly for our lowest functioning patients. So I'm going to start with the guidance around aerobic exercise, but I'm going to come back to the other modes. So when we talk about exercise, we talk about different intensities. You'll see here we've got light, moderate, high, or vigorous. So a light intensity exercise is that which doesn't really challenge us too much. It's not strenuous, and we can actually do it without feeling too breathless or too warm. That's the majority of our everyday activities. Moderate intensity makes us warm and comfortably breathless. And that's a really good term to use with patients when you're trying to describe moderate intensity exercise. Comfortably breathless. You feel your breath, but you're comfortable to carry on. And this infographic reminds us that if we don't even complete light intensity exercise, then we'd be considered sedentary. And we'd encourage all adults to not be seated for more than 50% of their waking hours, a goal that most of us will fail hugely today. So how do we define these different exercise intensities? Well, using heart rates, the easiest calculation we turn to is probably a percentage of heart rate maximum. If we have the luxury of doing a CPET, then we know their true maximum. For most patients, we're doing a 220 minus age, which we know brings with it a degree of error. And then we've got the effect of beta blockers as well. A little more accurate is our Carvonen calculation. So that enables us to calculate a heart rate reserve, and that takes into account not only their age, but their resting heart rate. And you'll see that percentage of heart rate reserve equates quite nicely to percentage of VO2 max. Once someone has become accustomed to exercise, then we know that using perceived exertion, which is quantified there with your RPE scale, rate of perceived exertion, that's your 6 to 20. There is also a 0 to 10, and both are validated for cardiac populations. So once someone becomes accustomed, we know that it's an incredibly accurate way to monitor exercise. We should be aware it's subjective, and it takes time to get familiar with feelings of exertion. But once patients are really comfortable with knowing how their body feels about exercise, I'll take away the heart rate monitor and just get them using those feelings. Because then when they're away from me, they're going for a walk around the park, they can accurately monitor the intensity of the exercise without looking at the numbers. So which intensities would we recommend for our patients with cardiomyopathy? Well, as Joy's very eloquently described to us, historically, because understandably we were so worried about fatal arrhythmias, we've had this blanket approach of all cardiomyopathy patients only being allowed to do low to moderate exercise. However, we know now that that's not appropriate. We shouldn't be having a blanket one-size-fits-all conversation. What are the concerns about quite conservative exercise? Well, you can see them here. And actually, Joy and I didn't compare our slides before we came. So I think the fact that our stats are the same gives us extra confidence that these are correct stats here. But we know that actually, we've actually caused a generation of patients to become sedentary, to have hypertension, and to be obese. And actually, they've now got a worse health prognosis because of an increased risk of cardiovascular disease and diabetes. So more recent guidance from ESC, starting in 2020 with the sports cardiology guidelines, and then more recently the 2023 guidance, which is in agreement with the American guidance, has a more liberal approach for some groups. So it encourages shared decision-making, individualized risk stratification, and importantly, regular review. So the advice we're giving someone isn't a one-time decision. It's a regular review so that if those markers of risk change over time, so does the activity guidance. So we'll see here that the guidelines recommend that all able individuals with cardiomyopathy would be encouraged to do regular low to moderate intensity exercise, but we only want that to follow an individualized risk assessment. And Joy's already showed you about what that individualized risk assessment should look for. For these groups, we're more concerned, we're going to be more conservative. I won't spend too long going over hypertrophic because we've already heard really comprehensively what we should be doing with these patients. It's the group that we do know the most about. We've got quite a wide range of research studies looking at hypertrophic cardiomyopathy. And we know for those with no markers of increased risk, we can safely recommend that they can participate in high intensity or even competitive sport. However, those with markers of increased risk, we'd be advising them to stay with low to moderate intensity exercise. For those who are gene positive but phenotype negative, we don't actually place any physical activity restrictions on that group, but we do want them having annual review to make sure nothing has changed. What about those with dilated cardiomyopathy? Well, we know as long as they don't have symptoms or arrhythmia on exercise, that they should be advised to participate in low to moderate intensity exercise, regardless of ejection fraction. And I'm sure you'll be aware there's very poor correlation between ejection fraction and functional capacity. And we shouldn't make advice around exercise based on ejection fraction alone. Participation in higher intensity exercise can only be recommended if the patients are asymptomatic, if their ejection fraction is over 45, and they've got no other markers of increased risk. Again, those who are genotype positive but phenotype negative can consider participating in higher intensity sport, with the exception of those with higher risk variants. Now, the exercise recommendations for those with arrhythmogenic cardiomyopathy are more conservative than any other group. We know that regular and high-intensity exercise is associated with acceleration of the disease process and worse outcomes. So those who continue to participate in exercise, particularly with those sports with large volumes, so endurance exercise or very high intensities, tend to see a greater acceleration of their disease process and a higher rate of arrhythmias. We know that in those with this condition, initiating sport at a very early age is associated with a younger onset of symptoms, and that by reducing exercise intensity, they have a substantial decrease in the risk of arrhythmias and sudden cardiac death. Now, for anyone who's been very active in the past and then diagnosed with arrhythmogenic cardiomyopathy, to be told to significantly reduce your exercise levels is incredibly challenging. If sport is a large part of your life, your identity, or possibly even your career, to be told to then limit your activity is a very large adjustment and a profound psychological impact. And this group do need specialised counselling. They need support by qualified exercise professionals to find a route towards an activity level that's safe and appropriate for them. You'll see that even those who are genotype positive and phenotype negative would be asked to refrain from engaging in high-intensity exercise. And in fact, the upper limit for exercise for all those with arrhythmogenic cardiomyopathy would be around 6 METs, which is a brisk walk at most. For those who restrict both the volume and intensity of exercise, we see the least progression of disease. You'll see, as well as annual follow-up, we also want those who are younger and those with high-risk genotypes having more frequent follow-up. So let's think about what we can do to make exercise safe as possible for all of our patients. Well, to look at this, I first want to just consider the physiology of what happens when we exercise. Why is exercise so demanding hemodynamically, electrically? Well, if we start on the right side of this slide, you'll see the normal physiological processes that occur when we exercise. So we get a surge of adrenaline, we get an increase in sympathetic activity that increases our heart rate and blood pressure. For most of us, our body copes with this and responds really well. But if we have any sort of heart muscle disease, the potential for ischemia and myocardial irritability leading to ectopic activity is increased. On the other side of the slide, you'll see what happens when we stop exercise suddenly. So we get a sudden drop in venous return, which leads to a drop in cardiac output and blood pressure. And that fall in venous return and all of those changes that happen following that can give rise to electronic disturbance. And I'm sure you'll appreciate in our patients who might have stiff or enlarged hearts, those responses are going to be even poorer. So how can we negate some of this risk? Well, the warm-up section of exercise, going into exercise gradually, really helps to ensure that that rise in blood pressure and heart rate happens more gradually. And that means the myocardium is far less likely to become irritable or ischemic. And by ensuring our highest risk patients remain at moderate intensity exercise, we're making exercise safer. The cool down is probably the most important part of exercise to get right for these patients. So by allowing the adrenaline that's been created during exercise to get reabsorbed gradually, we're significantly reducing the chance of that irritability. And then by keeping the feet moving when we're active, particularly maybe when transitioning between exercises, we again maintain blood pressure rather than seeing these peaks and troughs. So it's really important when we're encouraging patients to warm up and cool down, we find a way of articulating this in language they can understand, so they know why they're doing it. So we've talked about warm up and cool down. What else can we do? Well, with our highest risk patients, we might have a start low, go slow. So start with low intensity exercise if they're very inactive or they've got low functional capacity, and just build up slowly, build gradually. You'll allow the body to adapt to that activity over time. We want, of course, for them to be mindful of any symptoms and stop if they feel unwell. Sudden changes in position present significant hemodynamic challenge to the body, and we would recommend that for most of our patients, they avoid that. We love you, Joe Wicks, for everything you did for us during the pandemic, but you taught our nation to do burpees. It's just not good. You also taught us to go into exercise, go now, no warm-up, no cool-down. So if my patients ask me, can I do Joe Wicks? I say yes, but do a warm-up first, then press start, do a cool-down at the end, and just avoid those burpees. Sudden intense sprints as well don't allow for warm-up and might present more risk than benefit. And it's interesting, isn't it, in our previous presentation, those high-risk sports, basketball, football, they're often the sports with the sudden, intense sprints of exercise, and that's what our body can find the most challenging. What about heart failure? Not all our patients with cardiomyopathy have heart failure, but some do. And what are the extra considerations for those? I've said already, with our lowest functioning patients, we're just going to be more cautious with our initial exercise prescription and more cautious with our progression. Resistance exercise is often a really good way in with our lowest functioning patients. And I often start with that. I help them get their muscles strong first, which then gives them more capability to do aerobic exercise. We, of course, would want all of our patients who are at risk of decompensation monitoring their fluid balance, daily weights, and if they arrive overloaded, more breathless, fatigued, swollen ankles, that's not the day to be exercising. I said I'd come back to resistance exercise. All adults should be doing some resistance exercise of some kind 2 to 3 days a week. And I think it's the bit of exercise that actually gets neglected, and it's the bit that can give our patients almost the most benefit. Despite popular opinion, resistance exercise, when it's taught well and performed with ranges of 8 to 15 reps, so no powerlifting, can actually be completed at a lower rate pressure product, lower heart rates, lower blood pressures. So it's actually really safe for some of our patients that we'd only advise the low to moderate intensity exercise. And let's not underestimate the benefits of things like balance and flexibility work, Tai Chi, yoga. Some of those might need to be adapted to avoid the head down, downward dogs, or the sudden changes in position. But these forms of exercise are often initially more accessible and more acceptable to some of our patients than other styles of exercise. So cardiac rehabilitation is a holistic program of exercise and support to help people make healthy lifestyle changes. You all know that it's widely offered to people who have had heart surgery and had heart attacks, and we know that patients with heart failure and cardiomyopathy get less access. Currently in the UK, only 10% of those with a diagnosis of heart failure get referred to cardiac rehabilitation, That's a shocking statistic. It should be a lot higher. I and many others are working to try and improve that referral rate. We know also that those who have an ICD should be eligible for cardiac rehabilitation. But I feel quite strongly that all those with a diagnosis of cardiomyopathy may benefit from some structured exercise and lifestyle support. This QR code takes you to a program finder, so you can put your patient's postcode in and find out where their nearest cardiac rehab program is. And I'd encourage you to reach out to your local rehab program, ask if they accept patients with cardiomyopathy. If they don't, maybe explore ways in which you could support them too. Sometimes it is commissioning and funding issues, sometimes it's just around staff confidence. Most programs will offer acceptance of self-referral, so it doesn't always have to be a clinical referral. Gold standard cardiac rehabilitation is multidisciplinary, so that the patient has the very best of a dietitian, a psychologist, an exercise physiologist. So I really would encourage you to reach out, find out more about your local service. And that's all from me. Thank you.
Great, well, thank you very much. Wonderful talk. Just while people are thinking of questions, just the WHO exercise limits, sort of 120, 50 minutes a week, how many in the room actually follow that? Do you want to put your hands up if you actually do that?
It's not many, is it?
Well, it's more than I thought, actually, because it's quite a lot in a busy week, isn't it? So we're asking our patients to do that. It's quite an ask. Okay, so maybe pop your hand up if you've got any questions in the audience. Great, well, I think we've got a mic, haven't we? There's one just at the back there.
This might not be a very easy question to answer, but do you have any tips on unpicking the patient that's got a Fitbit or a bunch of Strava workouts that they want you to help you, help the patient get into heart rate zones, or when they're obsessed with the numbers? Because you talked a lot about things like how they feel and Borg scales in terms of perceived exercise. Is there any way to guide us on those sorts of patients?
Yeah, I think heart rate monitoring is a really helpful tool for a couple of different groups. For patients that are really anxious, I think heart rate zones, when they're calculated for an individual, can be really helpful in reassuring them they're exercising at a safe level. So I think it has to be individualised. I don't like this sort of blanket, just don't go above 130. I think we've got to consider the patient's individual resting heart rate, age, beta blockers. But if you've been able to give a patient a specified heart rate zone, that can be really reassuring. It can also help those patients who have a tendency to overdo it to bring themselves down. Some patients find monitoring heart rate long-term really helpful. If they don't find it a hindrance, if they don't find it makes them anxious, I encourage it, absolutely. And so many of my patients have their own devices already. But for those who don't, I say to them there's no need to go out and buy one. Let's spend a couple of weeks you getting really familiar with how your body feels when you're exercising at moderate intensity, and then you won't need a device going forwards, if that makes sense. But patients who are unfamiliar with exercise, who aren't regular exercisers, will not know how that feels. Every patient I see, I do a functional capacity test, submaximal, a step test or a walking test, and I get them up to about 70% of their heart rate reserve, sometimes 80 if they're lower risk. And during the test, I show them how it feels when they're exercising at moderate intensity. That feeling right now, feeling comfortably breathless but able to carry on, that's how I want you feeling. And very often they say, oh, that's way more than I do when I go for a walk. Yep, so they haven't ever got to a moderate intensity rate pace. So I think there's benefit in both.
Anything to add?
I think you've covered what I was going to say about the fact that a lot of patients do, and what you just said, a lot of patients do come to you with these Fitbits and Garmins and all sorts of stuff. So if we can actually find a way to utilise them to both of our kind of benefit, then I think that's great. I think the difficulty comes then when you get sent 1 million downloads that you can't interpret. And so in those situations, I tend to say, if you can get something like the Alive Core that is going to or the Apple Watch actually is very good at the moment. So things like that, I'd say, are more useful if we actually need to look for arrhythmia, but yeah.
Be aware that in someone with atrial fibrillation or lots of ectopics, the heart rate monitoring is less reliable and can actually end up being very unhelpful because you can get some pretty high numbers that scare the patient. So if they're in atrial fibrillation, I don't use a heart rate monitor. I just go on RPE, but therefore they need to be really good at monitoring their own exertion levels.
So I think that was an extremely important question in the clinical setting, because if we have a very good physiologist, rehabilitation center, etc., that's a great answer actually. But in the clinic, when you see an athlete or a patient/athlete or a patient who is asking for an advice on that, yes, if someone is lucky enough to have or wants to buy a watch or any of those monitors, that's fine. You can use roughly this estimation and asking kindly not to be obsessed with that. If they go 10% down or 10% up, that's fine. But actually the modified RPE or the Borg scale is quite practical and is a good advice to give in the clinic. Also, I sometimes give them the cards and I say, you know, probably the easiest one is asking them when they do the exercise to be able to keep a full conversation, for example. And that's a rule of thumb that they can use and they can follow, and it's reliable at the end of the day. But if you want to be more accurate, if you want to be by the book, then probably the best test is a CPET, a rehabilitation center, which of course the problem is that financially is not always covered. If someone does not have a severe disease or hasn't suffered any condition that can be covered, actually it's a difficult thing to obtain and needs money also. So if you do have something that you can send them for a CPET, then they can get this advice through the CPET, the VO2 max, and then they can learn how to train according to how they feel during this tailored training, basically. And they can use parallel the scales, the Borg scale, the modified RPE, and they can both train, okay, towards a specific level or up to a specific level, but also they can be detrained, okay? Let's not forget that rehabilitation is not only about training and retraining, it's also about detraining in a way which is tailored, gradual. And as we know, an athlete is obsessed with the exercise. And if you say to someone, okay, you need to actually go to mild exercise now, they will probably not visit you again, and this is going to be very risky. So you have to teach them and ask them how to do that with the psychological support, with supervision, etc. So thanks for this question. And also congratulations for both talks. They were great, amazing, and very triggering. So any other questions?
Thanks. Yeah, really brilliant talks. Thank you both. So I think I agree with what you've shown, that 70% of our patients are obese. They aren't actively seeking out exercise advice in the way you might see people, and they're not athletes. So you've shown really compelling data about how much VO2 max improves, and actually it's double, you know, what these drugs that we're receiving can do. So how can we motivate our patients that exercise is good and how to prescribe it? Because I think that's a real challenge clinically.
I think one thing that I've found is that we don't actually talk about exercise with our patients always. You know, we're in a busy clinic. A lot of the time it's about other things, about medication, about family screening, all of those things which are extremely important. And this sort of falls by the wayside. So I think sometimes just having the conversation and bringing it up and saying, how much exercise are you doing? And you know, and also the other thing along with that, which you point out about the obesity, is offering strategies for weight loss. I know with, you know, semaglutide on the horizon for everyone, potentially, eventually, that's going to be really helpful. But I think exercise just across the board is something that is free, and we should be encouraging our patients to do so. So I think actually having the conversations in the first place for a lot of people makes a difference, and reiterating that at every clinic appointment, because I think incentivizing people to exercise is very difficult, but I think once it becomes habit, that's when it becomes easier. And I think it's about supporting the patient to say, okay, since we last spoke, how have you been doing? How can we help you with that? Maybe thinking about ways that they could exercise, you know, can you walk to work? Can you cycle to work? Can you leave work a little bit early on some days? Do you take a lunch break? Can you fit things in? Can you stand up at your desk? You know, that it doesn't always have to be go and do a HIIT session. So I think it's about helping them facilitate and allowing them to kind of realize that actually exercise doesn't have to be, I have to go to the gym for 45 minutes and get sweaty. It can actually just be a brisk walk with your dog or something like that. So I think it's about making it more manageable for them to think about exercise.
Yeah, I think it's acknowledging that any behaviour change is really hard, and that's why a lot of people haven't done it. I think for people that are very inactive, that would be in the sedentary box, I start by just encouraging them to make some activity throughout their week. So I wouldn't even mention 150 minutes because it's completely unachievable for a lot of people. But I would start with, when can you use the stairs instead of the lift? When can you begin to do some of your commuting by walking rather than driving? When can you begin to build in a bit of activity into your day? Make that a habit. Doesn't it take 3 weeks to make a new habit? And then you've made it for life. So make something a habit for 3 weeks and then build on that. And show them that when they are more active, they have a bit more energy, they feel a bit better, and then build on that. Choose something you enjoy doing. Choose something that practically you can fit into your busy life. Our patients are as busy as we are. They have children, they have jobs, they have things they need to do. So it's difficult to build in exercise. So try and make it easy for yourself by building in exercise that works for you. And get on a structured program. A lot of us really struggle on our own. So if you can do something supervised initially so that you feel safe exercising on your own, that can be really helpful.
Right, thank you. Actually, should we go to the back first as they've got the microphone? Then we'll come to you, Catherine.
Sorry, I stole the microphone. So this is a question about trying to help our young people and who want to exercise and want to exercise in their clubs and schools. And we want to give them advice about how to do that safely, and with the shared decision making, allow them a more permissive, sporty lifestyle. But how do we support them to give that information to their schools and clubs so they do it in as safe a way as possible without the school and club immediately going, don't want anything to do with this?
I think ideally having them in the conversation, but that's not always practical in a clinic setting. I think having a clinic letter that very clearly depicts, you know, what the situation is and is very prescriptive about what they're allowed to and not allowed to do, the symptoms and things that you have to look out for. And I think ideally in a school setting, you know, could they purchase an AED? Could they have some way to sort of make this a safer environment? And I appreciate that's not always possible, but these are the kind of things that we would explore with clubs and things like that to facilitate that. But I appreciate what you're saying. It's very difficult to get that information, but actually writing a document that covers as much of that as possible, I think is very helpful, because a lot of people, and as Helen was alluding to, even people who prescribe exercise, our cardiac rehabilitation instructors, are very nervous about ICCs because we don't have the information. And there are going to be edge cases, and there are going to be people who are totally well and have absolutely no risk factors, and they die suddenly on a football pitch. I mean, we're never going to get it completely right. And I think if you are honest and upfront about that, and then saying these are all the things that we're going to do to mitigate it, I think that's personally what I would do. I don't know if Jerry or...
I think you've maybe uncovered a need for some published resources that make these guidelines make sense to sports coaches. You know, the CSE guidance, they won't understand. It's in jargon they won't know. But maybe we should produce something that is readily accessible for people who have got a sports background, who want to understand how to help these people be safe.
Helen and I have been in talks about some things, so some things are up our sleeves, so hopefully we'll be able to do something about this.
That's a good idea.
So thank you for those talks. They were both great. It was a question for Helen. It's along the same kind of lines. I just wondered, I mean, you work with adults, but I wondered what resources are available for children. And you were talking about the difficulty in conveying what adults should do in exercise. And of course, that might be even more challenging with children. So I just wondered if you knew of any resources or people working in that area.
Yeah, I really don't think there is much, actually. Earlier today, I was in the upstairs room learning about the conversations healthcare professionals have with children who need ICDs, and it uncovered a whole world I hadn't even considered because I'd never worked with children. But I think probably we do need to produce something that makes sense to children and their families around sport and exercise. So, yeah, give us some time and we'll see what we can do.
Great. And just on, while we're waiting, just on a similar lines, shared decision-making, patients, what are the sort of resources out there for patients to read around and understand?
I would direct people to Cardiomyopathy UK for some of their resources. They've got a couple of really good patient-friendly leaflets around exercise and cardiomyopathy that are very, very helpful. Cardiomyopathy UK have a national conference each year that's directed at patients. Now, unfortunately for you, it was last weekend, so you've got another year to wait, but I would encourage patients to watch back the presentations that are all on YouTube because they're very patient accessible. But I think we need to do more, don't we, to create resources that make sense to patients around this topic.
You always need a sort of separate pamphlet with their clinic letter, don't you, that goes into a bit of personalised detail.
I think there are some resources also from the British rehabilitation community, the society. They have some nice instructions, some videos there that are quite enlightening. So I agree about the children also, just to go back. I think appropriate communication, written notes, and informing the school basically, and emergency planning is the matrix of safe exercise. But we have to remember also, in general, the cohorts we have are not large. Imagine that even for the children, the athletes, the children who are athletes, the ECG guidelines, the international current ECG guidelines, not the guidelines, the position papers are not tailored to children, and we don't really have a lot of evidence on the children ECG on athletes. So you have to bear in mind that. But also, there was a question about how you prescribe exercise. Again, we have a long way to have exercise tailored to ethnicity, to the age groups. We do know that the female gender is underrepresented in all cohorts. We always need to keep in mind that what we see on a condition or disease, it's a snapshot, and therefore follow-ups and appropriate space between the follow-ups is also very, very important. And the other thing we don't know is the timing of detraining, I guess, and the level of detraining, the safe level of detraining. But we do have, for this reason, some guidelines there. So there is a long way on exact exercise prescription. But again, I will remain on CPET is probably the best way to tailor the exercise prescription.
Yeah, thank you. Els, did you want to?
Oh, I was just going to make a comment about, again, the signposting element, because the one thing we struggle with in clinic is having time to discuss all of these elements. So again, signposting, having an automatic caption at the bottom of your clinic letter, or a QR code, for example, that can redirect them directly. I mean, I know Cardiomyopathy UK provided that for us in our clinic, and it's super helpful. And even some of the, again, one of the things that we've adopted is, for example, QR codes for use for patients who you're referring for a device or an angiogram. So again, you can just insert it automatically into your clinic letter, and the patient, when they receive it, then can watch the video that's being created by David Wald. Actually, I think it was one of the things he's created from Bart's, a lot of different video animations to help support patients in general. It's just another way of trying to automate something and signpost in a more efficient way, I would say.
And actually, there's lots of different places doing good things locally. I wonder if we could share the learning on the website, do you think? Is that possible? Elsa's done a fantastic job with our website, so it's just an extra bit of work for her. But Brilliant. Okay, so we've got to keep going because we've got to wait for the other room to finish before we do the MDTs. So have any more questions from the wider room? So I might just ask then. So I've got a group of patients, young patients with HOCM, who have significant gradients but just don't seem to have symptoms and run marathons and swim across the channel and things. What do we say to them? And I do have quite a few of them. Do we still say you're high risk and you shouldn't be doing that?
I think it comes down to the shared decision making here, because on our side, in our head, having a significant left ventricular outflow tract gradient puts you at risk of, sudden cardiac death. We know it's on the AICC risk score. So I think I would probably err on saying, this is my view. And, if you are going to do this, then support them, because I don't think we should be in a position where we should just say, you can absolutely not do this. I'm going to tell everybody that you're not allowed to do this. And we're kind of moved away from that blanket ban. But I think I would be very honest with them and say, what you're doing makes me nervous. There is a risk of sudden cardiac death, and you have to be able to accept that risk if you're going to do it. And, maybe there are some patients and we're kind of oversimplifying it based on values, and maybe we should be looking more into, the actual correlation between the actual LVOT outflow tract gradient and symptoms and other things. But I think that's what I would say. I think it comes down to just being open and honest with your patient about the fact that you think otherwise, but then making sure that they're reviewed in a timely fashion so that, it becomes something that you support but not condone, if you see what I mean.
No, very helpful. I think the other three things I've heard recently is roller coasters, cold water swimming, and parachuting.
I think Wim Hof has a lot to answer for with his cold water business. There's a lot of people into that at the moment, yeah. Especially, I think I'd be very nervous about things like long QT with the cold water swimming, long QT1. But yeah, it's difficult, isn't it? When somebody's very adamant they want to do something, it's very difficult to change their mind.
No, yeah, I totally agree. It's quite a challenging case. But as we know, especially with the HCM, it's a multi-parametric approach, basically. You need to see everything before you counsel the athlete. And also, importantly, you have to see how an athlete does the exercise. You spoke about marathon runners, though. But if a patient with hypertrophic cardiomyopathy, I will not ask about the wall thickness. I will not ask about, if we just say it has just the gradient. If it is just the gradient, you have someone who wants to do deadlifts, for example, you probably are going to advise against that. But again, needs tailored according to the exact training regimen, according to the fit sim. Needs tailoring according to the specific somatometric characteristic, the specific risk factors, blood pressure variation during exercise, during the stress test we do, a stress echo, a CPET. We need to see the gadolinium. So all those parameters together, and then to explain that we probably don't have enough evidence and cohorts with standalone risk factor. So, and of course, following those cohorts that exist up for a long time. Even with those that are more specific, the studies are not followed up long term as yet. So we give advice with these restrictions, basically.
And the challenge is making time for all of this in busy clinics, isn't it? So we've got to use the wider workforce. Any other questions from the floor? I don't know, should we just perhaps just have a 4 or 5 minute break if people want to nip to the toilets and things, and then, so if you could just come back in about 5 minutes, and then we'll do the MDTs. Well, thank you guys. Really interesting. Okay, everyone, shall we grab a seat and we can move on with the MDTs?
And then Rachel can come up and just say a couple of closing words and tell people about drinks. And when Jerry's finished, then we'll get you up to close.
Why is that not on the screen? And where's Mo? Oh, Mo? Mo? Mo?
Last minute revision.
Oh, okay. You might have to remind me where we're handing over. I think I remember, but
So this is what I was checking. So I don't know this timeline. Would you like to go? It's mainly treatment and.
Yeah, I'll do that, and then I'll say genetic testing was performed, and then I'll hand over to you.
And then I go all the way till the pause.
Yeah, and
then you take over.
So how are we going to do this? Are we going to...
So what I've got, we've got a series of slides that stop. So I'm going to show a few ECGs, and then give a little bit of a story, and then say to the panel, what are your initial thoughts? What would you like to do next? Then give you a little bit more information, and then Mo will talk a bit about the genetic test.
Can you see else?
Not often the best person to ask. My eyesight is no longer what it was.
It's better than mine, right? Better than mine, I promise you.
I can't see her right now, no. But the first case is CPVT, so she could always appear and join the panel for the... I think she was planning to... she said she was happy to sit CPVT out, so maybe after I've done my case, next start, I'll go and find her for the second one.
Okay, everyone, I think we're going to make a start, if that's okay. Maybe grab a seat. We got some wonderful cases to show you. So without further ado, we found Else, excellent. Just helping set the wine up, apparently, but so good to see Else back. So we're going to start with our first case. So it's a pleasure to welcome Rachel and Mo to take us through the first case.
Thanks, Jerry. We're going to try and run the cases. We've got two cases we're going to present now, and we'll try and run them with a little bit of real time with our panel. So, oh, she says. So our first patient is a 14-year-old girl with no significant past medical history of note except a degree of dyslexia, and she was taking no medications. She was dancing in her room after drinking an energy drink and suffered a cardiac arrest, a VF cardiac arrest. She was fortunately resuscitated with a single shock. Now, I am going to show a series of ECGs, which I won't talk much about, but would like to give you the chance to have a little look through. And then after we've looked at the ECGs, I was going to invite the panel to give us their initial thoughts. So these series of ECGs were performed in fairly quick succession after her arrival to hospital. She was brought initially to her local hospital and then transferred to the Evelina Children's Hospital. There's one last ECG coming after this one. If you want me to move backwards and forwards between them, panel, please let me know. But hopefully this is the one that's perhaps most of interest. So, initial thoughts, really. Just along the lines of what is going through your head. What would you like to do next, and what additional information would you like?
Could we go back to the first ECG? Mm-hmm. Would that be okay?
I can scroll through them slowly while you're...
So shall we... It looks the fastest and most scary, doesn't it? So, I mean, Jan, this is obviously your area and your expertise. What do you think of that?
Well, that looks broad, with a right bundle branch block pattern. I think it looks fairly regular. So you've got a choice between, could it be VT or SVT with right bundle branch block? I think on this one I'd be opting for some kind of supraventricular rhythm with right bundle branch block if I hadn't seen the other two coming.
And what do you think, Steve? Would you give some adenosine in this situation?
Quite possibly, yeah. I mean, it's a regular broad complex tachycardia with a fairly typical right bundle branch block pattern. There's a sort of slurred S wave in V6, which you tend to see with SVT with aberrancy rather than VT. The inferior leads look a little bit unusual. There's sort of a QR pattern in lead 3. But certainly, if in the appropriate clinical context, I would think this could easily be an SVT with aberrant conduction.
Great. Shall we move on to the next one, Rachel?
Mm-hmm.
Yeah. So else, anything you might want to add about this ECG? It just looks a bit slower.
So this has now changed, hasn't it? So
yeah.
V1 is completely different. This is slower. And I think this is a little bit irregular. There are beats interrupting this, particularly over here. You can see a broad complex beat kind of coming in and interrupting it, and again out here on the lateral leads. So this probably is still something atrial, but it's different from the first. It's and you've got some V's coming in. So you're already thinking this is a bit odd. We've got two tachycardias here, which is odd in a, most people presenting with S14 with SVT just have SVT. They don't have this.
Okay. Should we go on to the next one?
Yeah. Yeah, so now you've got your V's coming in again, haven't you? Interrupting, coming into the rhythm.
Should I come through to the last one?
Yeah, let's go through to the last one.
And now I think
okay, so
it's obvious.
Yeah, so the audience, any thoughts about the last ECG? Go on, Yen. Yeah, no, brilliant, well done. And so it's, I think you'd agree, wouldn't you?
So it's bidirectional VT, unless they're intoxicated with digoxin, which is in the differential. You're pretty...
And not completely impossible in the clinical situation.
Yeah, okay.
14-year-olds taking a lot of digoxin in their bedroom dancing.
Overdoses aren't unheard of in,
Yes,
in teenage girls.
True. Yeah.
It's not a byproduct of nitrous or anything, is it? So, yeah. Great. And then I guess just teasing it out for the audience. So when you see this bidirectional VT, what are you thinking and what does it mean? And is it as diagnostic as people say?
Well, usually I quite like it to stop because it usually means something awful is going to happen next. So it does sort of create a sense of urgency. Is it diagnostic? Well, apart from digoxin toxicity, I think that's the only other place you really see this sustained bidirectional VT. You can get bidirectional couplets certainly in other things, but if it's a sustained bidirectional VT, then it's very unlikely to be anything else, I think.
Okay.
I mean, I think in ischemic patients and other patients, you can certainly get bidirectionality, can't you? Which confuses the issue in slightly older patients, but in a 14-year-old, this is pathognomonic.
Yeah. And I mean, any thoughts on the energy drink? Is that relevant?
Certainly won't have helped, will it?
An environmental trigger.
Great. And I guess going through the panel, so Els, what would you do next?
Well, so she's kind of had a slight stress test by demonstrating that she's developing a lobectomy. So I would be thinking, well, considering medications first line, but we're actually considering risk. So how symptomatic, risks, thinking devices, etc.
Yeah, great.
A device?
Not hopefully, so ablation would be more likely if she had continued ectopy and symptomatic VT.
Should we keep going?
Yep. So a little bit more information after the acute event. It's possible to find out that she had previous episodes of syncope when she was 9 and 12 years old, and both of those were related to exertion, from which she recovered quickly and didn't seek medical attention. There's no clear family history of note, and she has an echocardiogram that shows she has normal cardiac structure and function. And then just going to quickly go through her timeline. We've already talked about her presentation. She was stabilised on the paediatric intensive care unit, and we saw the multiple different types of arrhythmia on her admission ECGs. But with stabilisation, intubation on PQ and an esmolol, so a beta blocker infusion that was titrated to bring her heart rate down to below 80, correction of electrolyte imbalances, she did very well. She was maintained in sinus rhythm with a good blood pressure. She was extubated quickly, hemodynamically stable, stepped down from PQ. She went on to be stabilised on nadolol, a subcutaneous ICD was implanted, and she was discharged with cardiology and some neurology follow-up because unfortunately she had sustained a minor head injury when she had her cardiac arrest. And just to mention that genetic testing was sent during her PQ stay, and at that point I'm going to hand over to Mo to talk a little bit more about that.
Thanks, Rachel. So yes, so we actually saw the parents in PQ when this girl was admitted, and at that point genetic testing was sent. So what was actually sent was the R129 panel, which is essentially a large ICC panel involving 174 genes, but the analysis is just focused specifically on the usual suspects in CPVT. So we have the calmodulin genes, 1, 2, and 3. We have the RYR2, we have the TRDN and the CASQ2. And the test has actually shown a missense variant in RYR2. So what do we know about this gene? We know that it's obviously related to CPVT. It's, there is a mutation in 60% of CPVT clinically proven cases. And it's mainly gain of function variants, so there are largely missense variants that cause CPVT or ARVC. And the mechanism is essentially a pathological or unregulated response to beta-adrenergic stimulation. So you have enhanced sarcoplasmic reticulum calcium release into the cytosol and the cardiac myocyte, and that is what causes delayed after depolarization, subsequently monomorphic and polymorphic ventricular tachycardia. So it's an exaggeration of a normal physiological phenomenon of excitation-contraction coupling. That's why it's mainly gain of function that causes the phenotype, whereas loss of function causes another condition, which is ventricular arrhythmia secondary to cardiac ryanodine calcium release deficiency syndrome. And as expected, this gene is largely expressed in the heart. So also interestingly, there are mutational hotspots with specific exons known to harbor specific variants in the gene. And interestingly, our variant was located in one of the mutational hotspots. So we know that there are 3 main domains in the gene, and it's the variant is in the central domain. Just putting evidence together, collecting evidence for the pathogenicity of this variant, we know that it's not reported in the literature, so we know little about it, but it's also absent from NOMAD, which is a large population data set of apparently healthy individuals. So this is likely to be a rare variant. And also the computational tools or in silico analysis suggested that it's pathogenic. As I said, it's located in a hotspot. So if we collect the evidence together, we have, this is the ACMG, ACGS guidelines for classification of variants. And if we have 2 moderate and 1 supporting pathogenicity criteria, then this variant lies in the hot variant of uncertain significance category. So not quite class 4 or class 5 yet. But remember, we've only tested the proband in the family. So any further thoughts from the panel on what to do next and what additional information you would like to know?
Yeah, can you just go back a couple of slides for me? Yeah, that's it. So Catherine, do you want to just take us through some of the aspects that I think a lot of the non-geneticists might not get on that slide?
So should we go back to the family history slide? Have you got a... So you've got the 14-year-old here with a clinical diagnosis of CPVT. You've done genetic testing and got a hot VUS. So the next thing is to think who else in the family is at risk, and also you want to try and interpret this variant if you can. So CPVT is dominantly inherited, but with very variable penetrance. So it's possible that one or other of these parents have the variant and do also have a phenotype that may be unmasked with detailed phenotyping. So I'd refer to the adult cardiologists for exercise testing and interpretation of that data, and then concurrently look and see if this variant is in either parent. Because if it's in a parent and they have the phenotype, that would be supporting. But equally, if neither parent show the phenotype and the variant is de novo, then that would also allow us to up the pathogenicity of this variant. So they're the next things I would do. And while I was waiting for that interpretation, I think it's important to look at the 8-year-old sister as well, because she may also be at risk, and also have her assessed clinically for any suspicious signs.
Okay, thank you very much. And just, you mentioned exercise testing. There's different types, I think, isn't there? Different protocols, different ways of doing it. I don't know, Steve, if you wanted to comment on that.
Yeah, so, I mean, the sort of the typical exercise test protocol would be the Bruce protocol that most of us use, and we still use in Leeds. But there is now much better evidence to suggest that a burst protocol is more sensitive in picking up patients with CPVT. And the idea there is that rather than gradually incrementing your exercise output, you go straight in at a high physical performance. And what they often suggest is that you start your Bruce protocol at the point they left. Sorry, you start your burst protocol at the point they left off their Bruce protocol. So you start exercising quickly and rapidly, and that's supposed to be more sensitive. And I think there's good sort of evidence for that. We haven't yet sort of incorporated that into our practice in Leeds, and actually I think we have one example where the lack of a burst protocol has probably led to a misdiagnosis.
And we had a similar one, didn't we, Rachel? We had a similar one a couple of months ago. Yeah, and would you do that in an 8-year-old, Jan? Would you do a burst protocol?
Yeah, we've been using a burst protocol, not exactly as you describe, but for 4 or 5 years, I guess, in the younger people, where we just get them on the treadmill and ramp up fast. So 1 minute, bang, 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 bang. So they're really running. Just thought creating what they do in real life might be more advantageous if you're trying to trigger an arrhythmia than a Bruce, which was designed for ischemic heart disease, I think. So we've used that. I mean, it is true that, you know, an exercise test isn't 100% for CPVT. You can exercise people even on that protocol, and you won't always get a positive when you know that they have it. So it's quite hard to gauge exactly if your protocol is the thing or whether it's just variations in the condition, isn't it?
Just going back to the start of the case, we saw spontaneous bidirectional VT, is that right? That wasn't on exercise. And did the patient have an exercise test during the hospital admission? No. So if you hadn't shown us that ECG, this diagnosis would not have been obvious at the time, and unless you do an exercise test, then you're not going to pick it up, which then guides your genetic testing. So I guess that's important. The timing of the exercise test, I mean, presumably they had an SICD implant, so there'd be some sort of exercise screening template matching process. But I think this is an example where knowing the diagnosis before a decision is made about device implantation is really important, and therefore deferring an exercise test until outpatient review, which is tempting when you've got bed pressures and everything else, would actually potentially lead to harm here.
I wanted to ask Jerry if would there be anyone in the audience who would consider not implanting an ICD?
Yeah, so but if you wouldn't, put your hand up. That's called the brave minority, I think, Jan, isn't it? Yeah.
Jan said consider it.
I was lucky enough to take part in a paper that showed, in this particular group, first diagnosis, untreated, cardiac arrest in CPVT. The benefits of an ICD are very difficult to weigh against the downside of an ICD. So if you get them on beta blockers, flecainide, you have a good outcome. So I don't put in an ICD in this situation.
And everyone worries about the sort of vicious cycle of shocks, more shocks. And do you see that commonly, or is that very, very rare?
I think it's rare, isn't it? It's well written up, but I haven't actually seen it. I have seen people with an ICD, children with an ICD, die despite the ICD, because that's the other thing. The ICD doesn't always shock you out, and you can use up your shocks on rhythms that won't respond. So the benefits of an ICD in this group are difficult.
Yeah, interesting.
So it's the one condition, I think, where if you have a cardiac arrest, I mean, normally you just go ICD, wouldn't you? But it's the one condition where I think you need to have a think whether you're really doing the right thing.
Yeah, so having heard that, are there more people that wouldn't put an ICD in now? If we swayed the room?
I need to bring you the paper, because it's quite a large collection. It was the work of the CPVT International Registry that got together the large numbers around the world with people contributing. It was fairly convincing.
be sure they take their tablets, haven't you?
Well, I often add in a sympathectomy as well. Yes. Yes. And then, you know, they're going to be followed up. But if I get a teenager if I think he's any way not taking his tablets, then I take action. Because that's fairly common in our practice, as you see the teenagers and they're sitting there looking monosyllabic and, you know, mum is fussing. But the minute they leave mum, you know, they're not going to take their tablets. So that's when I'd step in. But you might buy yourself a few years at 14, mightn't you?
But I might just ask Catherine one last thing. The variant we saw, you know, you get these sort of likely, very likely pathogenic. We never use pre-test probability, do we, in genetics? We always just grade it on databases. And
I think we do clinically, so that's
we
why
do,
the
well,
phenotype
exactly,
is so important when you're doing genetic testing. That's why you need a clear phenotype rather than going on a fishing expedition, because it really helps in the interpretation. Is this are pathogenic or are variants in this gene associated with this phenotype? So in that way, I think.
And would you be happy to use this for the wider family, the one they identified?
Not as a VUS. I would want more.
Yeah,
I mean, we've got more evidence to look at, I think.
Okay, let's keep going.
So I'll hand over to Rachel again.
So family screening. We've got the immediate family, and the sibling was asymptomatic and had normal clinical investigations, including a treadmill, which was done to the paediatric arrhythmia Evelina version, I think, of the burst protocol. Mum and dad. We've got dad, who's 53, occasionally notices his heart jump, no clear past medical history, not taking any medications, had a normal ECG, normal heart at echo, mildly elevated blood pressure in the clinic room. We've got mum, who has noticed palpitations, she's 36, palpitations while she's exercising, had one episode of syncope in her teenage years, but this sounded clearly vasovagal. No past medical history of no medications, and also had a normal baseline ECG and structurally normal heart on echo. So mum and dad then went on the treadmill, as you have suggested. So dad, we mentioned, largely asymptomatic, a bit of atypical chest pain, has been running up to 5K without problems. Mentioned that is no clear family history, no past medical history, no medications, normal ECG and echo, mildly elevated blood pressure. So his treadmill was largely unremarkable. At stage 5, he had a couplet of unclear significance. I think our initial thoughts were, could this relate to some underlying coronary abnormalities with the chest pain or hypertension, given that his blood pressure was high in the clinic room. But in fact, his average blood pressure was significantly lower, so I suspect there was a bit of white coat anxiety in his initial assessment. And his CTCA showed only mild disease, non-obstructive coronary disease, so unclear what that couplet may represent. Mum, as we mentioned, has had exertional palpitations for a long time, but no, when I say no syncope, there was the vasovagal episode, but no cardiac sounding syncope. Also, no clear family history, no past medical history or medications, normal ECG and echo. She has a normal blood pressure as well. But on stage 3 of her treadmill, this is what we saw. And actually thinking about our discussion there around the type of treadmill, we initially did a Bruce protocol, and we brought her back to do a burst protocol to see if we could induce anything more than this, but we couldn't. So even with the burst protocol, we saw this, we saw bigeminy, but we didn't see anything beyond that. So if we go back to our family pedigree, obviously our proband here with the RYR2 variant then went on to perform testing for mum and dad. But testing for mum initially was negative for that variant, although we did feel that her phenotype was in keeping with CPVT. So I guess I'm now asking for further thoughts from the panel, particularly around the maternal phenotype, the pathogenicity of that RYR2 variant, and whether there's anything else in terms of genetic testing that could be helpful here. And I'll hand back to Mo.
Okay, so should we start with the ECGs? What do you think, Steve?
Yeah, can we just go back to that ECG? So, I mean, the first thing to say is that if you're not very familiar with looking at ECGs, it might from the back look like bidirectional VT, but it is actually sinus rhythm with ventricular ectopics. So one beat is narrower than the other. They've got a right bundle branch block morphology and an inferior axis, which is fairly non-specific. It could be coming from sort of left anterior fascicle, possibly, but that's speculation. In answer to one of the questions, no, this is not pathognomonic of CPVT. I guess in order to get more supportive evidence, you'd want to see, is it reproducible? Do you see the ectopics start at the typical heart rate of 110, 120 beats a minute? Do they melt away? Do they increase with increasing workload, and do they melt away with recovery? Because you do see ventricular arrhythmias on exercise in other situations, and this is certainly suspicious, but it's not pathognomonic.
So if you sort of said there was a 50% chance pre-test, what would you make it post-test?
Post-exercise test?
Yeah.
I would say 75 to 80.
What do you think, Jan?
I think Stephen's made some very good points there. It would be good to know if it was reproducible. And I think, as I always tell my registrars when I send them off to exercise CPVT patients, if you stop the treadmill, it usually stops. So, don't get too worried. So you'd want to see how it responded. I think those are two very good points, Steve. But yeah, I think that looks suspicious, especially if it's coming in, sustains in bigeminy, and then stops as you stop the exercise test. Yeah. How old is Mum? Mum's 30. She's young.
36.
Yeah. So, I mean, how often would you see that in a 36-year-old woman?
Yeah, not often.
And Catherine, what about the genetics and how that takes us forward?
So I suppose you're thinking, is the mum's phenotype connected genetically, or is it a phenocopy, or is it because of a variant in another gene, or is there further testing that we could do to try and make a connection between these two cases, which is something we could think about doing. So look harder for that variant that you found in the daughter to see if it's present in perhaps other tissues other than blood that you took, and so see if there's any evidence. It's rare in my experience in ICC to see that phenomenon, but in more general genetics we see mosaicism quite commonly. Actually, we're quite comfortable with seeing that in a lot of the conditions that we see. But my experience of ICC is I've seen it a couple of times and that's all. But it's something we could think about doing because it's an unusual picture, and the cardiologists are 75% confident this is CPVT in the mum as well. So the most likely thing is that there's a connection between those two. And that would be the way to try and look into that, to look at further tissues.
Yeah, it'd be good to see what the audience thinks. So put your hand up if you think mum has CPVT. That's 65% from the audience, so yeah. Mum's got a funny axis. Any thoughts on that?
Absolutely. It's sort of part of the diagnostic criteria, isn't it? I see what you're getting at. I mean, this ECG is on exercise, and therefore I wouldn't read too much into the partial right bundle or the AVR on exercise. If that was present at rest, then yes, that would raise the possibilities of maybe structural problems in the right ventricle.
It was normal at rest. I'm sorry,
Right.
I don't have
Oh, yeah, it's so normal at rest, apparently. Okay, should we keep going?
So inheritance studies were normal. That was done by Sanger sequencing. It was just testing for the familial variant, or the variant that was detected in the proband in the family. So we discussed this case on several occasions in our local AICC MDT meeting. And the thoughts we had, if the mother has got some sort of a similar phenotype, then is she low-level mosaic for the variant? Remember, this could have been missed by a conventional testing method like Sanger sequencing. Or does she have another variant in the same gene, or another channelopathy variant that might explain this? Obviously, this is not very common, but these are the suggestions we have had. And also whether she's a phenocopy. So we just decided to speak to our local lab, which is the Royal Brompton Genomics Lab, and decided to do the panel, the NGS panel, on mum stored DNA from blood. But also, as Catherine was mentioning, we thought about finding another tissue for testing in case she's mosaic, and different tissues might be affected differently. So we arranged for a buccal swab. So this will have some epithelial cells as well as leukocyte DNA. So it's not just leukocyte DNA. There's kind of epithelial cells in there as well. So the testing showed that she is actually a mosaic for the variant, with 9% in the blood and 4% in the buccal sample. They were done on 2 different stages, but initially we had the results of the blood sample first. And there were no other variants detected on the CPVT panel. The same variant was identified in a low-level mosaic form. The sister of the proband has had normal screening. She's hasn't been tested yet, unfortunately, but this was a surprising result. It was interesting from a genetics perspective, and we just had to look at the literature to see what's the prevalence of whether RYR2 mosaicism has been reported before, and there are a few cases in the literature. So there is a paper from 2010, or a case report, where the proband had recurrent syncope and was reported to have a positive ETT, and they were found to have a constitutional RYR2 missense variant. Her brother passed away at the age of 10 whilst playing football, untested. The mother was found to be mosaic for the variant in different tissues at a range of 10 to 25%, but she was actually asymptomatic, and she had a normal exercise tolerance test. On a similar note, there was another report of 2 siblings who've suffered from sudden cardiac death, and one of whom was reported to have a full-blown CPVT. Both were found to have the same variant, which was again inherited from their asymptomatic mother, who's had a normal exercise tolerance test, and the mosaicism varied across different cells. So we checked with our friends in the Brompton's Genomic Lab to see whether they have mosaicism in this gene in their cohort, and they actually reported that they do have 3 families and 6 families in total in their AICC cohort. So in these families, the phenotype of probands range from recurrent syncope with features of CPVT on exercise tolerance test, sudden death. So family number 1 on the right side of the screen, the proband had sudden collapse at the age of 7, which was, there was some features of CPVT on her electrophysiology, and her maternal half-sister actually passed away at the age of 8. Post-mortem examination concluding arrhythmogenic cardiomyopathy as the cause of death. And their mother had a mildly dilated left ventricle with paroxysmal AF. The proband had a constitutional RYR2 mutation, and the mother was mosaic at 29%. And family number 2, it's a story of 2 siblings who've actually had recurrent syncopes. Their exercise tolerance test showed bidirectional VTs and polymorphic ventricular ectopics. They were found to have the same variant. Again, the variant was inherited from their mother, who's mosaic for the variant and had normal exercise tolerance. And then family 3 at the bottom is a story of sudden cardiac death in a child whose post-mortem genetic testing showed another constitutional missense variant. They're all different variants, but they're all missense, as you would expect, which is also inherited from his father in a mosaic form. The father had bidirectional couplets on exercise tolerance test. Further on, the RBH genomics lab has also mentioned that they have mosaicism in other genes associated with ICC, including lamin A, PRKG2, and MOH7. So in family number 4, for example, the proband died because of progressive severe DCM, was found to have this variant. The father was mosaic for the variant and had a moderately dilated left ventricle. And family number 5, the proband was actually mosaic for the PRKAG2 variant and had severe HCM and Wolff Parkinson White, died at the age of 1 month. The last family, they had an MOH mosaic variant and they had left ventricular hypertrophy. Still, even though these are 6 families, the cohort was approximately 2,000 individuals. So the rate is it's not common. It's approximately 0.3% in the cohort studied at Brompton. Obviously, this some cases might have been undiagnosed. But the learning points for me, I guess, in this case, is the role of mosaicism detection and how this can affect the counseling with the family. For example, if a parent is mosaic for a certain variant, then the risk of recurrence is up to 50% as opposed to the de novo risk, which is much less lower. And also reproductive options and things like cascade screening in the family can be done if this is identified. And also from a technical perspective, the pickup rate of mosaicism by different genetic testing techniques. So we know that Sanger sequencing has a limit of detecting mosaicism up to 15 to 20%, whereas NGS, when it's high coverage and very targeted, it can have a much deeper read depth and higher detection levels of mosaicism, which can be up to 2 or 3%. And also the phenotypes that can be mild or partial in association with somatic mosaicism. And the value of the MDT in these discussions, we had these discussions between our team, within our team in genetics, with the cardiology team, with the lab in the Brompton, and I think overall it was a good experience for my learning. So special thanks to pediatric cardiology team at the Evelina, our colleagues in the Brompton's lab, and Lima, who's my clinical supervisor. Thank you very much.
Great, thank you very much. A wonderful case. It just shows how important the MDT is and how you must have a geneticist in your MDT. Yeah. But in the with teams, there's no reason anyone can't join MDTs these days. Thank you very much. Oh, we've got a question just before you step down.
Thanks. It's a very interesting case. This is going to be a classic genetic counsellor question. Hi, I'm over here. So I'm interested in the psychological impact on these parents who are mosaic for variants which have affected their child with the full phenotype, or in some cases with sudden cardiac death. And we all know how difficult it is for parents to know they've passed on a variant, even if they have it themselves and they have the same condition. In this case, the parent is perhaps more mildly affected or maybe even clinically unaffected, yet has passed on the variant to their child. In your case, I was wondering, how did the mother receive the news that she has this variant that her daughter has inherited?
Yes, this is a good point. I think with this family specifically, it was more of a mystery why she has these abnormalities on her exercise tolerance test when she hasn't got the variant. So it was more of providing answers rather than the sense of guilt, or it was more of an explanation. And generally she was very grateful because we had regular follow-ups in terms of what the next steps would be in genetic testing, and we were kind of clear in our discussions with her. And I guess at the end she was also grateful for knowing that this is something that we can test for in the younger daughter. And obviously I explored their reproductive avenues with her and reproductive options in terms of this finding, but she's completed her family. But I think in other families that would be important as well.
Yeah, no, great question, very important. Thank you. Caroline.
I'd say up to 50%. So if we're thinking that she's got mosaicism for the variant in the blood and the skin, she's probably got it in the heart as well because she has a phenotype. So the gonads might be affected. We know that she passed this mutation to her daughter, so there is a proportion of cells in the gonads affected, but we don't know to which extent. If all the cells are affected, then it will be 50% because you will have the other normal allele from the father. So yeah, I would say up to 50%. This is how I'd counsel generally.
I don't know if everyone heard that. Lima was just saying they could offer pre-implantation diagnosis if they want more kids. It's quite a long process, that, isn't it? Yeah. Yes, at the back.
Can you hear me? Yes. Thanks, Mo. This might be a really silly question, so forgive me. But with this patient, she obviously had the RYR2. You tested mum, she didn't have it, and it was purely by doing the exercise test that there was a phenotype that you then proceeded to pursue further. So a little bit nervous because obviously we counsel patients around testing, and in the situation, for a majority of patients, a negative result would be good news that they don't have this. But without that test, we would never have known. So with maybe, I was just discussing with Ellie, maybe it would be prudent that in de novo cases, or seemingly de novo cases, we do screens for the parents. Yes, it's a very low chance, as you said, 0.3% that this could be mosaicism, but should we do that? Should we advise that?
A very good point, and this made me nervous as well, but I think that's why this case is so interesting. With this family in particular, when we first met them in pediatric ICU, obviously at that point their daughter was very sick. She was intubated, ventilated, but we did ask them to self-refer to our AICC service for formal cardiac screening. I think clinicians might do different things, and as you say, this case might have, if they've had, let's say, baseline testing and they haven't had more testing, and it could have been missed. We could have done the Sanger sequencing, could have not picked up the mosaicism, and we would have given a different counseling approach, I guess. But also remember that some of the families who were found to have mosaicism in the gene, some of the parents did not actually have a phenotype and had normal exercise tolerance. So they were clinically unaffected. However, because they had more than one affected child, for example, this might have been picked up. So yes, but I think another learning point for me is in similar situations, I would always refer the patients, the parents of the proband to have formal cardiac assessment.
Could I ask our geneticist, so if you looked at the Brompton cohort, and I look after some of those families, I mean, CPVT is overrepresented in terms of there was only one lamin, one BRCA-G2, but there were several. Is there something about the rhianodine gene or something that makes mosaicism more possible?
I don't know off the top of my head. I think what's interesting about some of those conditions is that some of the ones where you have a really severe phenotype, we find more often are de novo, or in this case, mosaic, so effectively post-zygotic de novo in the parent. And I think if you think of all the new mutations that arise, new mutations do arise, a proportion will be in people who then survive to reproductive age, and a proportion will be more severe and cause early death. Now, if you look at the ones that are de novo, they could be any of that spectrum, whereas the ones that we see inherited, by definition, are the ones where people have survived. So I think those really poor outcome conditions with these sudden deaths are perhaps de novo with that mechanism that I've explained. Does that make sense?
So you mean if you have a full hit of it, you don't survive to reproduce?
Well,
you
if
only,
you've got,
you
if
only
you've got a
survive
variant
if you're a
that,
mosaic.
No, if you've got a variant that is so severe that you have highly penetrant disease that manifests in childhood, you won't survive to reproductive age. So the ones that we see being passed down the families are, by definition, ones where people have survived in generations before enough to reproduce. So it may be that that's what's skewing this representation.
I mean, it's quite good that genetics takes a little bit of time sometimes, isn't it? That we can get in there with our screening first.
Great. So if there's no more questions, we'll move on to our second and last case. So great pleasure to welcome Dan Hammersley. Thank you very much, Dan.
Good afternoon, everyone. Thank you very much for the invite to present a case. I think I may need an account name to log into the... do you? Just check the... Ah, thank you.
There will be a disco with the wine, by the way.
Some moves, Jerry.
Someone took a video of me at a wedding dancing and they keep playing it to me. This is awful. It's just the worst thing you've ever seen.
Yep.
What you want is it to be videoed at a wedding.
Yeah, you don't want that.
Someone who can help.
Perfect. Okay. Shall I just send it to... I've got it in an email. I can just...
Just in the interest of time, whilst we switch over, I just wanted to make a couple of announcements with regards to kind of some general housekeeping. If you can, anyone that's coming back tomorrow, if you can keep your lanyards and bring them with you tomorrow, that would be great. And anyone that's not coming back from tomorrow, if you can bring your lanyards to me at the end of the meeting, that would be super helpful. Also, perhaps if anyone's not staying till tomorrow, if you want to find me after the meeting closes, just so that if there are any changes on the directory of service that we've got on the website, we can do those changes up to date as of today, because I know a lot of staff changes happen. So if you do just want to come up to me either today or tomorrow at some point, then we can edit up the directory of service to make sure that that's kept up to date on the website.
Please obviously fill out the feedback forms, which there are the QR codes on your table, and do sign up to the YouTube channel. You will be able to watch back at a lot of the videos and things that we have had today. And then just one last thing just to clarify, because I've had a few queries. Tomorrow's meeting is at the Cavendish Conference Centre, which is near Oxford Circus. We're not back in here tomorrow, so please go to the right venue. Okay, the details should be on the website again, but it's near Oxford Circus, it's the nearest tube. Okay.
And if people wanted to just email about changes to the Directory of Service, can they do that?
Yes, absolutely. Yep, so again, if you do have any changes that you wish to make to the Directory of Service, by all means, you can email the AICC@bts.com email, and that will come through and we'll be able to edit it accordingly.
I guess while we're waiting. Oh, no.
Perfect. Good timing.
Perfect. So my name's Dan Hammersley. I'm a ST7 registrar at King's College Hospital. I'm actually going to be presenting a case from time last year when I was working with the advanced heart failure team at Harefield. I'm grateful to Ellie Quinn, who's here in the audience, who was both involved with the case and has helped with the preparation of the genetic component of it today. So the patient in question is a 21-year-old female who was previously fit and well, taking no medication, studying law in London. Her first engagement with healthcare services had in fact been 3 years previously, when she had presented to her local hospital with an episode of chest pain and some palpitations. She was found to have a very low troponin leak on her blood tests with a troponin level of 40. She had an inpatient echocardiogram that was reported to be normal, was discharged and had an outpatient Holter, which had interestingly shown 11 beats of non-sustained VT, and had an outpatient CMR arranged that she DNA'd. And she didn't engage then or she didn't have any further engagement at that point until 3 years later, when she represented to same peripheral district general hospital, again with palpitations, and an ECG which was reported to show a narrow complex regular tachycardia at that juncture. We were told that she had been given verapamil and had cardioverted, and she was then discharged. 2 months after that second encounter, she represented again to the same district general hospital with palpitations, and this time with breathlessness, with again a regular narrow complex tachycardia, but on this occasion with a clinical picture of severe cardiogenic shock, which was rapidly escalating. She had a bedside echocardiogram done that showed very severe cardiac dysfunction, and a shock call was made to Harefield Hospital, and she was urgently transferred over to Harefield. These are her investigations that were sent over to us. Do the panel have any comments on the ECG and the echo?
Els, would you like to comment on the echo?
Oh, sure. Significant severe biventricular dysfunction. Left ventricle is probably normal in size. There's a little bit of trabeculation there, but it doesn't, again, difficult to know. We haven't got any Doppler to see valve, but I think it's quite bright, but again, with echo, it's difficult to know whether that's just the gain that's been turned on the machine or not. Do you want me to go on to the ECG?
Yeah, you can, yeah.
So the ECG is obviously regular narrow complex it's a regular narrow complex. It is relatively tachycardic. She has some ST sagging, particularly infralaterally on the ECG, late R wave progression, only with transition with a positive R wave in V5.
well, actually septal cues really. Deep septal S wave. Can't see any obvious hypertrophy on the echo to correlate with something subclinical. Some fractionation again, particularly in one.
What's the rhythm on the ECG, Steve, would you say?
Sorry.
Well, it's a very unusual ECG, actually. I think it is narrow, but only just. I think it's broader than you think. If you look in V6, it's probably nearly 120 milliseconds. And there's that curious beat about a third of the way in on the rhythm strip, which just has a different QRS morphology. And if you follow it through the limb leads, it's got a different axis.
There's another one just there, in V3.
Oh, yes, yeah. Which is unusual. And, just thinking very generally, it makes you think, could it be a capture beat? Could it be a fusion beat? Could it be something a bit unusual? It certainly doesn't look like classic AVNRT. There's a sort of in AVNRT, you typically get either no P-wave activity or you get a sort of an R prime in V1, particularly sort of an upstroke, a notch in the distal portion of the QRS, which you don't see here. You do see in V3 a sort of a negative deflection in the ST segment on 4 of those beats, but not the second one. So it's pretty unusual, and I wouldn't be confident in being able to make a diagnosis from that. I'd keep a fairly broad, open mind.
Does it all look a bit low voltage to you too?
It does, doesn't it?
In theory,
yeah,
particularly.
yeah.
It looks very odd, doesn't it?
Yeah.
Yeah, so we think it's odd.
Yeah.
I think that's the take home, isn't it?
So I'll move forward with the story. So this patient was transferred over to Harefield and was in multi-organ failure extremely poorly. Was initiated on VA ECMO, obviously being looked after on intensive care. Had a coronary angiogram, which I've highlighted the slightly unexpected finding on this, which was that the patient had normal coronary arteries, but actually had a thrombus in the distal LAD, which was retrieved by thrombectomy, and that was felt to likely be embolic. Multiple attempts were made at cardioversion to try and terminate the narrow complex tachycardia, which were unsuccessful, and the patient went on to have a slow pathway ablation in the first few days of their stay. Following this, and after restoration of sinus rhythm, the patient was significantly stabilized, such that ECMO weaning was possible from 6 days, from day 6. And shortly after that, and decannulation, a repeat echocardiogram, which is shown here, was reported to show much improved cardiac function with an ejection fraction of 45%. The patient was then able to go on to have a cardiac MRI. I've shown some of the late gadolinium enhancement images here. Any thoughts on what we can see there?
So, Els, you're our imaging expert. Would you like to?
So if, for example, you look in the bottom right-hand image, you can see that the septum is white, so that's late gadolinium enhancement. So in a normal heart, the late gadolinium, the contrast agent, should wash in at the heart muscle, and it should wash out. Whereas here, it's gotten stuck within the myocardium, and so you can see that as a band of fibrosis in the anteroseptum. So that very much correlates with the angiogram above, to suggest, and it's also whilst it's almost transmural in the bottom right-hand image, the top left of the quadrant here, it's subendocardial to some degree, although it's kind of a little bit more subendocardial, which makes, again, you think slightly ischemic in nature, which would go with the spontaneous thrombus that had arisen most likely because of either her atrial arrhythmia plus or minus the LV function. causing the thrombus formation.
And there's a little patch in that inferior wall, isn't there? Which is that pericardial or is that epicardial? It's hard to tell, isn't
Looks
it?
to me, from where I'm sitting, that looks like that's pericardial. Epicardial. I think that's pericardial. Yeah, most likely. But it's the anterior wall that's the main late enhancement there. Which bit are you alluding to, Jerry?
It's just that
I don't know whether
mid to basal inferior wall. There's just a few little spots, isn't there? But I think you'd need some more little cuts.
Absolutely. Sorry. Yes. No. Absolutely. There is very much at the, but it's and likewise in this 2 chamber on the bottom left, you can just see almost 3 little blobs in the bottom that suggests there might be something else there. But again, it's
pretty subtle, isn't it?
It is quite subtle. Yeah.
Interestingly, the ejection fraction was found to be 51%. So the patient had a relatively rapid improvement in cardiac function. Whilst the patient was on the ward convalescing, there were several episodes of non-sustained VT that were captured on bedside telemetry. And then the patient went on to have in fact, 2 Holter monitors, which were broadly similar in their findings, which showed a first-degree AV block with a significantly prolonged PR interval of over 300 milliseconds and a very high burden of supraventricular ectopics, 29% and 2% of ventricular ectopics. So delving into the family history, so this 21-year-old patient has a mother who lives in the UK who was fit and well with no known cardiac conditions and not taking any medicines. She's estranged from her father, who she's not seen since for many years, and who lives in South America, who she's not in touch with. And there was a maternal half-brother who was 35 and well on no medications. And on the maternal side, there was a maternal cousin who had died in infancy several days old, for whom very few details were available. But it was the patient mentioned that it had been felt to be something that the child had been born with, and so we wondered whether that may be a congenital problem. Genetics was sent whilst the patient was an inpatient, and the results, when they reported, related to the DCM ACM 43 gene panel, and showed a heterozygous missense variant of unknown significance in the lamin A gene. Interestingly, this was a variant that has not been reported elsewhere in association with disease at all, not present on NOMAD population databases, and actually not seen in any of the other UK clinical genomics labs previously. That the variant was not listed on ClinVar, and the in silico tools predicted an adverse effect on protein function. Importantly, this related to a highly conserved region that was located in the head domain of the protein that has an essential role in forming the head-to-tail structure of lamin polymers. There were 2 reported cases of similar variants on ClinVar, which had been reported as being associated, one with hypertrophic cardiomyopathy and one non-specifically with cardiomyopathy. Any thoughts on the genetics from the...
Yeah, so let's go to Catherine.
Just a few comments, really. So, a VUS. So, I think everyone in this room is familiar with VUSs and how difficult they can be. But the missense variants in lamin, when they are likely pathogenic or pathogenic, tend to have a less severe clinical course than loss of function ones. So this girl's obviously got really progressive disease. So that makes me think a little bit. It's perhaps a little bit unusual. I think the comment that it's associated with hypertrophic cardiomyopathy and another cardiomyopathy on ClinVar, I think you have to be aware that the quality of those databases may not be brilliant, so perhaps don't read too much into that. And the fact that it's not been seen, this particular variant, that doesn't put me off, because we know that a lot of these variants are private to particular families. So sometimes we find a variant and we can look it up in the literature and learn about that in other families, but quite often it's private to that family. So we're quite often faced in that situation. And with the VUS, the first thing we'd want to do is segregation and find out if it's de novo, but I'm aware that this girl is estranged from her father, and I did look, actually, it looks like her grandfather's also deceased. We've had one family where had a variant in a child with a DCM, and it was present in her mother but not present in the grandparents, and that was enough to increase the variant interpretation to likely pathogenic. So if one parent's off the scene, if you can test grandparents, that may still be informative. I've used that, in clinical practice.
Brilliant. And I might just go back to one thing for Jan. So first degree heart block, what PR interval do you think there might be more significant conduction disease, sort of infrahissian disease and things? Is there a PR interval at which you think, oh?
Well, I would imagine this team were feeling quite pleased with themselves that they'd managed to do a successful slow pathway ablation in this person. Were they still on ECMO at the... Yes, on ECMO. So they must have been congratulating themselves to stop the tachycardia, but I wouldn't think they would be too pleased to see that length of first degree heart block. You might think it was something to do with what you had done. I think that, that degree of first degree is quite significant, and there are lots of things about this case that don't quite fit together, aren't they? So you'd be putting that alongside all the other flags that are accumulating. So I think that would not be acceptable.
Okay.
So the patient is now an outpatient coming back to the advanced heart failure clinic, although she by no means has symptoms of heart failure or at all. Her mother was tested and was not found to have the lamin variant. As we mentioned, her father is entirely off the scene, so it's not possible to classify this as de novo. The patient did very well, NYHA class 1, tolerated heart failure drug therapy that she'd been initiated on while she was in hospital. She didn't have syncope or any other red flag symptoms, and her ejection fraction was mildly reduced only. Here's another ECG from one of her clinic appointments.
So this is not normal, is it, Stephen?
So we think this is dodgy as well, don't we? So, do you want to take us through it, Steve?
So it's not a regular rhythm. Most of it is sinus rhythm, but I think there's some atrial ectopics giving it this sort of atrial bigeminy pattern. Very long PR interval, anterior Q waves, low voltages, sort of fairly flat repolarization, and a ventricular ectopic. So lots of atrial ectopics, a ventricular ectopic, and clear evidence of structural heart disease affecting the conduction system and the anterior wall of the left ventricle.
Okay. So this case was taken to our local MDT, and these were some of the questions that were posed at the time. The first was, is this novel lamin variant of unknown significance associated with phenotype in this case? And the second question was, should this young patient have a primary prevention ICD implanted, recognizing that she is NYHA class 1, EF 51%, and has not got a secondary indication for an ICD? And the third was about the family, now that we've identified this variant. So what do the panel think?
Yeah, so maybe if we do the third one first, because that's probably the easiest, isn't it? Do you want to comment on that, Catherine?
Yeah, so with this being a VUS, I definitely wouldn't use it for predictive testing. Actually, one thing I meant to say was, did you get the phenotyping in the mother when you did genetic testing?
Not done, yeah. So,
because that's a really helpful part of the picture,
yeah,
to know the phenotype in the mum as well.
Yeah, no, really good point. Okay, and then maybe come to you for the first question as well, Catherine. Do you think that novel variant would fit with the clinical picture?
I think it's hard to be drawn. She's got signs that go along with Lamin, so her AV block and the progressive, aggressive heart muscle disease that then led on to the formation of a thrombus. So, but you've all been saying as well that it's an unusual, I don't think it's a typical picture. So I think I wouldn't be drawn and say it definitely is, but I think we should treat her with a high index of suspicion that this is an aggressive arrhythmogenic type cardiomyopathy in the light of the Lamin finding and the clinical findings.
Yeah, and what do you think, Jan? I mean, the initial airway dysfunction was with tachycardia as well, wasn't it?
It's extremely unusual for that to get incessant AVNRT in that way and to present in that way. So that would immediately say to me something's going on here. This is an incredibly unusual presentation, isn't it? I've not seen much Lamin. I've got 2 young cases who presented with overwhelming Lamin, and they both had ECGs which were really low voltage and looked a bit like that. So for me, that would sell it to me, I think. This is, I think, Lamin.
That's interesting, because I don't think that's described, is it? And we don't see that so much in adults. Yeah, no, fascinating. Else, what do you think?
I mean, I think it could be. I think it could be consistent with Lamin, but equally, I would keep an open mind too. She clearly has a very aggressive condition that then improved. Is there something else going on? Is there any inflammatory element that may, again, have triggered a deterioration as well as the AVNRT? But it's pretty unusual.
So just regarding the inflammatory component, I didn't mention on the original CMR done close to the presentation, there was some high T2 signal in the area of the infarction, but globally not otherwise compatible with myocarditis.
Okay, that's helpful to know.
Yeah.
Again, you can get that if you've got an acute clot with the inflammatory response to that.
With that first presentation, the very first time she came to hospital, it was a sort of myocarditis-like presentation with chest pain and palpitations and troponin rise. So that's interesting.
Yeah. So she did have a small troponin leak at that point, and she DNA'd the CMR that was arranged as an early outpatient. So, yes, not.
I think her ejection fraction wasn't quite right either, was it?
Yeah, a non-sustained VT early is a bit abnormal for Lamin, isn't it? Because that was one of the first things. Okay, so let's ask the audience. Do you want to put your hand up if you'd put in a... Oh, no, Lima's going to come in.
Sorry, if you're focusing on the cardiac phenotype and asking whether this Lamin variant is related, what about the neuromuscular phenotype? Was there anything in the station that was not explored?
Well, if it was a cardiologist, they would have just said, squeeze my fingers, normally what we do, isn't it? That's about it. That's a good question.
So thanks for the question. To my knowledge, there's no other systemic involvement in this patient. Yeah.
And I
That's
guess
a good point, Lima.
CK is going to be up with everything anyway, isn't it? But yeah. Okay, so over to the audience. So put your hand up if you'd put an ICD in this patient. Oh, there's one at the back.
I'd be nervous.
2. Peer pressure's coming. 3.
Yeah.
Yeah. Let's see what the panel would do then. There's not a right or wrong, is there? So else, what would you do?
Yeah, I think it's difficult, isn't it? Because you've got to balance her potential sudden death risk versus the risk of the device, particularly at her young age. I don't think there is a right or wrong. I'd be very nervous and somewhat reluctant. So if she didn't have a device, I'd be wanting to put a loop in. I think this certainly in our MDT would raise a lot of debate. I think for me, I would probably err on the side of caution and implant an ICD. But I think that's my own perspective on risk prevention, albeit given her age.
Okay, and Catherine, what would you do?
I think there's something here about, and I don't have these conversations with patients, but about
talking to the patient about the uncertainty and the pros and cons of an ICD and trying to make that joint decision as far as possible, because we're all expressing some uncertainty. I think if the panel, or, you know, if we felt very clearly this was a lamin fit, even though it was a VUS, I think that would swing me a little bit. Yeah, I think it's a tricky one.
Yeah. And Steve, what about measuring an HV interval and with that PR interval? And if that's very prolonged, you might want to pace, and then you'd put a device in.
Yes, I mean, that would be an option. I like to know what the diagnosis is before. Trying to make decisions about treatment and device implantation when you don't understand the pathology, I think, is really difficult. If you take the lamin VUS out of the question, she developed a tachycardiomyopathy, didn't she? And whether it was just rhythm related, which is probably unlikely, or whether she had inflammation or myocarditis at the same time, difficult to tell. It could fit with giant cell myocarditis, couldn't it? This presentation, or was did they do a biopsy?
She didn't have a biopsy at the time.
Yeah, in giant cell, unless you treat it, doesn't get better, I don't think.
But she went on ECMO, would that not?
I still think in giant cell you have to immunosuppress them, probably.
Okay.
Absolutely, the rapid deterioration would go with giant cell, but I think the recovery perhaps wouldn't.
From memory, I think the troponin levels on the presentation were not sky high.
Sure. So her LV function has nearly normalised. So you haven't got an ongoing ventricular dysfunction to sort of trigger a device implant, and you're left with some atrial ectopics, AVNRT, which has been treated, and a long PR interval, and some ventricular ectopics, which isn't generally that doesn't reach any real criteria for ICD implantation. So what you're relying on is gut instinct, and whether we factor in this lamin VUS.
Did she have a calculated risk from the ARVC or arrhythmogenic cardiomyopathy risk calculator?
It was a lamin, wasn't there?
Yeah, she did. It was 20%. So I'll show you that on the next slide. So, yeah, so 19.9% 5-year risk of VTA was calculated, and that takes into account the variant, the fact she'd had non-sustained VT, which increased that significantly. So that was part of our decision as well.
But of course, then you can decide to not use the lamin variant for predictive testing. That's sort of an easy decision, yes, isn't it? But this has not been validated in VUSs.
Yeah.
And everybody has a high risk on the lamin risk calculator. Every time I do it, they're all at high risk. So that's the nub of it, isn't it? Yeah. We as cardiologists, we have to come off the fence and call the variant as to whether we include it or we don't. Predictive testing, that's a separate issue, but we have to decide, because if it is lamin, she gets a defib, and if it's not, I think you're on.
I think it's that
much less confidence.
That ECG that makes me think I would be persuaded that lamin is the low voltage. It looks very odd, that ECG, even for what this girl has been through. That is not normal. So you would be highly suspicious that lamin was relevant.
And the first degree AV block. And
first
then
degree AV
septal
block.
waves.
Okay, some ectopics which you might get after what she's been through. But there's something about that ECG that doesn't reflect everything else. It looks. So I would be worried if I didn't put one in. But it's difficult.
So you'd put an ICD in, would you, Jan?
Well, I can say that I know it would be a difficult decision, wouldn't it, at the time. Going forwards is always difficult.
And presumably it would have to be transvenous because of her conduction disease? Yeah, which again changes the odds. Yeah, we got the answer in the audience.
It's interesting because I think you're holding two positions with the Lamin at the same time. If you're using it to decide that it makes her have a risk score to consider an ICD, then I think it's difficult to tell the relatives we're not going to also look at you and use it as an important variant. I think it's difficult to hold those two positions at the same time, because if I was a relative, I'd want to know, well, if you think it's important enough to implant a defibrillator in someone, I'd like to have my phenotype and genotype assessed, maybe not as a predictive test, but as to gather information and correlate it. But I think it's difficult to hold the two positions at the same time.
I completely agree. The phenotype should absolutely be done in that half-brother and the mother, and that would put them in a very different situation than the girl herself. So I think it is different once you phenotype them, assuming they're normal.
Great, we've got a few questions on the table on the left.
And would you have been comfortable with that instead of putting an ICD in?
I mean, the problem with loops is you can just document sudden death beautifully at times, can't you? But, yeah.
Sorry, I was just interested to know, actually, when she'd presented a few years previously, did she have any conduction abnormalities on her ECG or anything suggestive of the DCM when she presented with the trop of 40? What was her ECG like?
So we didn't have that. We didn't have the original ECGs from the first two presentations prior to that, but it was not documented in the medical notes that we retrieved in terms of the conduction disease in the original ECGs. So we're not sure.
Okay. Do you have any more slides?
No.
No.
So I can update on what happened to the patient if that's helpful.
Yes, that would be great.
So after much discussion in the local MDT, the consensus was that there were features of the phenotype in the presentation that could be consistent with Lamin-related dilated cardiomyopathy, and on that basis to treat this as though it is Lamin-related dilated cardiomyopathy, and with the risk score calculation of 19.9, she was offered an ICD, which she accepted. That was implanted 6 months ago. She's had no high voltage therapy since. She remains very well. She's back studying law, no symptoms, and it continues to do very well. We've not recommended predictive testing in the family. That's the update with her.
Great, but you're going to do phenotypic screening in the family. Yeah. Brilliant. Well, wonderful case. Thank you very much. Beautifully presented as well. Okay, so just going to finish with a few thank yous, if that's okay. So just going to, a massive thank you to Rachel. I mean, people have no idea how much work goes into this. So I think I've only seen 10% of the emails, and that's sort of broken my inbox. So you've done a fantastic job. You've got fantastic speakers together. I don't know how you've done it. So a big thank you to Rachel. Elsa's been brilliant supporting Rachel, so thank you to you. I don't think Valerie's in the room, but she, as always, she's been a great help to all of us. Do you want to come and say a few words and maybe something about tomorrow, Rachel?
So big thank you from me to all of you for coming. We've had a wonderful day. A huge thank you to our chairs and our speakers for amazing sessions. I've really, really enjoyed the sessions that I've attended. I wish I could have been in 2 places at once all day. But thank you all very much. Just to echo Els, remember to come to the Cavendish tomorrow. Don't come back here. We have feedback questionnaires that we would be very, very, very grateful if you would complete. And yes, there are QR codes on the documents in the centre of your tables. So please, 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 we'd love to hear how you found today to help us in subsequent years. And last but not least, there are drinks just outside of here, which hopefully are set up now. So I hope that you'll be able to join us for a drink straight after this session now. Thanks very much, everyone.